Right. What a crowd. Good morning, everyone. We're going to go ahead and get started. So for those of you who are here, our agenda this morning, we first do have a confirmation hearing that we're going to do after introducing committee members. We're then going to hear from the Department of Health and Human Services, Maine Health and Northern Light, and get some briefing on the issue of labor and delivery units across the state. We'll break briefly for lunch and then come back and take public comment. So that is the anticipated order of events this morning. Before we get started, I would love to have committee members introduce themselves. You all look wonderful and rested. It looks like you're all having a great summer, and I appreciate you coming in on this beautiful August day. We'll start with Representative Mastracchio.
Good morning. I'm Anne Marie Mastracchio. I represent House District 142, which is part of the city of Sanford and the village of Springville.
Good morning, everybody, and good seeing you all. I'm Paul Flynn. I represent House District 63, which is Winslow, Albion, Freedom, and Unity Plantation.
Good morning. I am Rolf Olson, District 86, which is Raymond, Casco, Fire Island, and a bit of Poland.
Good morning. My name is Bob Foley. I represent House District 145, which is most of the town of Wells.
Good morning. I'm Representative Michelle Boyer. I represent House District 123, which is most of Cape Elizabeth.
Good morning. I'm Sally Clucci. I represent House District 52, which includes the communities of Bowdoin, Bowdenham, and Richmond.
Good morning, everybody. My name is Christy Matheson. I represent Kittery District 151, and I serve as the House co-chair.
And I am Senator Donna Bailey. I represent District 31, which is Buxton, Old Orchard Beach, and Saco, and I serve as the Senate co-chair. Welcome, everyone. So getting started here, this is a public hearing of the Joint Standing Committee of Health Coverage, Insurance, and Financial Services for the purpose of considering the nomination by the Speaker of the House of Dr. Patrick Connolly of Falmouth for appointment to the Advisory Council on Affordable Health Care. Under the law and the joint rules, this committee is required to hold this public hearing and to recommend confirmation or denial of the nominee by majority vote of committee members present and voting. As chairs of the committee, we will then send written notice of the committee's recommendations to the President of the Senate. The committee will hear testimony from and have an opportunity to question the speaker or his representative, the nominee, and any other persons present who wish to speak for or against the nomination. Persons testifying at the public hearing today are advised that the hearing is live streamed and may be seen and heard by persons watching online, and that a recording of the meeting will be archived. Pursuant to Title III, Section 157 of the Maine statutes, which requires that there be an affirmative motion to recommend confirmation of the nominee, I now recognize Representative Boyer for the purpose of making such a motion.
I move that the Joint Standing Committee on Health Coverage, Insurance, and Financial Services recommends confirmation of Dr. Patrick Connolly of Falmouth for appointment to the Advisory Council on Affordable Health Care.
Thank you. And a second?
Seconded.
Seconded by Representative Matheson. A copy of the statutory requirements for this position is available at the rostrum. I now recognize Anina Breen for the purpose of making a statement concerning this nomination from the Speaker's office. Oh, there she is. Yeah, it's in the front. Great, thank you.
Good morning, Senator Bailey, Representative Matheson, and esteemed members of the Health Coverage, Insurance, and Financial Services Committee. My name is Anina Breen, and I am a policy advisor in the Speaker's office. On behalf of Speaker Fecteau, I am pleased to introduce Dr. Patrick Connolly for appointment to the Advisory Council on Affordable Health Care to serve as a representative of the healthcare workforce. Dr. Connolly serves as a staff physician at Martins Point Healthcare in Portland, where he has worked for over 3 decades, and as an attending physician at Maine Medical Center. He also sees patients as a volunteer physician at the Portland Community Free Clinic. Dr. Connolly is a member of the American and Maine Academies of Family Physicians and the Maine Medical Association Advocacy Committee, where he serves as a committee co-chair and workforce representative. He has further demonstrated his commitment to the medical workforce by helping to shape future physicians through his roles as a clinical assistant professor of family medicine for the University of Vermont and Tufts University. Dr. Connolly's depth of experience as a physician within Maine's medical system, his commitment to strengthening Maine's healthcare workforce, and his dedication to the medical field and to the Maine community will be valuable assets to the advisory committee. And I'll do my best to answer any questions, but this isn't my normal policy portfolio. I'm filling in for Hannah Doolittle in our office.
Okay, thank you. Any questions from committee members? Seeing none, thank you very much.
Thank you.
I would now recognize Dr. Patrick Connolly for the purpose of making a statement concerning his nomination. Please come forward.
Good morning. I'm very pleased and honored to be nominated to this position. I have worked as a primary care doctor, for my entire career, in Portland, and have a lot of insight into how the system works and how it doesn't work. I'm especially interested in the role that primary care can play in, providing both better care and lower cost care to our citizens. I have a couple of recent studies that came up in the family practice literature supporting that the role that primary care can play both in reducing hospitalizations and hence cost and the longevity. There's a significant relationship between the longevity that a patient has with a primary care provider and their ability to keep them out of the hospital, avoid unnecessary emergency room visits. I have, been honored to have worked in the same practice for over 30 years. So I know my patients. Is the workforce that I represent is in serious stress because of a number of things, including poor reimbursement, unnecessary, administrative demands, and our goal, and as a role as a professor of family medicine at Tufts, I teach the next generation. I want them to be family doctors. I want them to have a workplace environment that is good, that is desirable, that they want to take care of their patients for the next 20, 30 years, like I have.
All right, thank you very much. Questions from committee members? Representative.
I've been called a doctor.
Yeah, I had that in my head.
Doctor, thank you very, very much. One of your first comments was controlling costs. What are the 1, 2, 3 things you see as primarily in reducing costs?
So first off, I think getting everyone into the system. There's nothing worse than somebody who doesn't have healthcare insurance, who's going to wait until the very last minute, to come in to seek care. They seek care late. They cost more. They have worse outcomes. Unfortunately, I had a daughter who suffered this. She was just a year ago. I was going through some medical problems, and was having all kinds of stomach problems, this, that, and she worked as a bartender, and did not have health insurance, so she didn't go to the doctor. And then it got to the point where it was unbearable, the pain. She went to the emergency room. She had stage 4 cancer. So not that going to the doctor that much sooner would have made her, would have cured that problem. But it would have reduced her suffering. So the more people we get into the system, the greater we have the ability to share, spread the cost out. But again, getting people into the system sooner is one of the keys. Second, we have a system that really focuses on the high tech, the high cost, procedures, the whole system of reimbursement for, for healthcare really focuses on that, emphasizes that. It does not emphasize the simple kind of grinded out, primary care that I do, for instance. So that's, that needs to be changed. That balance needs to be changed. And then what's my third? On top of that, I'll give you an example. There was, as you know, the Medicaid cuts with the One Big Beautiful Bill Act from last year has, presented us with a pretending catastrophe with loss of Medicaid coverage. And that's going to obviously affect your decisions and so forth going forward. I just heard a piece on NPR just last week about how the 50 billion for putting up to the rural hospitals to help offset that 50 billion versus $1 trillion. The math doesn't add up, but that one hospital in rural Iowa was going to use their money to buy a PET scanner. Okay. A PET scanner is a good thing, but it's not what our people need in the rural settings. They need better primary care. They need reliable maternity care. Those things that are not our system does not emphasize, does not prioritize based upon how we pay. Third, the system of healthcare insurance really works to often deny care when it's needed. Whether it's prior authorizations or denials, these are systems that just put undue burden, on the primary care system, causes an unfunded mandate to primary care doctors to have to fill out endless forms just to get a drug covered that they've been getting covered for the last 20 years. I think that's 3.
Further questions? Representative Cucci.
Thank you,
My
Madam
brain
Chair.
is
I hope it's
not
okay.
in committee mode.
I have 2 questions as it relates to primary care and affordability, if that's okay. Okay. So the first one is, you talk about the importance of primary care and focusing on primary care and trying to encourage people to become family doctors. One of the things I heard at a meeting I attended earlier this summer with Maine Health, with the chief medical officer of Maine Health, was that the goal is to use advanced practice practitioners plus AI to have one physician overseeing a panel of 5,000 patients. And I'm curious, like, is that something that you think we can work with, or is that going to drive family practice physicians out of the system that's attainable, that covers insurance, into this sort of concierge direct primary care programs?
If they could afford it.
If they can afford it.
Yep. So I've not heard of that plan specifically. The idea of me having a personal relationship with 5,000 patients is extraordinary. I just can't fathom that. I think the idea of team-based care certainly makes sense. Okay, that having a provider like myself working along with an NP or PA to provide healthcare certainly makes sense, and AI will certainly hopefully make our jobs easier. Having said that, there is no substitute for that good, personal one-on-one relationship that you have with your family doctor. Further, one problem that we're seeing with NPs and PAs is that a lot of them are moving on to work in specialty practices. Why? Because they get paid more, because of the reimbursement system. So it's a hard challenge to keep NPs and PAs doing primary care.
Did you have another question?
Me too. Okay. And then the other question, you're focused on primary care and solving problems before they come up. One of the things I've heard both from a constituent and I think the speaker experienced this earlier this summer, is that when they went in for a wellness visit, which is preventative care, right? Your annual wellness care, that they were limited to talk about 2 issues and no more than that. And in one case, my constituent, they went in for their well check for their son. He had a wart on his arm, so they asked about the wart. The provider said, get some over-the-counter treatment. they got a bill for $200 because they asked about the wart. And so have you heard of this? And do you have a sense of where this is coming from? Is this coming from the need to like bill as much as we can, or is it from time pressures, or is it the insurance company saying we're only going to pay for 2 issues to be discussed? So I'm curious, how do we think about that?
So part of this is a hangover effect from the ACA, meaning one of the provisions of the ACA bill law is that health maintenance visits, physicals, preventive health care is covered at 100%. Okay, to at no cost to to the patient. So if you come in and say, okay, how you doing? Hey, we're going to do your check your cholesterol and your mammogram and your et cetera. That's at no cost to the person, to the patient. If you're doing things over and above what you would ordinarily do in a physical, that is technically allowed to be billed, for a visit. So the way I approach this is if I'm doing something that, as part of their physical that is significantly different and over and above and could constitute its own visit, I'm going to do that. Okay. Now the offshoot of that is upshot is that that we have the ability to bill the insurance for that, which then comes at the usual copay and deductible rate. Okay, which can vary tremendously depending on insurance plans. So primary care doctors should be able to do all the things that they should be able to do in the time allowed, but they ought to be able to be paid for it. So in that case, that seems kind of stupid. Looking at a wart telling to take some OTC wart remover and the bill for being told. Having said that, if that person had frozen the wart, that comes off as a destruction code, as a CPT for that, and that could be part of the physical. So again, I will often, when appropriate, bill, for the physical and bill for, the significant problem that they come in for. Patients should be able to have their problems taken care of in one place, not get, shopped around or told, oh, come back next week. So, and there is time constraint issues. We only have so many, minutes in an hour, hours in a day, so many patients that we can see. But, there is a way to do that, effectively and fairly.
Further questions? Representative Foley.
Thank you, Madam Chair. Thank you very much, Doctor, for being here. I've had the pleasure of serving on this committee for 8 years. And one of the things that I have found with the healthcare system is that we've built up silos. We have the silos of the physicians, the silos of the hospitals, silos of the insurance companies, the silos of the legislature. And none of us are melding that together. How do we break down these silos to get to the root cause of the problem? We're all a part of the problem, and we all have to be part of the solution. But if we're just pointing this way and that way, which is what's happening today and in the past, we're not accomplishing anything. So how do we do that and make some meaningful changes to a system that, as everybody would say, is broken?
Well, it's one of the reasons why I'm here. I think I can bring my perspective to to the healthcare debate to say here's what works and doesn't work from our perspective. You're right. It's a whole bunch of different silos that are competing against each other, and it's almost like a zero-sum game. It's like, and it does not need to be. Right. I mean, this is a $5 trillion industry. Okay. And we're out here, and you're going to be talking about things where people are just starving for resources. We need to, have that frank conversation about what works and what doesn't work in healthcare and do it effectively and cost efficiently. But again, it has, you need to have those conversations. Looking forward to having those conversations as part of the healthcare advisory report. It is, I came out of one of the things I grew up with in my professional careers, working at Martins Point, we were working with a military HMO that would look at cost. How do we manage things effectively and efficiently? For these retired military families, and that would involve having those conversations across the disciplines, both in the medical specialties, with our specialist colleagues, and with the hospitals and with our administrative team. So it's not easy, but you need to have those conversations to make that work better.
Thank you.
Further questions, Representative Olson.
Thank you. Thank you for being here today. You touched a little bit on it, but looking for a little bit more in depth. And you may not be able to do it right now and whatnot, but what do we do to attract more into the rural areas and do better coverage and get people to actually service people up in the northern part of the state and things like that? Because, if you're overloaded with PCPs, which we're not anyway, down south, but we're really underloaded, so a very critical area up there. How do we look at increasing that exposure?
So probably at least 3 things come to mind. One is get people to train closer to where they want to practice. Okay. So if you do your training in Boston, you're not going to want to go to Fort Kent. One of my favorite students from Tufts, a guy named Caleb Swanberg, he's from, oh gosh, I'm spacing on the name. What's that? He's from where?
Caribou.
Caribou, yes, Caribou. So yeah, thank you. It's a small town. So I wanted to say Fort Kent, I knew it was wrong. So he trained in my office down in Portland. He really wanted to go back to Caribou to practice. I actually told him as a student, do not, train in a big center. Go to a more rural place to get your training, so you'd be more fit, closely approximated to practicing in Caribou, which is where he is now, and very proud to say. Second is if you're going to go practice somewhere where the reimbursement's low and so forth, you need to help them. Okay. Loan repayment, both at the federal and state level is a benefit. I actually had this conversation in Senator Collins's office when Caleb was a student about student loan programs. As you know, they were in the process, the One Big Beautiful Bill, cut back health profession, loan, loans, not just loan repayment, but having ability to pay your bills, to pay back the cost of your medical education, extremely helpful. Third is payment reform. Again, if the average primary care doctor earns half what the average specialist works, these kids aren't stupid. Right. So it takes a big leap of faith to say, I want to be a family doctor, a pediatrician, or general internist, when I could be, an ophthalmologist, and no diss against the ophthalmologist, but, they can make more doing a cataract than I can in half a day of seeing patients. And it's just the way we have the payment system set up. I was just at my college reunion in June, and I ran into one of my buddies who's an ophthalmologist. And I said, oh, I just retired. It's like, good for you. So, I could retire, but my patients won't let me. So, but in terms of, those would be 3 things I would start with.
Representative Mastracchio.
Thank you, Madam Chair. So why don't we just do this? Why don't we make medical school free, like other countries do? Because then you wouldn't have those loans, because in the end, the money is still being paid somewhere. I mean, you can say, let's pay those loans back. We're all paying those back. Personally, I would rather have people have to compete to get into medical school or nursing school or whatever, and those schools should be, those university professions that we need should be free. So why don't we do that? Why don't we advocate? And I would hope that you would advocate on this advisory council as what are the true costs? How can we really save money? And maybe your opinion, does the system need to be just blown up and started over? So I've been doing this a long time, and I've come to the conclusion that you can pull this thread and that thread. But I guess I want to know, are you going to tell the truth about what we really need to do or what legislators want to hear? And I hear you telling some truth here in a very nice way, but the truth is, This system is unsustainable the way it is. So are you going to tell us that?
I can tell you, how many of my colleagues are looking to leave the field, or more importantly, how few of the residents that I interact with, who are, in family medicine are actually going to go into primary care. A non-scientific, sampling of the graduating residents from the main medical program in Portland. Most were going into either sports medicine, addiction medicine, geriatrics, preventive health. Very few of them were actually going to be a rank and file family doctor. So it's a problem. Yeah, if I were king of the world, I'd blow it up. My understanding is that politics is the art of the possible. And so you need to work within those constructs.
I just want you to understand that I'm going to vote to confirm you today, but I hope that everybody that we're putting on these committees and then the future legislatures are willing to tell us the truth, because until we accept that truth, we're going to keep being back here, and eventually the system will just explode in and of itself, and none of us will have the health care that we need. So thank you.
Further questions? Representative Flynn.
Thank you. I guess we've been off here for a while because we're all full of questions. We've been holding it back. Early on, Doctor, you had made reference to poor reimbursement as part of the problem. Could you expand on that? And then, in your opinion, what's the fix to poor reimbursement?
So again, getting back to what primary care makes in relative to their specialty colleagues, it's very clear. It's about one half. You need to level the playing field between what primary care providers make and what specialty providers make. The amount of training, the differential in training they get is not adequate to sustain to justify, making $1 million versus $200,000. Again, so that's part, but so reimbursement reform needs to be part of that. The other piece we need to move away from the widget system, of reimbursement. Okay. We have, the more widgets I make, the more patients I see, the more biopsies I do, the more injections I do, the more money I make. We know that just, speeds up, the treadmill to increase cost and not necessarily provide better care. So the better the move to value-based care. Somebody I heard mention DPC at some point. The idea that you're going to pay your provider, or your provider is going to get reimbursed a significant amount to be your doctor, to answer that call, to deal with that, that complex computer, portal message, to give you the advice. Okay, which is over and above what you would do in the office, is I think another way to do that. It gets, people refer to, primary care as being on like the hamster wheel. You just got to keep going faster and faster. But it does not have to be that way. I mean, in some ways, I would like to be a DPC doctor. Having said that, I need to get rid of 1,500 of my 2,000 patients. Who's going to see those other 1,500 patients? So those are some of the things that would need to be done to give you better and more cost-effective care.
Further questions? Representative Chimino.
Thank you, Madam Chair. Thank you for being here. Do you think that perhaps if there weren't so many people that are able-bodied on our system, on main care, that the reimbursement rates would be better?
Meaning that they're on main care but able to work and would otherwise not be on main care? I'm trying to make sure I understand your question.
Correct. People that are on main care that really should not be qualifying for main care because they could go out and they could get a job, but they're not doing that. So they're on main care, and because of coverage, we're trying to spread our money over such a broad amount of people that if we had people that really truly were on main care that needed it, that we would be able to reimburse at a higher rate and cover them the way we should be covering them.
So again, I think the system works best for my patients and myself, when they have healthcare coverage, regardless of, of who's providing it. The problem I see is I see plenty of people who are of work capable, who are working, who don't have health insurance. I'll give you an example. I think that Anina mentioned in my bio that I volunteer one night a month over at the Portland Community Free Clinic, which started actually the first year I started practice back in '93. And that was meant for people who don't have healthcare, who don't have healthcare insurance, who do not have, who don't qualify for main care or Medicare. And so they were, but these people were the working, they're working poor, they're the working class. I've been seeing people in that role for 30 years. The problem is healthcare insurance, especially for small employers, has gotten so, onerously expensive that a lot of places just don't offer healthcare insurance. So that's a challenge that I see. I'll give you an example. Week and a half ago, I was in South Portland. New restaurant was opening up. And they actually had a kind of soft opening, free buffet. It's like, cool, free food. Went in and so forth, and it was a lovely place. It's anyway. The next day, I'm in the free clinic, seeing one of their cooks. Why? Because they don't have health insurance. So I think the ability, if we can find a way to get people who are of working class, who are able to work, to get them affordable health insurance, whether it's outside of Medicare, that's great. But the problem is it's so unaffordable that our system just doesn't offer it at a rational, reasonable price.
Further questions? Seeing none, thank you very much.
Thank you.
Is there anyone else wishing to speak either in favor or against this nomination or on this nomination at all? Welcome.
Good morning, Senator Bailey and Representative Matheson and the committee. I am Dr. James Jarvis, the president of the Maine Medical Association and a family physician in Bangor. I think when you've heard Dr. Connolly speak, you can understand why the Maine Medical Association wholeheartedly supports his confirmation to this committee. He will be an outstanding representative in terms of what we see on a day-to-day basis with our patients, with our communities, and for the physicians of Maine. And so with that, we give our support. I'd be happy to answer any questions if you want. I've known Dr. Connolly for a very long time. This will be a very good thing for you to do.
Thank you. Questions from committee members?
Thank you.
Seeing none, thank you very much. Anyone else wishing to testify on this nomination? All right, all public comments having been taken, the committee will now proceed as follows. We will review any additional written comments on the nomination that have been received by the committee. And then we will vote on the nomination and notify the President of the Senate pursuant to Title III MRSA Section 157 and the joint rules. The vote must be taken within 35 days from the date of the speaker's written notice. The hearing by the Joint Standing Committee on Health Coverage, Insurance, and Financial Services for Dr. Patrick Connolly of Falmouth for appointment to the Advisory Council on Affordable Health Care is now closed. In accordance with the law, the committee may not take the vote on this nomination sooner than 15 minutes after the close of the public hearing unless all committee members who are present agree. At this time, therefore, I will inquire whether any member present objects to proceeding to take the vote immediately. Right, seeing no objection, the pending question before the committee is that the Joint Standing Committee on Health Coverage, Insurance, and Financial Services recommend to the Senate of the 132nd Maine Legislature that the nomination of Dr. Patrick Connolly of Falmouth for appointment to the Advisory Council on Affordable Health Care be confirmed. In accordance with 3 MRSA Chapter 6, Section 157, and the joint rules. The vote will be taken by the yeas and the nays. A vote of yes will be in favor of recommending confirmation. A vote of no will be against the motion to recommend confirmation. Is the committee ready for the question? Edna is ready. The committee clerk will now call the roll. Thank you, Edna.
Thank you. Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Alford.
Yes.
Representative Alford, yes. Representative Boyer.
Yes.
Representative Boyer, yes. Representative Shamino.
No.
Representative Shamino, no. Representative Clucci.
Yes.
Representative Clucci, yes. Representative Flynn.
Yes.
Representative Flynn, yes. Representative Foley.
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Olson.
Yes.
Representative Olson, yes. 9 members of the committee having voted in the affirmative and 1 in the negative.
Thank you. So 9 members of the committee having voted in the affirmative and 1 in the negative. It is the vote of the Joint Standing Committee on Health Coverage Insurance and Financial Services that the nomination of Dr. Patrick Conley of Falmouth for appointment to the Advisory Council on Affordable Health Care be confirmed. Congratulations and thank you. So we're now going to take a moment to rearrange the furniture a little bit and move on to the next agenda item. While they're doing that, just like to let people know that there are sign-up sheets for testifying this afternoon. I anticipate is when public comments will be given. So if you do want to sign up for that, I think they're on both ends of the committee room, right, Edna?
Yes.
Okay. So be sure to do that. Thank you.
Okay. I think Bill's gonna go first, but Bill, I'll go off the state for questions. However you want to.
Are we all set, Edna?
You want to just make us one of your things that. I think maybe a third chair, yeah.
I think we have DHHS going first.
Yeah.
Yeah.
It passes first. But we might need 3 chairs, yeah. I can fix that.
Is that working? Pauline says she knows the secret.
She's got the
Magic touch. Thank you, Colleen. So first, we're going to hear from the Department of Health and Human Services overview of state authority and DHHS programs to address maternal health services in the state. I think we're going to hear from Director Bill Montejo and Dr. Amy Belisle. Good morning, welcome.
Good morning, Senator Bailey, Representative Matheson, members of the committee. I'm Bill Montejo. I'm the Director of the Division of Licensing and Certification within DHHS. And I'll talk briefly about the authority regarding the department and specifically my office over OB closures in hospitals as requested. And then Dr. Belisle will talk with you about some of the work that's been going on separate from my office. So you should have a memo that I produced that was distributed this morning. I'm not going to read the memo verbatim, but I will kind of highlight a few things for you. It really, I went through and tried to articulate to you the authority of the department, and to kind of give you the Reader's Digest version is very little. But within the certificate of need unit, which lies within the department, we have the authority, and the department has the authority to approve new healthcare services, but there's no authority to review terminations or closures of health services. So there's nothing within the certificate of need that would apply to this situation. Under our licensing authority, which is granted to us under the statute under Title 22, and I reference specifically subsection 1813, which is the legislative authority that grants us the ability to issue licenses to hospitals and other medical facilities. And it references approval, but the approval is really contingent on the statutes and the rules. So if we are going to deny a license, we have to be able to articulate what part of the statute or the rule are you not in compliance with. Section 1817 of Title 22, which is on the top of page 2, references that the department is authorized to issue licenses for the operation of hospitals. And it kind of highlights for you towards the end of that, upon inspection of the department, when an institution upon inspection by the department is found to not meet all requirements of this chapter or to department rules, the department is authorized to issue either a temporary license or a conditional license. So again, the authority is limited to our ability to show evidence that the facility is non-compliant with rules or statute. Temporary licenses are only issued to new facilities. Rarely do we get a new hospital. When a hospital builds a replacement or another facility, or a hospital changes ownership, that's not a new hospital situation. We do have a new hospital that is in the works, and that's a rehab hospital in the Bangor area. That will be the first new hospital in Maine, at least since I've been here, which was 2008. I cannot recall a new hospital. Conditional licenses are issued with a condition that the provider must meet. And usually it's something associated again with the rule. We would issue a license conditional on successful CMS certification or obtaining compliance with full CMS certification. If the time of the license renewal is coming up and a provider is out of compliance, that would be a condition we could put impose that would tie the license to the certification, for example. Again, we can only impose conditions that are based on statute or rule that we have authority over. There is a section of the statute 1822 that's been there for many years that references notice of voluntary closure of a hospital or medical facilities. You'll note it limits that to 30 days, and we've had discussions in the legislature before about this. It in my opinion, is nowhere near adequate enough. And that's, I think, that combined with a policy that we put out in 2022 kind of led to the enactment of Title 22, Section 1822B, which was LD 2189 in the last legislative session that this committee heard. That bill was not a department bill, but that was generated based off the policy that the department issued in 2022, because we were seeing occurrences then of temporary closures as well as some permanent closures. And the temporary closures we were seeing were really in a lot of the rural facilities where they had very limited providers. And for various reasons, there would not be an OB provider for a period of weeks. And so the hospital would notify us, and we implemented this policy to kind of give guidance to the notification requirement, also making sure that the hospitals were communicating with EMS and with other hospitals so that everybody was on the same page. It was a policy. There was no authority to enforce the policy within. And then, as you recall, LD 2189 came before you. I would just take a quick note to point to you that in 2023, the 131st session, in the first regular session, the department did put in a bill regarding notice. It was LD 1131. It was more broad. It encompassed a lot more than just OB and required the inclusion of a root cause analysis as to why. What are the factors that led up to a closure and those sorts of things. That was voted out as ought not to pass. Just for reference. Section 1822 of the statute, notice of termination or change in maternity or newborn care. There's really two sections, and one is the termination, and the second part of this that you'll see on the top of page 3 is a change in the level of care. And that's just the provision right out of the statute that was passed regarding the notice. Again, the notice requirements require notice to the department and to the public, but there's no enforcement or no additional authority granted to the department regarding this. So we've had some questions about a bill passed, hospitals are required to notify you, why can't you take action? And there is no authority to take action. It is a notice. So the department has no ability to prevent or prohibit the closure of a facility or so. Bottom of page 3, you'll see where subsection 3 there, I reference our authority promulgated in rule. So the licensing rule for hospitals, I will readily acknowledge is woefully outdated, and we are in the process of working towards revising this rule and many others with limited resources that we have. But the key things that I want to just point out to you in the licensing rule is that under section 2.9.4, on our license that is issued to a hospital, which is a public document, we note the maximum number of beds. And these are inpatient beds. Hospitals license inpatient beds. So emergency department beds are not inpatient beds. We don't restrict the number of emergency department beds. Hospitals can delineate how they utilize those beds in any fashion form that they choose. So a hospital may have 600 beds, 150 in the intensive care unit, and may choose to convert 50 of those beds to psychiatric and decrease the ICU beds. That's not something we note on the license. Hospitals give us, as part of our license application process, they give us a breakdown of the number of beds and where they're allocated. But it's not a requirement that they have approval how they use those beds within their facility. You have a question, sir?
Representative Flynn.
And they can change that without any notification to you?
They cannot change the maximum number of
Right.
beds. When they change how they allocate them, we ask them to submit a new revised application that just gives us the breakdown of the beds.
Thanks, Bill.
And that's the information that when we frequently get asked questions of how many psychiatric beds are in hospitals, it is pulled from that application. And then the other thing the application identifies is the level of care within the hospitals. So it identifies various levels of care. So maternity care or OB care would be a level of care, for example. Under 2.11, hospitals cannot, they're changing licensing information, no change in license capacity, and that's the maximum capacity, can be implemented, and no new construction or additions without approval from the department. There is an exception to this within the CON allows hospitals to increase their beds by 10% a year without having to get a certificate of need. They would still notify us of that change. So if a hospital if they had 600 beds and they sent us a notice that they were adding 150 beds, we would respond back and say that exceeds 10%, you need to go through the CON process. But if they sent us a notice that we're adding 60 beds and we're going to break them down here, that's the application, a change of information. Does not require special approval. And then just the last page is just some brief information for you on when we look at enforcement actions and licensing, the primary enforcement action we use is, you've heard me call this a statement of deficiency, which identifies you're not compliant with a rule or regulation. And here's the evidence of the non-compliance, and the hospital gives us a plan of correction. We do have the authority to revoke a license, suspend a license, refuse to issue a license, All of those actions are appealable, but we do not have the authority to fine hospitals or impose financial penalties or sanctions. And as many of you are also aware, our office does the federal CMS certification work as a contractor with the Centers for Medicare and Medicaid Services. When we take action on a hospital with that hat, it is not the department taking the action. It is also not our final determination. It is CMS. So when there's action on a hospital for violation of a federal regulation, CMS reviews those. And then that final determination is CMS's. At times, we've been in this disagreement. We have found something that we thought was a violation that CMS said, no, it's not, and there, we would not proceed with citing it. We've also had situations where CMS has demanded that we impose a fine, a regulatory sanction, that we cite something as a violation of their rule or regulation that we disagree with, and the response we get from CMS is, that's nice, it's our policy, our regulation, you'll do it anyway. Because it is CMS is the one that has the authority, not the state. Very brief,
All right.
limited authority.
All right, thank you. Questions, Representative Mastracchio.
Thank you, Madam Chair. So just to clarify for myself, so you have no authority to force an entity to continue a service.
No.
Second question is, okay, I'm just trying to remember something about the trauma center at Central Maine Medical. That when a different group came in and was taking it over, that there's some contention about that service that they were going to not continue. So just, do you know what I'm talking about?
I do. And
Can you explain to me how that can, because that's where is that process? Because it seemed to me that somebody was telling them, you have to continue this service.
that is a condition of certificate of need. So when the commissioner is looking at their certificate of need and approval of the sale, the commissioner has the authority to put conditions on that. And so the commissioner imposed a condition that the trauma certification would remain as a condition of the new buyer taking over the facility. That was a request for reconsideration was sent because that certification expired during the approval process. And so the commissioner amended the condition, and instead of requiring them to maintain it, because you can't maintain something that's expired, a new condition was imposed that required them to reestablish it.
Thank you, Madam Chair. So it's only because they needed the certificate of need
Yep.
that condition could be put on there.
Correct. The condition was really to maintain the existing services that the
Right.
hospital had. So the commissioner imposed that condition. Now, when a condition is imposed as a part of certificate of need, the department and the commissioner is limited to a 3-year window to look at that. So after 3 years, the department no longer has authority to look
Right.
at, are they still in compliance with that condition?
So for 3 years, if this all goes through, they will have to keep that trauma center, but then after 3 years,
There's
there's
no-
no authority anymore.
Correct.
Thank you.
Further questions, Representative Boyer.
Thank you, Madam Chair. Thank you, Mr. Montayo. Can you refresh my memory? If they don't meet the conditions during the 3 years, what is the department's ability there?
That's outlined in statute. So within the certificate of need statute, there's a section or provision on enforcement. And off the top of my head, I think the options are a financial penalty. The commissioner could impose conditions through the licensing process, additional conditions as part of the licensing process. And I apologize, I don't know off the top of my head what the third condition is.
Further questions, Representative Olson.
Thank you, Madam Chair. So you referenced a couple times that you've got no enforcement authority under these on the closings and things like that. If you did, and what would, your options would be to say either, no, you can't close it. In which case, who then bears the liability if you have an understaffed and underserved area that something goes wrong?
I think one of the things you have to look at is if we had the authority, we'd have to look at establishing criteria. Because we can't be arbitrary and capricious, sir. And as far as any authority that we exercise is always appealable. But liability, I apologize, but I am not versed to really discuss liability.
Representative Foley.
Thank you, Madam Chair. Thank you very much. I'm just curious. I look at some of the licensing criteria, and it seems to me a hospital or medical facility, before they go through a process of expanding beds or whatever, they must go through a financial analysis of the needs and that sort of thing. And so I'm curious, if a hospital wants to increase its number of beds, it must know that the area that they're in needs those beds. So why do they need to go and ask permission to increase their beds when we have shortages of beds? We know psychiatric, I mean, the list goes on, the number of beds, and it just seems to me that this is a process that would slow down adding beds, adding facilities to an already needed system. It just, I can't imagine a hospital makes, or a medical facility makes these decisions arbitrarily. They just say, okay, let's make beds. I just can't see that as happening.
I would agree with you that they don't make the decision arbitrarily, but I would say to you that it is also not a rash decision. Hospitals spend a lot of time doing their own research and looking at the cost benefit analysis of what's the cost of adding these additional beds and staffing these additional beds versus the revenue that they would gain from that. The primary reason you'd have to go back to the purpose of the certificate of need is really looking at the impact to taxpayer and to the main care system. So for some of this, if a facility, and I don't want to digress from your focus here, but if the facility is looking to finance a large expansion and main care is going to cover the financial interest for that loan, you have to determine is that the best utilization of those main care funds to reimburse for the interest for this large loan to expand it, and how does that impact the system, and are there other avenues for financing this, or are there others? Is there sufficient need for this in the community that we're not going to finance something that 3 or 4 years down the road just gets closed because there's not enough need to utilize it and it doesn't pair out. So it's I apologize, Representative Foley, it's a more complex process.
Thank you.
Okay, further questions? So I have a question that I'm probably going to ask most people who come up here today. So I'm really focused on trying to find solutions going forward. And in particular, we're talking about labor and delivery units is the focus of our hearings today. So do you have any suggestions or recommendations from your perspective on what we could do as a state to stop these closures and to ensure that people across our state have access to labor and delivery within a reasonable distance from their home?
From my perspective, Senator, you're already starting that, and that's to engage in conversation and really identify what are the root causes of these. And I know Dr. Belisle is going to go over a lot of work that she has been doing and the department has been doing regarding this. But I think that's the key to, if you want to prevent future closures, you really have to identify why are they closing? What's the root cause? And it's not, I don't think it's a universal single root cause. It's a complex problem. So.
Thank you. Any further questions? Representative Chimino.
Thank you, Madam Chair, and thank you. Are licensing fees based on the number of beds that a hospital has?
Yes.
Okay, thank you.
Anything further? All right, Doctor, you're up.
Thank you. Good morning. My name is Amy Belisle. I'm a pediatrician and I am the Chief Child Health Officer at Maine DHHS since 2019. On behalf of the DHHS Commissioner, Sarah Gagne-Holmes, I want to thank you for inviting me to participate in this important conversation with the Committee on Health Coverage, Insurance, and Financial Services about how we can improve access to perinatal care throughout Maine, especially in rural areas, by strengthening the perinatal system of care. Since 2019, the Department of Health and Human Services has led the Perinatal Systems of Care Working Partners Group with partners in health systems, social services, and state agencies. The perinatal system of care is being defined as preconception 3 months prior to pregnancy to 1 year postpartum after delivering a baby, and includes the care of the baby from the birth to the first birthday. Over the last 7 years, we have done great work in the state to strengthen the perinatal systems of care, but we face challenges with birthing unit closures and ensuring geographic access to maternity services in the state of Maine. It is a complicated issue with no easy solutions. Closures are due to many factors, including the decreasing number of births and birth rate in the state over the last 65 years. In 1960, there were 24,000 births a year. In 2000, there were 13,500 births, and recently around 11,500 births in the state. This has led to hospitals having a lower volume of deliveries, and it takes a lot of human and financial resources, including a specialized workforce, to staff a maternity unit 24 hours a day, 7 days a week. Like maternity and newborn providers who can handle emergencies and perform a cesarean section, including OBGYNs, family medicine physicians, pediatricians, family practice physicians, anesthesiologists, nurses, and respiratory therapists, to ensure that the patients can be safely delivered. We need to work collectively across sectors, including medical, government, health insurers, education, community, and businesses, to come up with innovative solutions to ensure access to high-quality perinatal care and ensure the best possible outcomes for pregnant people, moms, and babies. It is very important that we prioritize the health of women and babies, and this is critical to supporting thriving families and ensuring the health of the next generation of Mainers. I would like to share with you now some of the work that's been happening at DHHS to strengthen the perinatal systems of care. I have put together a PowerPoint presentation. I'm not going to go through every detail of the PowerPoint, but I just wanted to make sure that you're aware of some of the work that's been happening since Governor Mills took office. First, we started this work back in 2019 because the state had one of the highest infant mortality rates in New England. We felt it was critical to really look at our perinatal systems of care and how we could develop a vision, goals, and strategies to improve our infant mortality rate, as well as decrease maternal morbidity mortality rates. So we have done foundational work that I will describe, as well as use data and evaluation to inform our work. And we've been trying at DHHS to align the work that's been happening across our partners, both at the state and federal level. We've also been instituting policies and programs to improve access and health outcomes. And I want to start with our shared vision and goals. It is really that we're achieving the best possible maternal health and birth outcomes in all areas of the state and across all populations. We want to make sure that we increase access to high quality services and that we're ensuring all mothers, pregnant people, and infants receive the right care at the right place for facility in the state, which is at Maine Medical Center. We worked on developing a level of care map, which you will see, which is frequently referenced. It shows both our birthing and non-birthing hospitals, as well as produced level of care guidance, which we did in coordination with our hospital health systems. And as Director Mateo noted, there was no policy at the state level when there was a change in level of care or a closure. So we worked with our partners as well as the state CDC to develop a policy around notification when there was a change in level of care. As Director Mateo noted, there was LD 2189 that was recently passed. We also convened work groups to look at our framework around levels of care, maternal and fetal transport data, and preterm risk assessment. I want to note for you that there have been several needs assessments and evaluations around the perinatal systems of care. There are many documents that you can look at and data collected. I have referenced for you some of the ones that have been funded out of our federal funding, but have been done in the state. If you would like to look at them, several of them focus on our perinatal systems of care. We have data around workforce and recommendations. So there have been many needs assessments done that can inform our work moving forward. There's also, at the state, there is funding on the federal side that funds our foundational programs to support perinatal health, especially the Department of Health and Human Services. At the Maine CDC, we have the Title V block grant. They also have a state maternal health innovation grant. We also have what's called McPhee funding that funds our home visiting programs. But there's many perinatal perinatal grants that have come into the state, and DHHS has been trying to coordinate them. Some sit within the Department of Health and Human Services, but some sit within our state partners, including Maine Health, which had a rural management and obstetrics management strategies grant, and our Maine Medical Association Center for Quality Improvement, which houses our perinatal quality for Maine Collaborative, which has had several federal grants to improve maternal and child health. We've also, as we've gone through this process, tried to institute policies and programs to improve access and perinatal health outcomes. You'll see the Children's Cabinet has incorporated into their strategic plan several strategies to strengthen the perinatal system of care in the state and improve our infrastructure, focused on access, workforce, and quality. The Children's Cabinet does produce an annual report, and the 2025 report details the work on the perinatal systems of care that has happened in the state, starting on page 17. There are also several policies and programs that have been instituted at DHHS and at MaineCare to improve access to perinatal health outcomes. You may have remembered in 2021, the state had a federal grant known as the Maine Mom Grant to improve care for pregnancies impacted by maternal opioid use. In 2022, MaineCare expanded coverage to 12 months postpartum from 6 weeks postpartum. Dental coverage was also expanded, which has improved care for pregnant people with dental issues. And MaineCare rate reform is enacted. In 2023, MaineCare coverage is expanded to youth under the age of 21 with incomes up to 300% of the federal poverty level. And the Maine Paid Family Medical Leave was passed in 2023, which has recently started paying out benefits in 2026. I will talk in a little bit more detail in this presentation about some of the work that MaineCare is doing under the Transforming Maternal Health Model, which is awarded in 2025. And in 2026, MaineCare with the state has been the recipient of Rural Health Transformation Program funding. I'd like to say to you, since we started this work back in 2019, when we had one of the highest infant mortality rates in the state, we are seeing some progress with all the work happening within the state, but also with our state partners. The last year that was reported in 2024, infant mortality rate reached its lowest point since 2002, and our rate at 4.5 deaths per 1,000 live births, with the high previously was 7 infant deaths per 1,000 live births. So we are making progress, but we know that there are still a lot of challenges ahead. The Transforming Maternal Health Model, as some of you may be aware, is a federally funded opportunity to improve maternal health care for women enrolled in Medicaid and the Children's Health Insurance Program, or CHIP. It's led by the Office of MaineCare Services, and DHHS is receiving $17 million in funding over 10 years to invest in infrastructure, quality improvement, and whole person care. This program is currently in the second year of a 3-year pre-implementation planning period. And you'll see in the next slides that there is a lot of work that's happening in the pre-planning period here. The TEMA model is based on a federal model that outlined 10 priorities for the states who've received the funding. And the Maine also selected 4 additional elements to work on in the state to improve rural health care. I will note one of the things that's happening currently under the TEMA grant.
Can I just interrupt you? There's
Yes.
a question. Representative Matheson.
Thank you,
Thank you.
Madam Chair. If you don't mind just going back to page 13.
Yes.
I'm curious, so there are some really great federally required items here. I'm curious how, if you could just at some point in time in your presentation, talk around number 1 and 3. Access to certified midwifery workforce and cover doula services. How is this program?
Happy to do that, and I have a few slides coming up that will address that. Great. Thank you. One of the things that you may have heard about is the TEMA perinatal rural regional planning groups that have been created and work that has begun this summer. This state has put out a request for applications for a lead group to take the lead in rural regional planning. We have done this by public health district, and you'll note on the slide the lead organizations who are doing regional planning. They've started developing regional inventories of perinatal services. They're identifying region-specific strengths, opportunities, and aspirations, as well as providing a mapping of regional continuity of maternity and perinatal care. This is a 2-year process. They have just begun the process and kicked this work off. But we're hoping that in the future, it's going to line up with the work under the Rural Health Transformation Program. So as just requested, in terms of the current transferring maternal health activities under increasing access to licensed birth centers, the state does not currently have licensed birth centers in the state, but there are several birth centers in the community. One of the first pieces of this work is working with Morgan Miller, who is a certified professional midwife who's working on the perinatal transitions program. It's a program to work with the midwives and the local hospitals, emergency medical services, and the community providers to train on how to work more effectively together if you need to transfer a patient to the hospital. So that's one of the first things that is happening in that area. I know the federal side is very interested in licensed birth centers, and that's something that we're going to have to work out over the next several years as to what that might look like. Under the TEMA model, doula services, the plan is to have them covered by MaineCare by 2028. There have been 2 doula consultants hired by MaineCare who are working on this with us, and the Maine Doula Council was created in 2025, and there's a rate determination process for doula services that is being advanced currently. There is also funding for for value-based payment model. Currently, there is work that will be starting on a value-based payment model or maternity services. MaineCare has to wait for additional guidance from CMS to really start that work, but they are working closely with the federally qualified health centers in the state to see which areas currently provide maternity services and who might be interested in expanding their services for maternity care. That will provide another access point for families in rural communities. In terms of the TEMA grant, there's also work around data infrastructure. They're working with the Health Information Exchange around data, as well as with our very good maternal child health epidemiologists at the University of Southern Maine on this project. We're also working on increasing access to home monitoring of gestational diabetes and hypertension. There were several projects that were done by Maine Health under the Rural Maternity Obstetrics Management Strategy around piloting home monitoring. And so we hope to continue that work, as well as increasing access to telehealth. One of the programs that TEMA is going to be funding is around virtual care for perinatal behavioral health. The Our Moms program did start a virtual telebehavioral health project around behavioral health. And as that funding has ended, the funding is being transitioned over to the TEMA grant. In this model, they have 2 social workers and then a psychiatric NP who are providing virtual telehealth to people who have been identified as needing additional services around perinatal behavioral health.
Representative Clucci.
Thank you, Madam Chair. On those 2 positions that are providing that behavioral health through telemedicine, is there any reimbursement component in that, or is those? Okay, can you help me understand how it's funded then versus like,
Yes.
and then the reimbursement piece?
Yes, so Maine Health has hired those positions, and originally it was through a company, but now I think they're hiring their own people, but they do bill MaineCare and the other insurers for the services that they are providing. But with the model, there is a difference in the amount that they can bill and take in through the insurance and the cost of the model to be staffed by these positions. And so the TEMA grant, well, Our Moms and now the TEMA grant is paying for that difference in cost.
Yep. Do you have a sense for like what it actually costs to like for those 2 positions versus what are the total amount of money that gets billed? And does it equal out, or is it more than what it actually costs to host to pay for those salaries and overhead and everything?
I don't have the exact numbers, so we can get back to you. But to do this type of program, you have to pay for those 3 positions to be available, regardless if they're actually seeing patients, so that we have it available all the time. And in fact, they're fully booked currently, but there is a difference in what they can get reimbursed for and to run that program. And that's the difference that the grants are paying for currently.
Okay, yeah, I'm just curious to understand, like, is it cheaper to just for the state to just pay for those positions and their overhead and all that kind of stuff versus, and then not have to worry about any billing versus actually having to like bill for all the particular services? If these people are just being hired to be on, 24-hour care for 1 year, what does that cost versus?
It's not 24-hour care.
Well,
partial-
but I'm
Yes.
just saying, like, just.
Yes, I understand what you're saying. I think one of the challenges, so when we're able to do pilots and get federal funding, we're able to launch these services and get them set up. This is a service that's being fully utilized. But from a sustainability model, you would like to have some billing and reimbursement. So when the federal funding or the grants go away, there is a model to pay for this service and continue it in the future. Yep.
So I understand that, but if the funding is always coming from like main care, then it's taxpayer dollars paying for it anyway. So what I'm trying to understand is like, is it just cheaper for the state to fund these positions to deliver this care and ignore the whole billing process, even going forward? Or do we need to stay with a system of billing for every little thing? Because then you're paying overhead for billing costs. And like Rep. Mistracchio had said, like, we need to think about things differently. So I'm just sort of curious, as we're really thinking about the state having to play more of a role in paying for propping up maternity care, is it cheaper to just pay for it and not worry about billing?
I'll go back to if I was the king of the world. I like where you're going. I can't comment on that at the moment, but I do understand where you're going with that. And I think that that's a good question as we move forward on these different programs to support maternity care. So, yes.
Representative Mastracchio. I mean, Matheson.
Right, I've been called words. I'm just curious and give me some structural background and conceptual. This is a pilot program that goes how long
10
and what
years.
is, and what is the funding for it?
So the TEMA grant, all these activities are done over a 10-year process. There's $17 million coming to the state. It's like an hourglass funding model. Some of the money comes in the first 3 years in a pre-planning. There is more money coming in the middle section of the grant, and then towards the end, there is less funding coming in as they hope to move to sustainability and they move into the evaluation of the program.
So this is part of that 10-year
Yes,
plan.
yes.
Thank you. Appreciate that.
Representative Foley.
Thank you, Madam Chair. Thank you very much for the information. I'm just curious, this FQHC's maternity services program, that seems to me to be a very valuable service that would solve a lot of the problems that we're facing because they are multifaceted, they're spread out. Why is it taking so long for us to resolve getting the CMS? I mean, 10 years is too long. Why can't we just find a way to put that process, get it up and running? I mean, you know, these FQHCs, they need revenue, they need support financially, and they're there and available to do these sort of things. It just seems to me, we've got a lot of studies and things going on here, but nothing is solving the problem. And this seems to me to be at least an initial way of solving this current problem with maternity care throughout the state. Can you just explain why
Yes.
it's taking so long?
I'll divide that box into two. They're actually two separate things, just for awareness. One is the Federally Qualified Health Center maternity services, and the second is the maternity services payment model. They're under that same bucket, but they're two different pieces. They've actually started this work. Maine Care is working with the Maine Primary Care Association. They have a learning collaborative they've been doing over the last year around maternity services. And there are several, I believe it's 4 FQHCs in the state that actually provide some maternity care. Some of them do all of it, but some of them are doing prenatal and postpartum care. So we are currently working on this with the Maine Primary Care Association and the Federally Qualified Health Centers. But as noted, you need to have people who are able to provide that service. So often they need to recruit family medicine providers who do obstetric care, and there are certain requirements about who can do that in terms of their training and number of deliveries. So it requires more people, services, but we have started that process. I think it's great. I mean, we feel like that's a very valuable program.
Thank you very much. That was another question I had. How much are we encouraging multidisciplined physicians that can handle multiple situations, including maternity care, where the hospital may not be able to provide enough for just maternity, but if you have a multidisciplined physician who can handle emergency room, or are we working towards trying to encourage the licensing of multifaceted physicians? Is that a feasible way of looking at our rural healthcare crisis that we're facing? Not just in maternity, but
Yes.
in a lot of things.
I'm smiling, my friend, Dr. Jarvis from Northern Light Eastern Maine Medical Center, because he has been pushing that idea in terms of encouraging more family medicine providers that can do obstetrics in their practices. They train to do obstetrics during residency programs, and then just going out into practice, making sure that they continue that practice, as well as there is funding under the Rural Health Transformation Program to fund 2 family medicine OB fellowships in the state that they are starting, one at Northern Light Eastern Maine Medical Center and one in Maine General. So yes, I think that where you're going is one of the conversations that we've been having, especially because family medicine providers can also provide newborn care. So I think that that is one of the things that we should be looking at the state.
Just one quick. Are there any barriers to the licensing of those sort of multidisciplinary physicians? Do we need to change the licensing criteria to make that happen quicker?
I think that's really a discussion that needs to happen with the Board of Medicine and the Board of Osteopathic Medicine, because we really can't articulate what their criteria is if there's any obstacles there.
I appreciate that. Thank you.
Yeah.
Representative Arford.
Thank you, Madam Chair. Do I need to introduce myself?
Up to you.
Okay. Well, I am Representative Arford, and I hail from State House District 101, the western part of Brunswick. And first of all, I would like to thank all our presenters for the information that they are providing today. This is clearly high-end data and follow-up on a number of different initiatives, and I personally appreciate it. So thank you for that. And my question about this particular piece of information is, could you give us, this is not going to be necessarily a report out on the data itself, but what I'm trying to figure out is how all this connects to the topic that we're hearing in our communities people are most concerned about at this moment, which is their access to community-based birthing centers. And so how does this data, which primarily concerns quality, or at least it definitely covers quality, and I want to really recognize the efforts that are being done to improve the quality of care, but how does that actually relate to people's access within their own communities to birthing centers in a place where they can give birth to their baby? And is there a correlation there, either between somehow that allowing for or supporting community-based birthing, or does it in any way demonstrate the quality of care discrepancies between community-based birthing and birthing that's done not in the community, where mothers have to travel a distance to give birth?
Just want to make sure I understand your question. When you're saying community birthing, are you talking about home births? Is that what you're asking?
No, I'm in a birthing center.
So at a
The
level
closing of
one
a
facility.
hospital-based birthing
Okay.
center.
Yep. As Director Monteo said, because we don't have the authority in that area, we have been working hard to make sure that we are reducing our infant morbidity and mortality rates, and that is what a lot of our efforts have been at the state level. There have been some papers that have been published, and Dr. Dora Mills has presented a nice policy brief at the Maine Policy Review recently that has a lot of information that I think will tie all these pieces together. Our focus has been really making sure that we have excellent outcomes for moms and babies, and that we're trying to build the foundation for the system in general, which was not really in place 6 years ago.
Just a quick follow-up. So am I correct in understanding that right now there's no data that speaks to whether or not having a hospital or a community-based birthing center improves the quality of care for the mothers who live within that community and choose to deliver their baby there? Is there any data that demonstrates how that quality of care compares? And I'm talking nuts to bolts from the pre-care and the post-care to mothers who are not able to do that. They have to travel a distance, at least for the birthing experience.
Yes. I would direct you again to the paper that Dr. Mills has done, because she's done some of that in her literature review. There is more national data that you could look at. In the state. We do not have that data looking at outcomes at this moment.
And again, thank you.
If that's what you're asking.
Well, yeah, thank
Yes.
you so much for
Yes.
being here with us today.
Yes, we do have some initial driving time data, but not actual patient outcome data at this point.
Obviously, that would be wonderful information to have in the future, but I think everybody really appreciates you being with us today. Thank you.
You still have a little bit more, Dr. Bush.
I just wanted to mention to you that the Maine CDC does have many initiatives to support perinatal care. A lot of these initiatives have been to improve infant health, reduce our safe sleep deaths, which is one of the factors around our infant mortality rate. They've been doing a lot of work to institute universal public health nursing and make that available to new families. We have our Maine Families Home Visiting Program, as well as our WIC and Maine Mom Program. They've done a lot of work around safe sleep, and they are currently doing a lot to support perinatal behavioral health. We also, in terms of the closure question, have two wonderful perinatal nurse outreach educators. There's a contract with the Maine CDC with both Maine Medical Center and Northern Light Eastern Maine Medical Center to provide education on perinatal emergencies. They have been doing a lot of work in the communities around training for basic life support and obstetrics, advanced life support and obstetrics. They've also produced several guides and documents for hospitals that no longer have a birthing unit. And when Director Montejo was talking about what happens when we get a notification from the hospitals, and we try to organize education and training and work with the hospitals to see how we can support them, support the unit that has been closed, as well as their emergency department and family medicine providers who might be in a position of needing to manage a maternal or newborn emergency. We also, in terms of data, we do have our data from our maternal fetal infant mortality review panel. There is a link to the 2025 report, which was just published on the state website. And we are working closely in terms of the quality with our Perinatal Quality Collaborative, which is at the Maine Medical Center for Quality Improvement. I do want to note with the Rural Health Transformation Program, there is some focus on perinatal health. This is the $190 million of funding that is coming into the state. And you'll note that there are 5 categories that DHHS has used to try to organize some of this work. Under population health, there is currently an assessment that is being done to assess where we could potentially do more work around mobile health options for perinatal care. The Maine CDC has done a pilot under one of their grants around providing maternal health units in the different districts. We are also working on strengthening workforce in the perinatal area. Per the question earlier, there is funding going to the Consortium for Healthcare Education and Training, which we call CHET. That is centered at Maine Health, but it's a partnership with the other health systems, including Northern Light, where they're funding 2 positions for an OB fellowship for family medicine physicians. They are also plan to continue funding our residents in OB and family medicine to go out to rural areas where they could do maternity training. We're also going to be expanding funding for our mobile simulation programs that provide training around OB and newborn emergencies. Under our sustainable rural health ecosystems, there will be rural regional health planning starting under RHTP. And the goal is to try to align that with the rural regional planning that's happening under our TEMA grant to make sure that we're all moving in the same direction with the rural regional planning. So that's an overview of the work that's happening. I know that there is more work that needs to be done, and we really look to partner with all of you as well as the different sectors, because this is a very challenging project around making sure that we maintain access to perinatal care in all geographic areas of the state. Thank you.
Representative Boyer.
Thank you, Madam Chair. Thank you for being here. I had a two questions, if it's okay, Madam Chair. Around workforce, what are the educational incentives in recruitment retention? Do you have do we have parameters for what those are yet?
I can get back to you a little bit more data on what that is going to be.
Okay.
I think the challenge for some of these is that under CMS, some of them will require a 5-year service commitment.
Mhm.
So there's been a lot of back and forth on that, but we can get you more information.
Yeah, I had heard the 5-year service commitment. I also thought I saw somewhere, and I've read a lot lately, that like FAME was getting 12.5 million. And I'm just really curious at what that looks like. I was surprised to learn that a typical OBGYN makes $400,000 a year. So I just like hope that that's being thought of when we're putting those like recruitment and retention ideas together. And then I had another question. In all of this planning, and work that's being done, which is amazing, is there any like planning about like, okay, this is our population, this is how many births we think we're going to have in the next 5 to 10 years, this is how many hospitals we think we need, this is how many birthing centers, this is how far we think is reasonable? Because like we talk about a reasonable distance, but if we don't have an agreed upon, I mean, I could think 30 minutes is reasonable. You could think an hour and a half is reasonable. Like, are we doing any sort of that like overview planning that gets us somewhere in 5 or 10 years, like that we know where we're driving towards?
So there has been some of that started in terms of trying to gather some of the data. So the Maine CDC has an epidemiologist who is called a CSTE fellow who has looked at some of the driving distance data to help inform some of this work. So we're starting to get that data. Our hope is that some of these conversations will happen under rural regional planning work under both the TMA grant as well as RHTP. But as you're saying, and what we know from a planning standpoint at the systems level is we're going to need not just DHHS, but all of the partners at the table, including our health systems, our insurers, the legislature, to really work on this together to move this forward.
Thank you.
Representative Clichy.
Thank you, Madam Chair. So one of the things that I struggle with grants is that there's always this push to try and make it self-sustainable at the end of a certain time period. But I think my understanding is that, operating labor and delivery doesn't make a lot of money for hospitals. Cancer makes a lot of money, like NICUs can make a lot of money. So I would hope that when we're thinking about planning, that we take into account the fact that like, these are not necessarily things that make money or can make money. And so I would like the recommendations to also be thinking about how do we just directly pay for these services in an ongoing way when, right, like if sometimes good work that doesn't make a lot of money, like we spend a lot of time funding grants to do that. And then the money runs out and it's like, well, why didn't you keep the grant? Because you can't make money doing something that's for good, but it's not profitable. So why is anybody going to do it? So we need to recognize the reality of like our sort of current financial system and build that into what are the real recommendations. It doesn't need to be that the state just needs to be paying $30 million for maternity care every year. Straight up, right? And I want that to be on the table as you're considering these things, because we have to be thinking about it very differently and not expecting people to pull money out of thin air when it's never going to be a profitable activity.
Representative Chimino.
Thank you, Madam Chair. Thank you. I'm looking at the 5 different programs here that you have that Maine Public Health Initiatives for perinatal systems of care. And I'm wondering if any of these programs actually encourage, promote, or incentivize people becoming pregnant. I look at these closures, a lot of it is due to because there's no demand for those services. There's not enough of it to keep these labor and delivery places open. And if we can actually encourage people to have families and have children, I think that would go a long way in keeping these birthing centers open. So any thoughts on that? Does Maine encourage pregnancy? Thank you.
I'm not sure the answer to that question.
Do any of those programs that you've listed here, is there anything within those 5 programs that actually encourage pregnancy, to your knowledge?
I think the programs are supporting healthy pregnancies and healthy babies. And that's what we're supporting, is the families to be as healthy as possible.
Okay, well, do you think maybe we should be putting programs forward that do support and encourage pregnancy within the state of Maine?
I think there needs to be a lot of pieces in place to be able to support families to have healthy pregnancies and healthy families.
Thank you.
Further questions? Representative Arford.
Thank you, Madam Chair. And again, thank you for being here today. And some of the comments have initiated a thought that I've had many times about the way in which we manage, well, the public thinks of our public education system. And I know for being a parent myself, the parents are well aware within their community of what the best schools are, what the best teachers are, even though the school itself will say, oh, everybody's equal, everybody's the same. But through word of mouth and reputation, that information gets disseminated. So along those lines, when we're talking about the infrastructure and the quality, because that's what we're talking about, right? The quality of care. I'm sharing a thought here. I have no idea if it's based in reality, but based on what you've just told us, that as we work, and I can see a significant effort, data-based effort to improve the quality of care delivered to pregnant women in the state of Maine. And as that occurs along the lines of what I just shared about education, I can imagine that the word of mouth in our communities is that, hey, this is a great place to deliver a baby. You know, I did it there, or my sister, and they got great care, and et cetera, et cetera. So I'm imagining that as we improve quality of care, we might also be improving a woman's desire to give birth in that community or even in our state. And I'm just wondering if you heard, I'm imagining that you or other people in the industry hear word of mouth reports in the surveys you do. And I guess my question would be, do you do surveys of the women who give birth in our various locations and where they're receiving this improved quality of care, commenting on that their experience was at some level? And as you review these surveys over time, they actually indicate from the patient's perspective that the quality of care is satisfactory, excellent, and or improving. If you do any surveys that indicate that, or you yourself personally have any information on that?
So DHHS does have some information in terms of there are surveys of people who deliver babies. CDC has data from the PRAMS data, which the Maine CDC works with the federal CDC to analyze. The data that you are referring to, I would defer to our hospital colleagues because I think that they collect more data on the patient side about their experience in hospitals than the state does. MaineCare does collect some data around patient experience, but the specific data that you're referring to, I think, would be more of a health system data collection base.
Final thought, if there is any such data publicly available at some point in the near future before the beginning of the 133rd legislature, I would love to see it.
We can locate what we have at DHHS, and I think you'd have to make that request to the other
Okay.
systems.
Thank you so much.
Representative Foley.
Thank you, Madam Chair. Thank you again for all your information. It's very helpful. Under the $190 million that we got from CDC or whoever gave it to us, how much of it has been spent? Do you know at this point in time? How much have we invested in?
I'm going to have to get back to you on that. Kristen McCauley is the director of that, and they are currently in that process with CMS around the spending.
I'm just curious if the money, I had an opportunity to spend some time at Maine Medical last fall, attending I was a doctor. And, you know, one of the things I heard from the interns that were there was the need for financial support. There's many programs out there that Well, there's Doctors for Maine Future Scholarships, there's tuition support. And each one of these had indicated that they would prefer to stay in Maine if they had the financial support or incentive to stay here in Maine. And I'm just wondering if there's any way that some of this money can go to support some of these programs already exist. They already do great things. They're just limited in the amount of money they have. And then building incentives for them to go to rural areas, to stay in rural areas, tax incentives, repayments of loans and scholarships. I think, those are some of the things that we could start to look at to maybe get more folks to stay in Maine. A lot of them say, well, because of my loan debt, I've got to go to Boston. I've got to go. And yet we have an opportunity, hopefully, maybe to build on these programs. So is that something that these monies can go to, do you know? Or if you don't, could you ask the person who's in
Yes.
charge of it if that's something?
We can get more detail for you. I think that builds on your question about the contract and the money going to FAME. So I don't just have all the details on that, but we can get that information for you.
Representative Boyer was with me as well.
Yes, yes.
Yeah, I mean, I think we have the bullet point that there are some plans in the rural health funds to be used on those issues. It's just, I think we're looking for a little more details on what
Yes,
that actually
We can
looks
provide
like.
that for you. Yep.
Yep. Further questions, Representative Matheson.
Could you just explain to me what you mean on bullet number 5, sustainable rural healthcare ecosystems supporting financial stability of rural providers, funding for the regional rural health planning? I don't really know what that means.
Yes. Yeah, I know. I'm just trying to provide a little bit more information. There will be rural regional planning. So
It's on the last page.
DHHS is partnering with the Office of Affordable Care, Healthcare, to organize and convene rural regional planning processes across Maine rural communities. It's going to be co-led by state and community leaders and include local healthcare providers, government representatives, public health leaders, social service entities, and community members. And the RHCP leadership with the Office of Rural Healthcare will provide a structured, data-driven process to help these groups identify essential health services to support their communities. There's been funding put into the application, and the work really is just at the beginning level at this moment. So we could get back to you about what the plan is, but that is really just in the planning process right now. Yep.
My chair actually pointed me to your creating regional partnerships in rural areas slide. So that's actually really helpful. I
Yes.
guess that's what we're referring to.
Okay, so
that
there's
bullet.
2 separate pieces. One is that there is work happening on parallel regional planning under the Transferring Maternal Health Grant under Maine Care. And now that the RHCP funds have come in, they are going to do another rural regional health ecosystems project. We're hoping to marry those 2 pieces together so that there is a strong focus on maternity care.
That would be good.
Yeah.
Yeah, I mean, it seems like they're doing the same thing.
Yes.
So why recreate the wheel?
Yes, but the RHCP work will be a bigger focus, but we are, we've already kicked off that process around the perinatal rural regional planning.
Further questions? So I'm just going to ask you my blanket question, which is, I mean, it sounds like you've got the frameworks for some really good work. But so with all of this, what more do we need in terms of either legislature or new rules, or the $1 million question is, if we're doing all this wonderful work, why do labor and delivery units keep closing, and what can we do to stop them? Do you have any recommendations?
Well, again, I'll go back to what I said at the very beginning. I think it's a complicated question. We've had a decreasing birth rate and number of births in the state over the last 60 years. So we have about half the number of births we have now than 1960. So lower numbers of births But the cost to keep maternity units are high because you have to be able to staff a unit to ensure that you have a healthy delivery and are prepared for emergencies. And so it's a complicated question. I think where we are hoping in the future as DHHS is to really work across the different sectors, working with you, insurers, with our educational system, our business partners, our schools, really with all the groups to make a plan. As you can see, DHHS has been doing a lot of work to improve maternal and infant health. We've really made an impact with all of our groups in reducing our infant mortality rate in the state, and we are seeing very good progress. But to get to that next level, which you are talking about, we are all going to need to work together on this issue. It's not something that's going to be centered at DHHS. It's really going to take the whole state to really address this moving forward.
Yeah. Representative Foley.
Good question. Thank you. I was just curious, has any study been done as to why the birthing rates have dropped so dramatically in the state of Maine over this period of time? I'm just curious if we looked into why.
I do not know the answer to that.
Just a good.
Yeah, I mean, I think it's across the country. It's not unique to
Yeah,
Maine.
but I mean, I care
Yes.
about Maine.
Right.
I don't care what's happening.
Further questions, Representative Cloutier.
Thank you, Madam Chair. Rep. Foley, just one of the reports that we got that Colleen had included was from public health researchers, a list of studies that have been done, and most of those actually do talk about the reasons why birth rates have declined. It's not necessarily the packet there, but there was a memo that had like links to I think there were like 25 or so studies that have been done. And there was a bunch on that. Yeah. Yep.
Further questions? All right, Representative Arfrey.
Thank you, Madam Chair. Very quick question with no commentary this time. How do, along the lines of global reports that report outside of the state of Maine, how do our birthing rates compare with other states? Or is this a common, my understanding is, at least in many other states, this is a common theme, that birthing rates in rural areas are declining. And I'm just wondering if you could comment on that.
I believe you are right. In many of the rural states, we are seeing that. I don't know how we compare to the other states right now. We can find that out and get back to you. I just don't know off the top of my head.
Fair enough. Further questions? All right, seeing none. Thank you very much, both of you, for all this great information and answering our questions and for being here. And we're next gonna have a panel from Maine Health. And are Maine Health and Northern Light coming up together or?
Oh, I think Maine Health first. And then
Okay, so just Maine Health first. Got Dr. Andy Muller, Cindy Wade, and Dr. Catherine Campbell. Whenever you're ready.
Okay, good. Senator Bailey, Representative Matheson, and all the members of the committee, thank you for convening the discussion today about a really important topic. My name is Andy Muller. I'm a family physician, like Dr. Connolly earlier. And I also have the privilege and pleasure of serving as the President and Chief Executive Officer of Maine Health. And earlier this year, when I began to hear from our leaders at Lincoln Hospital and our internal subject matter experts that there were great concerns about our ability to continue to reliably and safely deliver maternity care at Lincoln Hospital, my heart sank. And then I got sick to my stomach, knowing how difficult this would be on everyone. This is an incredibly gut-wrenching thing that we've had to do, to think about how we protect our patients and continue to deliver reliable and safe care. As a family physician, as a father of 3 daughters, I recognize that where people enter this earth is an incredibly important and emotional topic and differs in many ways from other aspects of healthcare services. And at the same time, while we care deeply about our communities, We also have to think carefully about the safety of the care we can provide. And that's ultimately what led us to this conclusion. Particularly after we've exhausted thinking about all the different various ways we could try to continue to sustain that service safely and reliably, which is what makes this so incredibly hard. And I really appreciate Representative Boyer's question earlier about how do we start to work together to think about this, because that's something we've been asking for. And we're going to need help from the state for that, to really convene us all to sit down and think about how do we ensure that we do have critical services across the entire state of Maine. And we think about that geographically, and we think about it independent of the individual health systems to begin the discussion, and then think about how we can all work together to ultimately ensure that we can sustain those services in a safe and reliable manner long term. And so we really welcome and support that idea. And as this committee knows, the challenges that are facing Lincoln Hospital are not unique to just Lincoln County. They're a challenge across all of our state and our rural communities, and thinking about how we long-term preserve that care. And we do think that we have an opportunity to look at all of that together in whole to really solve that problem. And I think it's important, when we first approached the state about this idea of trying to coalesce all the groups together, convene all the groups together, maternity wasn't the only area that we were thinking about. We have concerns about our ability to sustain trauma services, general surgery services. All of those things are going to be under pressure in the future for a variety of complex reasons that we have to work through together to understand. And while it might be tempting to try to solve the issue around maternity with specific policies or specific legislative action, I really do think this is a much bigger and broader conversation, and there are potentially some unintended consequences of trying to solve this piecemeal as we think about the broader challenges that we're going to face. And we recognize that really no state, no rural state has effectively solved this challenge around maternity care, and in some cases, some other services. But we have a lot of faith in the state of Maine and the people in the state of Maine, and think this is something that we really can model for other states moving forward, for sure. We know that there were a question about what other labor and delivery closures we've had within our Maine health system. And most recently, because of low birth volumes and difficulties around really continuing to sustain that service, we closed labor and delivery at Waldo County Hospital last year for a very similar reason. And while that was really hard at that time as well, I have to tell you, I was rounding at Pin Bay Hospital, the next closest facility. We combined those programs about 3 weeks ago, and ran into one of our pediatricians who was coming off of call the night before. He was tired and busy. And I asked him how things were going since we combined those two facilities, the programs at those two facilities. And his answer to me was, I have to tell you, last year, our labor volumes were down. We were down to 200, and we were all extremely anxious about the future of the program. Since we've combined the programs, we're on target to do 360 deliveries this year, and our run rate is for 400 deliveries next year. And we're now very excited about where things are at. And in fact, for the first time in several years, we've been able to do something we haven't done before, which is to recruit a new obstetrician gynecologist into the community. And they're planning to add an additional pediatrician. They felt much better about the care they were delivering and what that looks like. The other hospital in our system that stopped maternity care was Goodall Hospital in Sanford, when that went through a significant change from a full service hospital to a more focused hospital in 2014. Now focusing on emergency care in the community, as well as becoming an acute psychiatric hospital for that reason. So I'd like to introduce my colleagues with me, and would ask if we could give our testimony before answering questions, and we're happy to answer any of the group's questions. To my immediate right is Dr. Catherine Campbell. She's a maternal fetal medicine specialist. She's an obstetrician gynecologist with additional training in caring for high-risk pregnancies. She also serves as the chair of our Department of Obstetrics and Gynecology for our system. And then Cindy Wade, who's the president of Lincoln Hospital. I'd like to turn it over to Cindy.
Yeah, Andy. So thank you for the opportunity this morning to share with you what we've been doing and what's happening at Lincoln. So I wanted to also tell you, I have worked at Lincoln for 32 years. I grew up in a community other than when I was in the military. I had my last son at Lincoln. My granddaughter was born at Lincoln. And when I tell you that we desperately wanted to come up with a way to continue to provide labor and delivery locally, I mean that. At the outset, I do want to be clear that this was not a financial discussion and decision. This was truly about the difficulties of recruitment and retention of a clinical team that was necessary to provide the care that we feel is high quality and safe in our communities. And we've been able to do that. However, as Director Monteo referenced, looking at the root causes of this, which I think is very important for us, it truly was the ability to recruit and retain providers to provide this care. And it's been very challenging. And the reasons why we hear from providers, why they either didn't stay or didn't want to accept a position, was because of the low birth volumes and because of the high call burden, which I'll talk a little bit more about. And I know Dr. Campbell will as well. Understanding that root cause, as Director Monteo talked about, at Lincoln, the challenge of recruitment and retention necessary to support the labor and delivery service 24/7, 365 has had those two issues of low birth volume and call burden. For labor and delivery, you need a unique, highly trained team to provide that service and to do it very well. And you need that team that's ready to and prepared to deliver a normal vaginal delivery, prepared for a C-section, whether that's a routine C-section that's planned or an emergency C-section. And you also need to be prepared to provide care in an emergency, whether that's a maternal emergency or that's a fetal or a newborn emergency. Over the years at Lincoln, 32 years, we provided this care in various ways and various models. We have had midwives, we have had family medicine, OB trained providers. We've had family medicine OB providers who perform C-sections. In fact, that's how we're providing that service today, is by a combination of those types of providers, as well as you need OBGYN providers. And I know Dr. Campbell will talk more about that, who can do all of that care, plus be the backup when there's an emergency situation that needs to be handled. I will say, family practice OB providers who perform C-sections are also trained in some of those emergencies as well and do a great job. But you also need those OBGYN providers for other types of emergencies. And that's where we've had difficulty with the recruitment and retention. The rest of the team, you need nurses. There's standard of care out there that you need 2 nurses at every delivery. And in order to do that, you need to have a unit made up of nurses that provide part-time, full-time, and per diem care, and that's how we do that. You'll notice in your paperwork 16 nurses to do that because of that combination of different hours of care that those nurses provide. Those nurses need to be highly trained to provide labor and delivery care, maternal care, and newborn care. You also need an on-call pediatrician at all times in order, if there's a newborn emergency or a C-section that needs to happen. You need on-call anesthesia at all times. And you need a fully staffed operating room in order to be available to come in and do emergency C-sections and to handle other emergencies that might happen in a labor and delivery situation. So you need a highly trained team 24/7, 365 days a year. While each hospital that's closed labor and delivery has experienced different staffing challenges over the years, ours has been unique to that OBGYN part of the care. And we've tried to solve this in many different ways. We have looked to our recruitment team, and they have tried to recruit nationally. We've looked at and explored different models of care. We've looked at and we've used contract labor and per diem providers. And in fact, today, our OBGYNs are 100% per diem, which means they can pick and choose which shifts they want to do. We've been successful in trying to find people throughout our system that will cover care. But it's been at the diligence of a team trying to do that, to provide that 24/365 care. The consistent message that we hear from the folks that we're trying to recruit and retain, again, is low birth volumes. They cite low birth volumes, and they cite the high call burden. In fact, we've been trying to recruit a full-time OBGYN doctor since 2020. And again, have been providing part-time coverage over the last 5 or 6 years, as well as mostly and all completely in the last couple of years, per diem providers providing that care. The low birth volume, as I've mentioned, is part of the issue that we hear from those providers that we're trying to recruit. We had 132 deliveries in 2025. We had 131 the year before and 130 the year before that. And nationally, that is considered low birth volume, according to standards. Through our assessment, we looked at all of the data. We looked at the market. We looked at how many people are delivering, how many people are delivering in Lincoln County, how many deliveries are coming from outside of Lincoln County. One of the statistics that stood out was out of Lincoln County pregnant women, about 32% of those women consistently over the last 5 years are coming to Lincoln to deliver. So that means the rest of that percentage, 68%, are going somewhere else to deliver their babies. Providers want to deliver babies. OBGYN providers, midwives, family practice OB doctors want to deliver babies. They want regular exposure to deliveries and enough volume to maintain their skills and have a meaningful obstetric practice. With Lincoln's volumes, it's been very difficult to recruit physicians to that. Dr. Campbell will talk more about this, but it's worth noting that we are in a time of transition in medicine. 32 years ago, we might have one doctor that covered all of that by themselves. And maybe they had somebody that would come and cover them when they were on vacations. That is not the model that our providers want today. And that's been difficult because of the volume and because of the call burden. Our current providers, people coming out of school, people we're talking to, do not want that high of a call burden. They want less call so that they can have a work-life balance and be with their families. As a result of our difficulties due to low volume and recruitment challenges, we identified a new model that will help to ensure access to care for the women in Lincoln County by partnering with our neighboring hospitals to provide the labor and delivery services while maintaining and expanding pre- and postnatal services and GYN care in Lincoln County. I'll share with you, in fact, just this week, we signed 2 OBGYN physicians, both of which were part of the Main Track Tufts Medical School LIC program, one of which was one of our students at Lincoln, Dr. Sidney Ford, and one of which was a student at Stevens Hospital in Norway. They both signed this week to come to this new model of care that we are going to provide. Both agreed to join us to provide pre- and postnatal care as well as GYN care in the ambulatory setting at Lincoln. They'll provide GYN surgeries in our surgical suite at Lincoln. However, the model that they preferred and the model they chose was when they knew that we were partnering with Midcoast to provide labor and delivery at Midcoast Hospital in Brunswick. They are coming to do all that ambulatory care at Lincoln, provide GYN surgeries at Lincoln, but they will be doing their labor and deliveries at Midcoast Hospital. And that's the model that they chose. That's the model that they signed up for. Part of that was because they didn't want to come to the low deliveries, the low number of deliveries, and they'll get a higher number of deliveries at Midcoast Hospital. And they didn't want to come to what we consider is one, is call every 4 days or 1 in 4 call days, where a provider covers a 24-hour shift every 4 days or every fourth weekend. That was not palatable for them. They wanted less call burden, and in the model that we'll be providing, they'll be doing every 7 or 8 days of call. But they're exactly the type of providers we need to be recruiting to the state of Maine. And we need to look at models of care that we can provide that are going to attract those providers and keep those providers in the state of Maine and practicing. In the meantime, right now, because we rely solely on our per diem OBs and OBGYNs, we are experiencing some difficulties and some consequences of not being able to have a consistent group of part-time or full-time providers in the OBGYN world. During the last 6 months, we have had 4 occasions when Lincoln's Labor and Delivery Unit temporarily was closed, and we could not accept patients because of the necessary coverage was not available to us. That is called diversion, and there's a whole process that you go through when you have to go on diversion in order to make sure that your patients are notified and all your local hospitals are notified and your partner EMS people are notified. Our team works, this is a full court press every day to make sure all of our shifts are filled, and so that we don't have to go on to diversion. And what happens today is those per diem physicians will pick up our provider that is a family medicine OB provider that does C-sections will pick up extra shifts. But that is not a sustainable model. Per diem coverage and picking up more and more call coverage is not the model that's going to sustain labor and delivery. When we were going through this process, we went out into the community to have some open forums and hear from our community. And we spent time listening to the community, and we heard lots of questions and some ideas from the community that became part of the assessment. And the community group, which became the Community Coalition, brought forward a much broader vision of the future of Lincoln Hospital during the miles and delivery work that we were doing, and had some ideas around increasing birth volume and developing new staff models. We did take those seriously. We looked at what they provided. They provided lots of documentation, and we read through that and considered all of that. The challenges that we continue to face, however, were whether or not all of that could be credible into the future. And with 132 births, no employed OBGYN providers, and an inability to recruit for over the past 5 years, and an increasing need to look at going on diversion when we can't cover because of lack of coverage, that model is not sustainable. That is not a safe way to provide labor and delivery in a community. Ultimately, we concluded that neither the options that we identified in the assessment nor those proposed by the coalition would establish a sufficiently reliable path to maintain services in a safe and reliable way. One of the questions that came up is why not delay the decision? And I want to address that because our community asked that question. Elected officials were asking that question. Why not wait a year? Why not wait 2 years? We were already seeing the increase in the inability to cover those shifts and the time, the amount of time that we were concerned about not having the right number of providers to have coverage for labor and delivery became more frequent and more concerning. And we were concerned that we would not be able to cover the shifts. And so we really knew that that was not sustainable. In fact, we just, with the help of per diem providers and our family medicine OB C-section provider, were able to cover a lot of shifts that were open. But we still have 5 days over the Thanksgiving holiday right now that are not covered, that we will be working to find somebody that can cover those shifts. Our incredible team, our providers that do help us scramble to make sure that we're covering those. And that's not a way to provide care. And honestly, that's what keeps me up at night, is worrying about making sure that we have the right team in place to take care of our patients that come through our doors. The question for us was ultimately came down to whether or not this was the model, the reliable model to sustain in Lincoln. And I'll turn to Dr. Kat Campbell, who can walk through what we looked at through the assessment process and elaborate on some of those.
Thank you, Cindy, and thank you to the committee and our co-chairs for taking the time to listen to our testimony today. And I just wanted to start by saying that I did not grow up in Maine, but I did grow up in a small rural community in northern Michigan. And so I understand how deeply the closure of a local labor and delivery unit can affect a community. These services are personal, and their loss can feel significant. I have dedicated my career to obstetrics and gynecology and to building high-functioning systems of maternity care that are safe, reliable, and centered on patients and families. My goal is to ensure that pregnancy, delivery, and the postpartum period remain as joyful, safe, and positive as possible, even as we adapt how and where their care is provided. And I just wanted to start by highlighting three overarching points of what I'm going to say today. So number one, access to maternity care is about the location of the delivery and, importantly, the location of prenatal and postpartum care. For most of pregnancy and the postpartum period, what patients need most is reliable, high-quality care close to home. Timely prenatal visits, ultrasound, additional testing, management of pregnancy complications, behavioral and social support, postpartum care, lactation, and rapid access to when concerns arise. We recognize that the majority of maternal morbidity and mortality occurs in the postpartum period, and preserving and strengthening these services locally is essential, even when delivery occurs at a separate hospital. Second, our obstetric workforce is changing and has changed, and our care models need to change with it. The next generation of OBGYN is seeking sustainable practice models with reasonable call frequency, team-based care, professional support, and enough clinical volume to maintain skills. In rural settings, maintaining a traditional 24/7 labor and delivery model at very low volumes can require a physician and midwife workforce that is increasingly difficult to recruit and retain. Our goal has to be designing a system that is sustainable for both patients and the clinicians who care for them. And three, Lincoln patients will have coordinated maternity care pathway, not simply a change in delivery location. The plan is to maintain comprehensive prenatal and postpartum care at Lincoln while creating a deliberative, coordinated pathway for delivery. This includes early delivery planning, clear communication between teams, shared clinical information, defined pathways for urgent evaluation, for transfer, and continuity back to Lincoln after delivery. The objective is a system that feels seamless to patients and provides reliable access to the right level of care at every stage of pregnancy. And as Cindy shared, the assessment that was done in the white paper was not conducted to validate a decision that had already been made. The purpose was to determine whether there was a clinically safe and sustainable way to continue labor and delivery at Lincoln and what that model would require. The assessment was conducted. It looked at staffing models. It looked at travel times, regional capacity, and patient outcomes. Waldo was a good example for us, as earlier Andy was telling us about what seems to be a very successful transformation of combining the two areas for a shared team-based model with delivery at a single hospital. We have looked carefully at the experience following this transition. The two hospitals are approximately 22 miles apart. Lincoln and Midcoast are 24 miles apart. To date, we are not seeing evidence of the significant increase in emergency deliveries or adverse outcomes that we all feared. Does not mean that there is no risk when a labor and delivery unit closes. Just the opposite, we recognize there is risk. And that is why a thoughtful transition with a nearby receiving hospital that has capacity and appropriate clinical resources will maintain safe access to maternity care. And importantly, the prenatal and postpartum care was also maintained and expanded as it will be at Lincoln Hospital. In regards to Maine's maternal, fetal, and infant mortality and the data associated with that, we really should broaden our conversation around what is driving maternal and infant outcomes. And it should help us and inform us as we move forward in thinking about maternity care across the state. The data, which thankfully, we have state maternal mortality review committees as well as infant mortality review committees. It gives us this very granular data. We have this committee active in the state. It's critical to help us make decisions, but the data shows that the vast majority of pregnancy-associated maternal deaths occur in the postpartum period, rather during labor and delivery itself. The primary drivers of maternal mortality in our country today are mental health disorders, as well as substance use disorder. We're also very concerned about hypertension in pregnancy and how we respond to treating severe range blood pressures and hypertensive disorders of pregnancy. We're also very concerned about how we recognize and promptly respond to hemorrhage. Hypertension can occur in any phase of pregnancy, outpatient setting, delivery, hospitalization, and postpartum. Hemorrhage can occur antepartum. Most often it occurs in the early postpartum period. Infant mortality, we have primary drivers of infant mortality. Number one is actually prematurity. And so we should be thinking about this as we are building our systems. Birth defects are a very large contributor to infant deaths. The third one is maternal health. I always like to think about maternal health as a bellwether of our society. It helps us understand where our health is at the individual level. In maternal health, we know that substance use disorder has been a significant factor in maternal mortality, morbidity, and it clearly affects infant health and well-being. Perinatal mental health is also a significant contributor. And it would be amiss to not include social determinants of health, a primary driver of our overall health as individuals, and this affects our pregnant population. I'm just going to transition to our care teams and building sustainable labor and delivery teams. It is true that our workforce is changing. In 2003, the laws changed, or actually were implemented, because I don't think there were any laws protecting residents in the work hours that they were assigned to. And they were put in an 80-hour work week. And so they work at 80 hours, and that is actually rigidly applied. And residency programs will actually lose their accreditation if residents are not trained within and kept within that 80-hour work week. Traditionally, people graduated from their training, and just like Cindy was talking about, they moved to the community. They assumed a job as an OBGYN, and they might have been the single OBGYN for that community, and they were just on call 24/7. It was a lot. Medicine was also a lot different back then, and I think now it is very different, and the demands on our care team providers are immense. Our residents are not graduating the residency programs with a plan to go back in time and do something that maybe a grandparent did or a parent did in terms of how they delivered their obstetric care. They are going to do it in the way that they were trained, and it is within a model that supports team care, team-based care, work hour restrictions, and really a little bit more of a shift work mentality towards when you are working in these intense environments. And I want to ensure that we highlight when a physician does a shift work, it does not reduce the relationship between the patient, the family, and that physician or that midwife. In fact, I think it can actually lead to a more robust relationship because both all care team members are also achieving that work-life balance that we all achieve, that we all want to achieve. Low volume is a critical component of our physicians working in hospitals. In order to become board certified, you have to attend multiple deliveries, you have to take care of complications, and you have to be well-versed in all aspects of obstetric and emergency GYN care. In low-volume settings, it becomes very challenging to get that exposure, and it limits their ability to successfully complete board certification. And so we see providers looking for jobs where they have a reliable volume of patients to care for, including enough volume so that they can take care of those more rare emergencies, and they can maintain their skills in them. In moving towards our next steps, we are preparing for the transition. We have a steering committee with various subcommittees who are working together, linking Mid-Coast Hospital and Lincoln Hospital to build our ambulatory GYN practice and obstetric practice, along with a coordinated care and that transition where they will receive care in the Lincoln area and they would deliver their babies at the separate hospital. That work is very important. I think this is critical to us being able to provide high quality maternity care in the region to our patients. And I think it is one step forward in thinking about how we can be innovative in going into the next generation for providing high quality maternity care here in Maine.
So in closing, just want to thank you all again for the discussion. We look forward to working with this committee, the legislature, other key stakeholders across the state, other health systems, and trying to think about how we solve not only the challenges around rural maternity, but really lots of different specialty care and ensuring that we've got appropriate access. We're happy to take any questions.
Representative Mastracchio.
Thank you, Madam Chair. So I'm from Sanford. I remember when our labor and delivery closed, and I have two questions around that. The most important figure that I heard from the testimony that you all gave was that 68% of Lincoln County women deliver at another hospital. Can you quantify that in numbers? And if those people all delivered at that hospital, you would have sufficient numbers to maintain a labor and delivery service. I'm just saying that, and you can answer that, but in Sanford, the reason that ours closed is because people were choosing to deliver in the other hospitals that were over the border in New Hampshire, at what is now Southern Maine, in Biddeford, or in York, there were a lot of choices even in 2014, but the impact for Sanford was that labor and delivery closed. And I want to just, before this will just finish the question, because for what happened in Sanford after that was the hospital closed. So I just want to make sure that you understand, and you probably do, that for a lot of people, that's where they're going. So I would like you to address that issue as well as, because I understand the numbers. You can't have it if you don't have the numbers. It's worked in Sanford, had a big uproar in the beginning, and it all worked out for us. So, but I think in the end, our hospital, our inpatient hospital closed. And that was a bigger issue than the labor and delivery.
So a couple thoughts to start, and we'll ask my colleagues to chime in as well. Part of it, I think just honestly, if you look at the map of Lincoln County, where the hospital is located, Damascus is not the center of the county. And I think for some of those women, it's just simply more convenient to go to Maine General or to Mid-Coast or to Penn Bay or to other hospitals. The other thing we haven't talked about is that there are many women who have complicated pregnancies who need to deliver at a level 4 NICU. And so they have to end up planning to deliver at Maine Medical Center, for example, or a level 3 NICU like Eastern Maine Medical Center. And while we talked about declining birth rates nationally and in Maine, the other thing we haven't necessarily talked about is that a higher percentage of women are having complicated pregnancies. And so, and that rate's going up significantly. So that's creating a challenge where there are fewer and fewer women with normal pregnancies who can deliver safely in a community-based obstetrics and gynecology center. To the other part of the question about the hospital, I'm going to use this as a real important just sort of education and statement period, because I don't think we're talking enough about this. And with Representative Foley's deference, I'm going to speak just a little bit about the national picture and then tie that back to Maine. Nationally, our minds are snapping as we try to think about how we're going to provide the care that needs to be delivered as we age as a nation. and in which we're going to go from about 19% of our population who is 65 plus to 22% of the population is 65 plus. And we're going to see children fall from 21% of the population to 19% of the population. We're going to have more seniors in this nation than children. So as a nation, we're struggling to figure out how we're going to provide that care to 22% of the population. Maine's already at 25% of our population is 65 plus. It's going to be when the US hits 22%, we're going to be at 30%. When patients matriculate from commercial insurance to Medicare, our reimbursement goes down dramatically. However, the demand for care goes up twice as much, and the cost to deliver that care is 2.5 times more expensive. We're facing a huge crisis that we're all going to have to put our heads together and figure out how to solve for, to the degree that even we as a healthcare system are building a new strategic plan around how do we try to effectively manage the total cost of care through delivering better care outside the walls of the hospital, lower cost settings, because our fear is if we don't do that, we're going to end up irrationally rationing care. And this conversation was hard enough. I don't want to be a part of those conversations when we think about what are we going to do if we can't meet the demand of our communities. So to that end, Lincoln Hospital is vitally important to us. We don't know what we'll do in that community if we don't have access to care, which is why we're making big investments in that care. We just built a $20+ million new primary care center. We're investing in more oncology services because there's demand for those services, expanding our surgery services in that community. There's demand for that. Frankly, the 2 physicians who we just recruited who want to do ambulatory care in that community can provide more GYN surgery, which there's going to be huge demand for in that community. And so that's part of the challenge that we're going to face, is that our communities are changing and the demographics and the demand for care is just going to look very different. And somehow we've got to think about how we respond to that.
So the hospital's not closing.
No, we've just spent a lot of money on it for sure. Yeah, I think that was the case.
Representative Olson.
Lights are flickering.
Yeah.
I hope it's not like in the theater, it's telling us to get out. So, I've got a couple of questions on the per diem side. When you bring someone in on per diem, how long do they sign on for? Number one is, so in other words, I mean, in some scenarios, per diem on nursing per diem, they're there for 60 days or whatever. That really doesn't cut it on the OB side. So what's the length of term that you've got them on there?
Sure. There's a couple of different approaches. We can have per diem, and so that person would be hired, credentialed at the hospital, and then they would sign up for the shifts that they wanted to work. It could be 1 day a month, 2 days a month, one day a week. And so that's a little bit different than hiring a locums. And that's usually someone who is hired in through a national organization that helps physicians find these types of temporary jobs. And they're signed on for various periods of time. So could be 1 week, it could be a month, it could be 3 months.
Okay. And secondarily, if the mode is looking at it, more in the realm of per diems, are we looking at flipping it to the patient side? Are we looking at any issues with network and whatnot? And so that now you've got doctors that are not going to be covered by their insurance. So we have a secondary issue there that may or may not be picked up under the surprise billing and things like that.
That has not been my experience with either locums or per diems, because they would be insured by the standard of the local hospital. And in obstetric care, we take all insurances. So there's no denials in obstetric care.
Yeah, but I mean, we ran into the whole issue on the surprise billing, especially, it hit especially hard on anesthesiologists because they're under the hospital, but they're not in network. So
we credential them all through all of our
through
payers.
Okay.
So that's not an issue.
Okay. I just want to make sure we're not flipping a problem from one side, one side of the room to the other
Right.
side.
I think a very important differentiation to make for obstetricians.
And then the third question, you mentioned that you talked about travel time and you had the discussions with people. Did you at all, was there any consensus on what they considered to be a reasonable travel time for delivery services?
Yeah, I mean, that's a product of a lot of research. And it's been done here in the US and across places in Europe, especially bigger countries like in Scandinavia. And so there's not a single there's not a single time or distance that is stated. Rather, it's a continuum, and it sort of makes sense. So if you are 6 hours away from definitive care, that's going to be a lot riskier than being 60 minutes away from definitive care. And so there's not a single standard that we have here in the United States, but it should be a critical part of the conversation and what we think is reasonable.
Representative Matheson.
Thank you so much for your information. Building on that, I know you guys did a time analysis for Waldo. Did you do that for Lincoln County?
Yes, we did.
That one.
We
Great.
did do-
Can I get information on that too?
Yes.
That'd be
Um,
great.
share
Thank
that.
you. So there's a lot of numbers.
Mhm.
I've read through all of the information everybody has sent, and I really appreciate the hard work that everybody has put into this. The 32% that I keep hearing, that number seems strange to me based on how many actual births there were in that county. So I would like clarification on that because my understanding was that there were 260 live births and 130 of them were in Lincoln Hospital. So that doesn't seem like the numbers line up. So could I get some clarification on
I can
that?
clarify that. So there's two sets of data there. So one set of data is if you were pregnant and living in Lincoln County, what was the percentage of those patients that delivered at Lincoln Hospital? And that's where the about 32% were delivering. The 132 births is that 32% plus patients that came to do their labor and delivery at Lincoln from outside of Lincoln County. And there are folks that drive from Sabatis, Hope, Appleton, Union, past Penn Bay, past Midcoast, in some instances, from much closer to Maine General to Lincoln to have their babies. So that's why those numbers, if you try to put them together and come up with the percentages, you won't get there because you need to look at them separately.
So that's where that 32 comes from because you separated them out. Great.
Yes.
Thank you. I appreciate that clarification. Just one more, I promise. I'm I have a problem with putting numbers on care. And I understand that absolutely workforce is important, and I really appreciate that Maine Health is considering other safe methodologies for labor and delivery, midwives, making sure that family physicians are OB trained. And in hopes that you're also allowing them to be in hospitals. That's great. My concern is this 200 number that I keep hearing about, which is the low birth rate. Do we have that application to emergency rooms as well? Do you have a number of people you have to see in an emergency room that's considered a low rate? So therefore, our emergency rooms are going to start closing as well. The reason I ask that question is because women's health seems to be at the chopping block, always. And that concerns me a great deal. I don't hear from hospitals that you have a number that you have to have for your emergency room to keep that open. So I guess I'm curious where you land on that and what's on the next chopping block.
Okay,
And why is women's health the first one?
I can start with that, and then Andy, 200 is just a definition to describe very low birth, like annual births. It's a number that is a little bit arbitrary. However, it comes from data looking at various outcomes around delivery volume and perinatal morbidity, maternal morbidity. And the 200 is the number that has been generated. There's nothing really magic about it. It could be 250, it could be 175. It's just 200. And I think it's part of a way for studies, because studies have to pick these numbers, and they're sort of lines in the sand. And so I would say that about 200. But it is a way for us to have conversations, compare apple to apples across labor and delivery units across the country.
So,
And does that,
I
does
just
that
wanted to
help you
add-
identify whether or not you want a labor and delivery,
I
that
think-
number?
I think that I think an important differentiator in obstetric care is that thankfully most people are low risk and most people are going to have an uncomplicated delivery. We identify people who are high risk. Maybe the baby has congenital heart disease or the mom has difficult to control hypertension, and they are going to deliver at a facility that has all of the resources available. Most life-threatening obstetric complications happen in the low risk person. So I'll say that again, most severe obstetric complications happen in a low risk person, and they're unpredictable. And I think that's what worries Cindy when she's up at night thinking about the coverage. It's what worries an emergency room doctor who is working in a hospital with no labor and delivery. And it's what worries a single provider who is at 3 o'clock in the morning, the only person there when someone comes in with a life-threatening hemorrhage. And so I think that is one of the key differences between, having your doors open for any type of care that someone could walk in for versus obstetric care, where a small emergency room may not be trauma certified, and that is a well-advertised fact. A labor and delivery unit is our doors are open because we provide all aspects of obstetric care, including life-threatening emergencies that would be better cared for at a much larger hospital, but we are at a small hospital or a place that has fewer resources.
And just to add to that, I would say that 200 is not a threshold that we use internally to make a determination about continuing a service or not. If we could figure out a way to safely and reliably staff this service, we'd be interested in keeping it open for sure. However, once you start to get below that number, where it becomes a concern is just the ability to attract talent to do that. Bankers don't want to work in a bank where there are no deposits. Bakers don't want to work in a bakery where there's no flour. And obstetrician gynecologists want to be at a center where there's a vibrant number of deliveries to be able to perform. And so that's part of the challenge we see. The additional challenge that occurs with obstetrics and gynecology is that, particularly for younger residents coming out of training, they have to care for a certain number of diverse patients in terms of conditions during the early part of their experience in order to sit for their boards. And it becomes increasingly unlikely that if you're going to take 1 in 4 call, that you actually be able to achieve those numbers once you get below 200 a year, which makes recruitment a challenge, particularly in an environment where today the estimates are we have between 8,000 and 9,000, an 8,000 to 9,000 shortage of obstetrician gynecologists across the country. And so they can choose from all sorts of job opportunities, many of which offer 1 in 7, 1 in 8, 1 in 10 call versus 1 in 4. And so if you're already worried about being on call every 4th night, and you have the additional complication, I might not get enough deliveries to ever become board certified. It makes it really challenging to work in those areas. Now, for the emergency room specifically, I don't know what the number is, but I'm sure all of our emergency room physicians and APPs will tell you they're seeing more patients than they can possibly handle, and they genuinely are. But there is a reality that we know, since we've become much more as a profession, really looking at evidence-based data, that the people who do the most procedures tend to be the very best at those procedures, and those who do very few of procedures tend to really struggle with complications. And I think part of the challenge and this is where I think we need to have these conversations together as a state and with our professional organizations, with the medical boards and professional societies, is to understand what we're willing to accept and tolerate when we know there may be a better alternative in another location. And how do we figure that out together and really ask those questions intently? Because I think it was Representatives Arford's question earlier, what is the patient's perception of the quality of the care? And while we certainly ask them about their experience, the reality is that when you look at patients on the front end, most of them assume that if the service is available and the hospital is credentialed and certified by the state and Medicare, then the care is safe and high quality. It's hard for individual patients to really discern what is an appropriate number of C-sections for a physician to do in a year to be effective and high quality. And so that's where I think we need to make sure we really understand what we're providing and make sure we're all comfortable with that to do that effectively.
Other questions, Representative Boyer.
Thank you, Madam Chair. Thank you all for being here. Cindy, I think you mentioned that family practitioners with OB training were doing some of the labor and delivery services. Is that something that is hospital to hospital? Like, does every hospital in our state allow family practitioners with OB training to do labor and delivery, or is that like a hospital by hospital choice?
So I'm going to look to my colleagues. Yes, we have used family practice OB providers for as long as I can remember at Lincoln, and at various times have had more than have had a full complement of that type of provider. And we do use family practice OB providers in other hospitals in the state of Maine. That is something that is utilized and unique. I think more unique, but becoming more of an option are those family medicine providers who are OB trained and can do C-sections, which we've had one of those at Lincoln, and they provide a different or a higher level because they can do the C-section part as well as handle some of the emergencies, but not necessarily all of them, but some of them. And it's been a great adjunct to the team that we've had to provide. But I don't think family practice OB with C-section is necessarily in all hospitals in the state of Maine at this time.
Yeah, they wouldn't necessarily be prevented from being credentialed to work in a hospital and perform cesarean delivery.
I think that's what I'm trying to get at.
Yeah,
If there are barriers, can you be clear about what they are?
no.
So that we don't leave here, I don't leave here assuming, oh, if we invested in family practitioners that can do C-sections or OBs, that would help solve our problem if the next situation is they're not credentialed at all hospitals. So if you can just help me understand that.
Yeah. And I just add to this conversation, obstetric care is a team sport, and we have lots of different components to that team between our skilled nursing, the OB provider, and we have different types of OB providers, right? We have certified nurse midwives, we have family medicine OB, and we have OB/GYN. And so we welcome that complex or diversity of the skill set that people bring to a team like that. And I think that in thinking about being innovative moving forward, I think across the country, we're thinking about collaborative obstetric care and having those diverse teams. Part of the conversation, though, should be that an OB/GYN has a different skill set than FMOB. And when an OB/GYN is on call, they take care of obstetric emergencies and routine obstetric care, but they also take care of GYN emergencies. And of this group of people we're talking about, they're the only group that's trained to take care of a hemorrhage associated with miscarriage and ectopic pregnancy that needs to go to the operating room. And so I think we should just keep that in part of the conversation.
So it could be part of the solution, but it's not the solution.
For sure.
Yeah.
For sure. Yeah. And I think we have to think through what that looks like. And it goes back to really understanding what capabilities we're willing to have and not willing to have. And I think that's where we have to have a lot of stakeholders around that. It would be challenging for us to make that determination around what that standard is alone. And so that's where we're going to need help from the professional societies, the medical board, our regulators to understand what that would look like. And to specifically answer your question, the medical staff bylaws have just effectively been normalized throughout our system. So the ones that apply at Lincoln apply at Maine Medical Center, apply in Farmington, apply all across our system. And so there's not a credentialing barrier to those physicians being able to provide the care.
And if I might just add, so that model with a family medicine OB C-section provider, we actually had someone come that we were trying to recruit, and we had the same conversation and challenge with that recruit. Not enough deliveries, and the call burden was too much.
And just one last thing I wanted to add. Any OB/GYN on call always has a backup OB/GYN for helping with any emergency. And so an FMOB with cesarean delivery privileges would also want that backup. Generally, that would be an OB/GYN who is trained to handle a broader array of complications associated with delivery.
Just to add to that, and I'm not sure we've specifically talked about this, but this is another challenge that we're finding not only with OB/GYN, but other particularly procedural based specialties is, as Dr. Campbell referenced earlier, many years ago, they changed how we educate residents. It's very different than when Dr. Jarvis and I were residents together at Andrews Air Force Base many years ago. And so with the work restrictions, many who are coming out of training today don't feel fully trained. And so they want to work in an environment where they have lots of other peers around them who can step into the operating room if necessary, or who can mentor them through difficult cases. And that's more challenging in a smaller community or a smaller practice. And that's one of the obstacles we're starting to run into now, is they want the reassurance of knowing that I've got an experienced clinician of my same level of training near me in the event something starts to happen. I think many years ago, there were many who had strong independent streaks who thought it'd be great to go to a rural community. I can do whatever I want. But I think there was a great deal more confidence in the level of training back then, just because they did a lot more of it in the same number of years. And frankly, our understanding of medicine was much simpler. And what we did was far less complex than what we do today. And so for that reason, it creates an additional barrier to us that we're having to work to overcome. Now, to that end, as was referenced earlier, we're making big investments and big strides in expanding our graduate medical education in rural communities to specifically try to do this. I think a good example is Franklin Hospital in Farmington, where we're planning to launch a family medicine residency program with OME to try to help solve some of those challenges and expose people to the practice of rural medicine, because the reality is once they experience it, they really like it. We've seen that with a rural internal medicine residency program at Stevens Hospital in Norway, where out of the 6 graduates, 4 are still practicing in the state of Maine, 3 are practicing in Norway. And so we see that as a model for the future. So we're expanding our offerings to try to make that happen. We're doing it at Penn Bay with surgery, because we recognize general surgery is going to be one of those areas that's going to come under strain as well as the workforce becomes really, really constrained.
Well, Senator Foley.
Thank you, Madam Chair. And thank you folks for being here. I appreciate the difficulty of these decisions. I served on the Board of Trustees of York Hospital for 8 years. And I understand, we had to make some tough decisions with our urology, psychiatric help, and eventually our maternity as well, because those services were taking too much revenue from our other services to make it viable. So, and I also want to take the opportunity to thank you for partnering with York Hospital, because I think it was going to be difficult for that situation to continue without a partnership with Maine Health. So I really appreciate that. My question is, and one of the concerns I would have is, if a mother shows up at the emergency room with a complication, is there an emergency protocol, either an ambulance service or something ready to go to take this person to get the care they need? I mean, to me, that would be a concern, to really want to make sure that there was something in place to take care of that.
Yes, there is, and it is actually a critical component to a healthy system that we develop. And so having the emergency room prepared for obstetric emergency is something that is already done across our healthcare system, and it's actually national requirements. So this is done in every emergency room. And it's something that we're looking at very carefully because it is a critical component that if someone arrives, that we can have the help available immediately. We can have as much skill available immediately. And then we have emergency transport systems to get them to their location of definitive care.
Thank you.
And I would just add that specifically with the planning at Lincoln, we have also 4 EMS companies in Lincoln County, which is a lot, but it's great. And we are partnering with them as well. They are part of our training. They're part of our work plan, and they're part of the simulations that we do in the emergency room so that everybody has that level of training.
Thank you.
Further questions? Representative Arford.
I looked at our agenda. Thank you, Madam Chair. And I see that after we take a break, we're going to be getting more information that may answer some of my questions. So I'm only going to ask one. And that is, based on what we've been presented so far, there's no data available publicly that demonstrates the difference between the quality of care, including the mortality rate of rural-based birthing centers and rural hospitals and hospitals that are not considered rural. that you do not have any data you can share with us that actually demonstrates the discrepancy, if there is any, between quality of care, rural, low volume, quality of care, non-rural. Well, I want the whole realm, also low, just comparing these different settings.
Sure, I think it's a really important question. And I think the more appropriate comparison is between labor and delivery units that have an intact team that practices together, does simulations together, comes to work every day, and knows how that labor and delivery has built systems to respond to emergencies. And compare that to a labor and delivery unit that is putting things together on a day-to-day basis, bringing people in from the outside who, yes, we do a C-section pretty much the same way every day, but there are small differences that can be critically important. And so I think that one of the systems that we want to continue to reinforce is that we have diverse obstetric teams that are committed to working on that labor and delivery, who practice together day in and day out, know how to respond to emergencies, know the systems that have been created in that hospital. And so I think that, and there are data for that, showing that teamwork, communication is directly linked to quality of care and patient outcomes.
Yeah. And thank you for that. That's excellent information.
And I think that can happen in higher and lower volume hospitals. And there are data of that. And it's actually, I actually did research on this at my previous job. And it wasn't so much the volume that was the contributor, but it was these sort of difficult to measure components that actually create quality.
The final question, that was where I was going, if the low volume, high volume, and you're saying wasn't a distinguishing factor amongst
Right.
the quality rate between the
And
different settings.
then I think Cindy highlighted the difficulty with getting that routine, regular team hired so that they were practicing together, doing simulations together, all aware of like how to respond to particular emergencies.
So just real quick, would it make a difference if that high quality team that works together day in, day out performs even in a low volume setting, delivering excellent quality of care? Is there any information that speaks to, if they were to rotate that same team that works day in and day out, they just were delivering their care at different settings within, let's say, the same county? Is there any information that speaks to whether or not, because they're rotating, the quality of care is negatively impacted?
I mean, I think we go back to the complexity of the problem, and the other rate limiting step is the ability to recruit and have the obstetricians, family medicine, midwives, the volume needed to provide something like that. And I think that's one of our rate limiting steps in the conversation we're having today, is that despite best efforts, the team at Lincoln had difficulty recruiting and retaining. And it's almost like it becomes like a cyclical problem.
Thank you.
Further questions? Can you just clarify something you said? And I understand the intention is to keep the pre and post natal care at Lincoln. I assume that means at Lincoln Hospital. First of all,
Yes, we have an ambulatory care center that has that care in it right next to the hospital on the same campus.
And so then you indicated that the plan would be that, again, someone would have their prenatal care, would give birth at a different hospital, and then their care would be transferred back to Lincoln. What does that mean?
So the model would be, they would get their prenatal care at Lincoln, and then they would have their labor and delivery experience at Midcoast Hospital or Penn Bay if they chose Penn Bay. And then they would come back and have the ability to come back to that ambulatory care center for their postnatal care. So their follow-up care, and then for their newborn care with our pediatricians on the campus. That happens today with patients that deliver off-site.
Okay, so it's an option.
Yes.
The way you presented it, I was envisioning you were physically transferring mother and child
sorry.
back to Lincoln.
Sorry.
So when you would use the word transfer, so they would just have the option.
Yes,
That's all.
to come
Okay.
back and have that post-care.
And it would be recommended because that would be sort of the heart of where all of their prenatal and postnatal care was given. And so in practical fashion, what that looks like is that the person would have their delivery, they would be postpartum in the hospital. And because of the EHR that talks across all of our hospitals, you would be able to establish that appointment and they would just go back to their community and have that appointment scheduled for them.
Right, but again, we are talking about though having a different team, as
would-
you just indicated, for your labor and delivery than your pre and postnatal care.
It would be mixed because the OB team members providing prenatal care are also working at Midcoast Hospital and they're part of the call pool. So yes, you might meet someone that you have not met before, but you also might meet the obstetrician or midwife that was caring for you during prenatal care.
So maybe I misunderstand when a woman has her prenatal care through Lincoln, they don't always see the same doctor? They see different providers depending on.
They could potentially see different providers. So
Oh,
they might
okay.
see their midwife, but if their midwife's not there for their appointment, they might see a different midwife or family practice or family medicine OB provider. Or if we had a per diem OBGYN provider on campus, they might see that. And the plan is for us to coordinate the care in the prenatal visits. So that a couple of things. One is so that some of those providers that you'll see there will also be working at Midcoast and partnering with Midcoast to do the labor and delivery part. So one of our doctors, Dr. Sam Culver, she is a family medicine OB. She could see you prenatally, and then you might see her at Midcoast delivering your baby as well. And then back postpartum at Lincoln.
But that's all out of the control of the woman giving birth.
Correct. And that's true today. That's
Right.
true today. You may not see, especially given the circumstances of a lot of per diem providers, you might not see the same provider in your labor and delivery experience.
But just to clarify, which part is out of control to the person?
Choosing who you want to see as
For
your
the delivery,
provider.
For the delivery.
For the
Well,
delivery?
for everything, it sounds like. Prenatal care, it sounds
Yes.
like you again, might see the doctor you want to see, you might not. It sounds like definitely labor and delivery, you have no choice. And then postpartum, I'm assuming it's the same setup? Where you
might-
again,
yeah.
you might see the person you want, you might not.
And I think this is an very important part of the conversation in that, and this is the changing milieu of how our physicians train and what the healthcare environment looks like. And so our graduates are coming out of their training, really working in team-based care, where they are part of the group, they see the patients, but as a patient, yes, you might get one of however many are in your group because the model of a single person being on call 24/7 is not sustainable in this day and age. It would be very difficult to maintain that and
And I
people just aren't
understand that
choosing
for
it
labor
either.
and delivery, I didn't realize it was
And-
happening.
And I would
pre and
add, the
postnatal as
team
well.
works hard. The team in the ambulatory setting, which is made up of patient service representatives, medical assistants, the provider, there's a nurse. They try very hard to have consistent visits with the same provider. But there could be an opportunity where that provider is away and you need to come in for your visit and somebody else will see you, but it's a team base. And so you typically will know who those providers are at some point in time. But they try hard to have you have a consistent prenatal visit with the same provider. It just doesn't always happen that way.
Do you meet everyone on the team?
The goal will be to meet all of the doctors that would be performing labor and delivery in the setting with this plan, this transition, and you would meet them. And there's a couple of different ways. There's a recommendation that we would have a meet and greet night where you go to, for instance, if you're doing your prenatal care at Lincoln, you would go to Midcoast and do a meet and greet with the providers. You get a tour of the unit. You get to meet the nurses on that unit as well. And when you meet and greet the providers, some of those providers will be the same providers you're seeing prenatally.
And just to be clear, it's not that really different at any other hospital or even a private practice now. It's sort of the same type of experience.
Okay, Representative Mastracchio.
Thank you, Madam Chair. I just want to say, correct me if I'm wrong, but I had my kids 45 years ago And that's what it was like. I went to a practice where maybe I saw this nurse midwife and I didn't know who was going to deliver my baby. And, it was like, well, I hope that person's on call the night I go into labor. I mean, it was the way it was. And I guess I don't find it that, I tried to make appointments with the providers that I wanted to see when I was in my prenatal care. And postnatally, I actually didn't really care. I just wanted to get it done so I get home to the kids. But honestly, I think that you sound like you've got a plan in place, and it actually doesn't sound that different from what I experienced many years ago.
And I'll just add that there is actually a large body of data looking at different care models on labor and delivery, from the individual provider-based model to a team-based model. And actually a lot of the outcomes in the team-based model are better for both the patient and for the newborn. And part of that is because labor takes time, right? And we don't want to be on the clock for most of what happens. Yes, we have some time parameters, but it might be that the patient who started her labor, on the morning of your shift, and you're sort of, let's say you're on until 7 p.m., that they don't deliver before you leave, and they deliver at 10 p.m. that night. But if you're the single provider and you're covering that patient, you might be trying to have, maybe you had something scheduled in the evening. And so there becomes this like outside time pressure placed on that person's labor, and that it's actually associated with higher cesarean delivery rates. And so there are benefits of this team-based model.
Representative Clucci?
I was just going to ask if I could sort of see if my understanding is correct of how this could work. So when I had my second child, I saw the midwives at Midcoast, but because I wanted to have try for a vaginal birth after cesarean, what I was told was I had to transfer my care down to the high-risk hospital or the high-risk practitioners in Portland 4 weeks before my care. So for all of my prenatal visits, I saw the midwives at Midcoast. Then at 4 weeks, I went down, or at 36 weeks, I went down and I met with the high-risk groups, and they did like weekly visits with me. And then when I delivered at Maine Health and, or Maine Medical Center, sorry. And not only did the high-risk doctor come over, but there were also a pool of residents, right? Because it's a teaching hospital. And so I saw whoever I saw when I was actually delivering, but the care was sort of at that point being managed by high risk. But then when I left the hospital, all of my follow-up just went to Midcoast, to the midwives again. So is that basically what we're sort of talking about when people would transfer to a different hospital for their delivery and then come back for their care?
I would say sort of, because there's going to be, I think coming from either Midcoast or from Lincoln, the doctors who work there and the midwives who work there don't also work at Portland. But the difference here would be that your midwives and doctors work at Lincoln, and they are also in the call pool. And so it is really seen as, I get my prenatal care and postpartum care here, and this is my delivery hospital with the same care team. There's just additional people in that call pool when I go to Midcoast.
Yeah, another way to look at it might be that there's an OB practice that has their largest office next to the hospital in Brunswick at Midcoast, but they have a satellite office in Lincoln, and you can get your prenatal and postnatal care at the satellite office. But when it comes time to deliver, you can't deliver at the hospital there. You have to go to Midcoast. But you can ideally still see that same team, and there's a chance that your obstetrician gynecologist or midwife might be on call at Midcoast, and you can deliver there with them.
Further questions? Seeing none, thank you very much. This is very helpful. And so committee, I think people are getting a little hungry. Yeah. So, Lisa, are you able to come back if we break for lunch now? Okay, thank you. So I think it makes sense to break for lunch now and try to come back at 1:30. Yep. All right.
1:30?
Yes. 1:35 maybe, but.
Oh, my God.
No, I'm here, well, I do. I'm very happy to be in my seat. I'm good for the day. I told everybody, don't expect me that I expected that this would be like this.
I
Or you go
think
front.
need to entertain.
Very nice job.
Very good. Well, I'm glad you put a pie on.
Thank you.
Good job, good job. Yeah, I'm sure you'll find that experience. You know what? Rich Evans is still here, right?
Oh, is he?
I think he is. Do you know Rick? Patrick, big black man, Air Force general surgeon. Been at Maine.
Okay.
Air Force. Good guy. Well, he was a member. Anyway, well, thanks. Good to see you.
I promised Dan to get a photo.
Oh, yes, yes. Where is, Jim's over
Jim's
here?
right over there.
Okay.
Look at somebody.
I
promised Dan.
Oh, yeah.
Sure. I'm not the best camera person, but I'll do my best.
You gotta be better than me.
I'm better than it just sitting by itself trying to get it to work. Want like a sideways one or vertical? Okay.
Oh, you want?
No, that's okay.
Okay.
All right, I'll take a few. Ready? We're gonna go sideways.
All right.
Ready? Want to get buttoned. Okay, ready? Okay.
Thanks so much.
If they're not good, I can retake. Take a peek at them. Make sure I did all right. Never been known for my camera skills. Sometimes I put people's skills off for one. Okay, they look all right.
I'll be back for mine.
No, they see your. Yeah, well, I mean, then you go to the hospital and whoever's on is gonna do your.
And their model is exactly what we did for years with keeping Lincoln Hospital able to do prenatal care anyways, coming down to us. Unfortunately, because of liability insurance that had to stop, but we've been doing it for decades. Same exact care.
I just need somebody.
I thought I might have put it in.
Well, thank you.
Yeah.
So welcome back, everyone, to Health Coverage Insurance and Financial Services. Next on our agenda, we're going to be hearing from Northern Light Health. Thank you for your patience and being willing to allow us a chance to get some lunch. Whenever you're ready.
Okay. Good afternoon, Senator Bailey, Representative Matheson, and members of the Health Coverage Insurance and Financial Services Committee. My name is Lisa Harvey McPherson. I'm a registered nurse, and I'm here today at your request, providing information on Northern Light Health labor and delivery care. I thank you for the opportunity to share information about our services. There are no plans for a reduction or closure of labor and delivery units at Northern Light Health. Now, during testimony I provided to this committee earlier this year, I shared information that Northern Light Inland Hospital closed a birthing unit in 2025, followed by closure of the hospital. Loss of birthing providers led to the closure announcement, and more complex challenges closed the hospital. Today, I am pleased to share that for certain regions, like Bangor and Portland, we are developing plans to grow our services and accommodate population demand for care. We have 5 Northern Light hospitals providing dedicated labor and delivery inpatient care. Northern Light Eastern Maine Medical Center in Bangor, Northern Light A.R. Gould Hospital in Presque Isle, Northern Light Mayo Hospital in Dover-Foxcroft, Northern Light Main Coast Hospital in Ellsworth, and Northern Light Mercy Hospital in Portland. Our hospitals provide a comprehensive range of birthing and maternity care services, including prenatal care, labor and delivery care, and postpartum care. Births at each hospital are supported by a labor and delivery clinical team, 24/7 surgical unit care, anesthesia, pediatrics, and emergency transport. The neonatal intensive care unit at Northern Light Eastern Maine Medical Center is a level 3 nursery serving central, northern, and eastern Maine. NICU babies range from 23 weeks gestation, premature, to term infants requiring intensive care. For critical newborns in outlying hospitals, we provide 24-hour neonatal transport service. Our specially trained team of clinicians travel out to the regional hospitals to stabilize the babies and transport the baby back to Bangor for NICU level care. And this was mentioned earlier this morning, Northern Light Eastern Maine Medical Center provides extensive maternal and neonatal education and outreach to rural hospitals, EMS professionals, and other clinicians across the region. From July of 2023 through June of 2026, this outreach reached 1,738 participants and provided approximately 8,538 continuing education and training hours. Our education focuses on maintaining readiness for high-risk, low-volume maternal and neonatal emergencies and includes resuscitation, basic life support, stable training, advanced fetal monitoring, maternal transport case reviews, OB neonatal skill workshops, neonatal emergency care, and maternal and obstetric emergency management for EMS and emergency department clinicians. The training has been interdisciplinary, reaching RNs, providers, EMS personnel, and other healthcare professionals in rural and community hospitals and training sites throughout the region. Participating locations include Waldo County General Hospital, Northern Light Main Coast Hospital, Northern Light Mayo Hospital, Calais Community Hospital, Millinocket Regional Hospital, Reddington Fairview Hospital, Holton Regional Hospital, and Cary Medical Center, amongst others. This regional outreach helps to ensure that clinicians in rural settings have access to specialized perinatal education, skills training, and ongoing professional development to maintain competency and preparedness for obstetric and neonatal emergencies and to support safe maternal and newborn care across Maine. My testimony includes a brief summary of data on babies born at each of the Northern Light Health birthing hospitals over the past 5 years. I've color-coded the data to indicate the number of births after regional birthing unit closure. For Eastern Maine Medical Center, we have 7 labor and 2 triage labor and delivery beds. In 2023, we delivered 1,564 babies, and this year we are projected to deliver 1,613. At A.R. Gould Hospital, we have 4 labor and delivery beds. And what's interesting to note about A.R. Gould, in 2023, we delivered 174 babies, and that was the year that Northern Maine Medical Center closed their labor and delivery unit. In 2024, we delivered an additional 20 babies, up to 194. In 2025, Holton Regional Hospital closed their labor and delivery. So in 2026, we project an all-time high of 240 deliveries, primarily as a result of closing the birthing unit at Holton Regional Hospital. At Mayo Hospital in Dover Foxcroft, we have 6 labor and delivery beds, and in 2023, we delivered 104 babies. In 2025, I noted that Inland Hospital closed. So this year, we are projected to reach a high volume of deliveries in Dover Foxcroft at 168, and we attribute that to the closure of the birthing unit and in Inland Hospital. At Maine Coast Hospital, we have 6 labor and delivery beds, and in 2023, we delivered 203 babies. In 2025, MDI closed their labor and delivery unit. We delivered 319 babies in 2025. This year, we will deliver slightly fewer babies at 314. We believe that mothers in that region had already chosen to receive their care at the hospital in Ellsworth, and that defines a consistent trend in deliveries. At Mercy Hospital, we have 10 labor and delivery beds, but we can flex up to 17. And in 2023, we delivered 673 babies. That is the year that York Hospital closed their delivery unit. So in 2024, we increased to 719. And for 2026, we project 755 babies to be born at Mercy.
Can I just interrupt you?
Yep.
So it looks like at a number of your hospitals, you're kind of at or near that 200 per year number
Yep.
that we keep hearing about.
Yep.
But you've been able to keep those units open. How are you doing that?
Well, that tees up the next part of my testimony.
Okay.
So I'll be talking a little bit about the data and strategies for rural hospitals. In 2023, the Journal of the American Medical Association Health Forum published an original investigation, Obstetric Volume and Severe Maternal Morbidity among Low Risk and Higher Risk Patients Giving Birth at Rural and Urban U.S. Hospitals. And I've attached that article to my testimony. The investigation found that in this cross-sectional study of births in the U.S. rural and urban counties, risk of severe maternal mortality was elevated for low risk and high risk obstetric patients who gave birth in lower volume hospitals in rural counties, compared with similar patients who gave birth at rural hospitals with greater than 460 annual births. So the authors conclude in part that the findings imply the need for tailored quality improvement strategies for lower volume hospitals and rural communities. At Northern Light Health, we have implemented quality improvement strategies at our rural hospitals that include ongoing education, validation, and simulation training for providers and staff, education and competency training for stabilization and care of at-risk newborns prior to transport to a higher level of care, advanced life support obstetrics training, participation in quality collaboratives to benchmark data and support evidence-based practices and quality improvement, quality regulatory reporting programs to monitor perinatal quality and outcome measures, maternal safety bundle requirements that include clinical policies, discharge education, emergency drills and education, and clinical case reviews, team debriefs, and ongoing performance improvement activities. These practices support safe delivery care at our hospitals. Rural obstetric patients often present with higher rates of medical and social comorbidities, including diabetes, substance use disorders, and tobacco use. This all increases the complexity of care. And this creates a paradox in which rural birthing centers manage higher acuity patients with fewer available resources. Today, many rural birthing centers remain operational only through a patchwork of physician coverage arrangements, nurse staffing models, traveling clinicians, and locum tenens providers, which drive costs higher and strain long-term sustainability. As you've heard, a primary challenge in sustaining safe delivery care in low-volume rural hospitals is the availability of OB/GYN physicians and their ability to sustain clinical competencies with a limited number of deliveries. Birthing care is staffed by a team of clinicians, including physicians, mid-level providers, obstetrical nurses, and nurse midwives, with an OB/GYN physician as a clinical leader. According to Simply Hired, a leading job search and recruitment platform, there are estimated 3,000 to 5,000 OB/GYN physician vacancies nationwide. This reflects the persistent national shortage of OB/GYN providers and intense competition for candidates, particularly in rural and underserved communities. As a result, rural hospitals face significant coverage gaps and escalating compensation costs. Similar workforce challenges exist for certified nurse midwives and labor and delivery nurses, where recruitment and retention are nearly as difficult in rural regions of Maine. So as noted, low annual birth volumes in rural hospitals further complicate staffing efforts, as providers often worry about maintaining clinical competency and procedural skills. Consequently, candidates may decline positions or leave rural practices because of the perceived professional risk. At Northern Light Health, we're currently recruiting across all of our hospitals for the following birthing professionals: 5 OB/GYN physicians, 1 nurse practitioner, and 1 certified nurse midwife. The OB/GYN physician position at Northern Light A.R. Gould Hospital has been open for 5 years, demonstrating the significant challenge of hiring in rural Maine. And it also exemplifies the burden on the existing OB/GYN physicians, as the 2 physicians on staff take call every other night for extended periods, supplemented by financially unsustainable locums coverage. Northern Light hospitals, like all of the hospitals in Maine, are not-for-profit, mission-focused organizations. Our services respond to the needs of the population, and the closure of birthing units in Maine reflects the demographics of our population. The 2025 report on Maine's population outlook, published by the Office of the State Economist, documents that Maine's birth rate per 1,000 population has been below the national birth rate for many years. The report also documents that the combination of increasing deaths and decreasing births has led to natural population decline, meaning the state has more deaths than births in recent years. This dynamic has disproportionate impact on rural regions of Maine that have the oldest population density. In my testimony, you will see a graph that documents the birth rate per 1,000 in the US is 10.7, and in 2023, the birth rate per 1,000 in Maine was only 8.3. In conclusion, there's no one solution or easy fix to address access to birthing care in rural areas of Maine. Data demonstrates that severe maternal mortality increases when the volume of deliveries are low. Advancing solutions such as opening more birthing units in rural Maine will jeopardize the safety of moms and babies. Regulations to mandate birthing unit continuation in rural regions with a low volume of birth and a sustained lack of staffing is not a viable pathway forward. Birthing teams of professionals, including OB/GYN physicians, specially trained family practice physicians, and nurse midwives, will all still have maternal mortality risks in the care they provide due to the low volume of births. Identifying a pathway forward needs to involve many stakeholders: hospitals, clinicians, EMS providers, state government, legislators, patient advocates, and payers, including Maine Care. Each has a role and a responsibility for safe birth and care in Maine. And Maine also has a unique opportunity over the next few years to prioritize rural health transformation project funding to invest in stakeholder recommendations to address rural birthing care. So I thank you for the opportunity to provide comments today, and I welcome any questions that you have.
Thank you. So I didn't hear an answer to my question, so maybe you could be
Yeah.
a little more specific. Remember, I'm a lawyer, so need to bring it down to this level. That, you know, you have a number of hospitals where you have kept your unit open that is at or just around that 200 births per year mark. So how are you doing that? What are you doing to be able to do that? You know, specifically because you're making it work, which thank you.
Yeah.
And then the second part of my question would be, and what more do you need in order to continue to do that?
The quality programs that we've put in place support the safety of the care that we provide in these low volume birthing units.
So give me some examples, please.
So-
I don't know what that means.
Yeah, so when the clinicians have a low volume of births and they need to maintain their skills, simulation is a big part of how we support their skill maintenance, as well as, quite frankly, the support they receive from Northern Light Eastern Maine Medical Center, coming out to rural hospitals and rural communities with their highly skilled clinicians working with the rural providers on training and skill maintenance. That's training and skill maintenance. Then the other part, as you've heard about today, is staffing. And I would say that the region of Maine that has the greatest difficulty within our footprint for staffing is Aroostook County. And that's why we have been trying to recruit an OBGYN for 5 years. Recruiting into Aroostook County, is Dr. Jarvis still here? If Dr. Jarvis would hear, I would thank him for his commitment to train physicians in rural communities. That ultimately will be how we increase the number of physicians in rural communities. But in Aroostook County, we also have a mix of physicians who work under Conrad visas, H-1 visas, and the visa challenge that we have currently in this country does impact some of our ability to recruit foreign docs. We also have, it's as much about the nurse midwives and the registered nurses. And what we see in Aroostook County is a phenomenal partnership with the nursing programs and the hospitals and providers. So the nurses who grew up in Aroostook County are trained in Aroostook County. Sometimes they may be trained somewhere else in Maine and return to Aroostook County and stay in Aroostook County. The nurses who work in the OB unit itself, we have 100% retention rate for the nurses who care for the babies. And we have slightly over a 10% turnover rate for the nurses who work in labor and delivery. So when they have that commitment to the communities they're caring for, and that's a specialty within nursing and medicine, that's what they want to do and they tend to stay. But that's our highest risk environment, I believe, is Aroostook County.
Thank you. Other questions? Representative Chimino.
Thank you, Madam Chair. Hi, Lisa. You gave a list of the number of births that were projected for 2026. Do you have anything on mortality rates for those individual hospitals in 2025?
I would have to get that for you.
Okay, that'd be
Yeah, I can do
appreciated.
that. Yeah.
Thank you.
Further questions? Representative Musrattian.
Thank you, Madam Chair. I'm looking at the paragraph where you talked about AR Gould.
Yep.
And that you have an GYN physician position that's been open for 5 years.
Yep.
And you have 2 others.
Yep.
Are they nearing retirement? I mean, it would seem to me that even though you are having increasing births, I'm
Yep.
just wondering what your plan is, because it would seem to me that
Yep.
increasing births, that maybe you might have something in mind and how you're going to recruit somebody.
I did not think to ask the age of the 2 OBGYN docs in Aroostook County. I can ask them how old they are. But what was interesting, when I'm not here with all of you, I spent time at our footprint. And within the past 10 days, I spent time at AR Gould in the county. And I intentionally went to the labor and delivery unit because I wanted to meet the staff and see the care that was provided. And during that visit, I learned that the vast majority of the births are with nurse midwives. Now, you have to have
Okay.
OBGYN coverage, but in that area, the nurse midwives deliver most of the babies.
Okay, so does that mean though that they're kind of identifying the women who may be higher risk and transferring their
The-
care to other hospitals before they deliver, or saying, okay,
Yes.
we think you're gonna have a problem,
Yes.
so maybe you need to go stay down close to this
Eastern
hospital?
Maine.
Yeah.
Yes, similar to what was described. The
Okay,
higher risk
so
moms would go to
That's what
Eastern
you're
Maine.
doing. You're managing the system, but
Mhm.
it would seem to me that with the position that's open, unless the births significantly increase and you find a way to recruit somebody there. Physicians seem to be retiring earlier. I understand
Yeah.
that because of the stress that they're under and the difficulty it is
Yeah.
to practice in this environment
Yeah.
that we're in currently. So I'm just thinking that it looks like you're on the upswing, but I would say that you're just as much on the edge
We are on the
as
edge.
everybody.
And that call schedule for the 2 OBGYNs, that's why we bring in locums doctors in Aroostook County to help give some relief in that call schedule.
Yeah, it just would seem to me that
Yeah.
that's not a sustainable model right there. What's
That-
going
that's
on
the
there
highest
Gould
risk
right now.
environment. But I want to emphasize, there are no plans to close any birthing unit. at
Excellent. I
Northern
mean,
Light.
I'm happy to
Yeah.
hear that. I just think that we need
Yep.
to look at, if we're going to look at this as a
Mhm.
state, we need to look at
Yep.
what's on the edge and what's not.
Yes, and we do need to return to state health planning. And I know that's a conversation that we had earlier this year with this committee. It was referred to HHS. It was probably at a time where everyone was winding up their work. It didn't move forward. But that needs to be a policy priority, returning to state health planning.
Representative Olson.
Thank you, Madam Chair. I mean, you know, when you're looking at the ones that have the low numbers
Mhm.
right now, you're talking about doing simulations and whatnot. Have you looked at all about rotating them down to your high output areas for a while to try and keep up some of that? You're looking there,
Yeah.
you know, if I look at that, you're looking at about 14
Yeah.
per week births there. So if you were to rotate some down there for a while, that will give them exposure there to come back and do some swapping that way.
Yeah, so I am certain that we have done some of that, but our credentialing structure is a bit different than what was described for Maine Health. When you're credentialed at a Northern Light Health hospital, you are only credentialed at that hospital. So if a provider wanted to go to Eastern Maine Medical Center, for example, that they would have to be credentialed there. If they wanted to go to Mercy, that's a third credential, and we're working to resolve that. But that administrative burden does exist for us.
Is that a Northern Light issue or is that a state issue?
That's a Northern Light issue, and we have plans to address that. Yes.
Yeah. Representative Clutie.
Thank you, Madam Chair. Thanks, Lisa. When women that are sort of identified as higher risk
Mhm.
pregnancies are referred to other facilities, is there housing or places for them to stay when they're transferring down for the last few weeks of their
So
pregnancy?
the higher risk moms would be referred to Eastern Maine Medical Center. And Eastern Maine Medical Center is unique in that they have an inn that's attached to the hospital, the Riverside Inn. So a lot of families, for a variety of reasons, it might be oncology, it might be surgery, it might be delivery. The inn is attached to the hospital and a lot of families choose to stay there.
And just as a quick follow-up, does insurance cover that?
No, because there's not a medical component to the inn. We've been asked about that and we've looked at that in the past, but there's not a medical, it's housing, it's custodial.
Right. I'd be curious to know if in advance of next legislative
Mhm.
session, if there's something that this committee can do to help, create legislation that says if you are in a low, in an area where you need a higher level of care for your delivery for X
Mhm.
amount of time, you could, it would just be helpful if you would
Mhm.
think about that and provide that to us for
Mhm.
something to consider if it would be helpful for your
Yep.
patients.
Glad to.
Representative Flynn.
Thank you, Madam Chair. Lisa, great seeing you again.
Thank you.
Quick question, follow up to what you had said on the percentage of deliveries at Gould that you discovered that the vast majority, or seems a percentage of increase of the midwives has increased. What percentage of the total are midwives?
Okay.
Approximate. And then how does that compare industry-wide? And then how would that compare to the historical data at Gould?
Okay. I don't have the industry standard, and I'll just talk about full-time clinicians. So we have across our health system, 38 full-time clinicians. And of that, 3, 4, 5, 9, 13 are certified nurse midwives.
So at Gould, you had said you were surprised by the number of,
Yep.
what percentage of Gould, how many,
Yep.
what percentage are midwives?
Yep, at AR Gould, they have 3 certified nurse midwives that are full-time, 2 full-time OBGYN physicians. They have 1 per diem nurse midwife that works occasionally with the shifts that he or she wants to accept, and 2 per diem OBGYN physicians that once again accept shifts based on their preference.
Okay, thank you.
Further questions? Representative Arford?
Just following up on my good colleague to the right, Representative Clucci. What do you, I know in Portland, they have Ronald McDonald House, which
Mhm.
provides either free or extremely low cost lodging for families of children
Mhm.
that are staying at the hospital for treatment. Do you provide any housing? Is there anything like that in
There's a
Bangor?
Ronald McDonald House in Bangor near Eastern Maine Medical Center.
And do you know how many people they can house annually?
No, but I could find out for you.
Well, I don't want,
Yeah.
I was just curious if if it would be worth pursuing some way of engaging the business community like Ronald
Mhm.
McDonald has in stepping forward to provide housing, more
Mhm.
housing for people that wanted to, that was related to their hospital care.
Yeah, I think I really believe we need a multi-stakeholder group.
Okay.
And, bringing in a housing partner into that discussion isn't on my list, but I think that would be a good addition.
Right, and so this is actually my question, much more pertinent to what we're here to talk about today. We've heard a lot about mortality rates
Mhm.
and quality of care, and you've talked about what you're doing to improve,
Mhm.
to lower one and improve the other.
Mhm.
And so my question is, have you explored a model where, when you're working to accomplish both, improve the quality of
Mhm.
care, reduce the mortality rate, and also provide OBGYN care,
Mhm.
including birthing services in your rural hospitals that are at risk of closing? Do you ever rotate your treatment teams? And let me just finish my
Yeah.
question,
Yep.
so that if you, just for instance, if you were looking to ensure that every provider
Yeah.
was guaranteed 200 births a year, live births a year, then
Yeah.
you would have a way of rotating the teams so that they spent maybe 2 days in an underserved area, and then they're back to their community that they've spent most of their time. But because you're rotating everybody, you would actually get adequate coverage for the
Yeah.
rural hospital if every provider team
Yeah.
spent 2 or 3 days there a
Yeah.
week. I mean, have you explored any
So-
models like that?
Rotating specialists works when you have a controlled, predictable schedule. So if you have a specialist that podiatry and goes to another hospital and does 5 podiatry procedures, they're all scheduled, the OR scheduled, they're there for the day and they leave. OB is different because those typically are not controlled, scheduled, time event assured births. So if you have one rotating team and we have 5 birthing hospitals, are you assured you've always picked the right one? And if we have a number of events going on at another rural hospital, you may have scheduled thinking Lisa's going into birth delivery on Thursday, but 3 women at a different hospital are giving birth and I'm running late. So it does not lend itself well to that model if you're only dependent on that rural team kind of moving around. You have to have the core. You have to have the core there for 24/7 to manage every potential delivery and every potential complication. And then if you have traveling supplemental staff, you may not be using them efficiently.
Representative Moyer.
Thank you, Madam Chair. Thank you, Lisa. I asked this question earlier. How does Northern Light treat family practitioners with OB or cesarean skills?
Interestingly, at Northern Light Mayo Hospital in Dover Foxcroft, it's a specially trained family practice doc that delivers most of the babies. Clearly, the OBGYN leads the team, but at that location, it's a family practice doc. I believe it's around the availability of the clinicians that want to work in these rural regions. It's not a credentialing issue. It's not a licensing issue. It's really more around availability of workforce.
Thank you.
Okay. Further questions? Seeing none,
Okay,
thank you
thank
very
you.
much. It's very helpful. All right, Colleen, did you want to go up?
Thank you. I'll try to go very quickly, but I just wanted to orient you to some of the materials that I provided to you online earlier and provided in hard copy and highlight a couple of the documents primarily. I will say you've had a number of folks that have submitted written testimony prior to, or written comment prior to today's public comment period. Your packet includes all of the written comments that were emailed to me as of 8 a.m. this morning. There have been a number of additional emails that have come through this today during the course of the meeting that our administrative staff hasn't had a chance to copy. So as soon as the meeting is over, I'll be scanning those, putting them together for the committee members and sending them off to you. And as additional, I think the committee is open to continuing to accept written comment. So as additional written comment comes in, if I'll continue to share that with the committee. For folks who are listening or if are in the audience, all of the materials from today's meeting should be posted tomorrow because we had some handouts from the department presenters earlier that may not have had enough copies to reach everybody. So we'll put the whole packet together that will include both the written comments submitted, you have in hard copy here and any additional written comments that you have. But just real quickly, there are a couple of things in your packet. The testimony is on white. It's at the back of your packet. The salmon is just a copy of the recent legislation that the committee is familiar with related to the notice provision about labor and delivery unit closures or changes in the levels of maternity services. And Mr. Monteo referenced this in his presentation, but this is a copy of that whole public law. In response to some of the committee's questions about licensing, and some of that was alluded to earlier, on yellow is some information provided by the Department of Professional and Financial Regulation related to licensed professionals that have within their scope of practice maternity health care services. And if you have any additional questions, representatives of the licensing boards are here. Tim Terranova is here from the Board of Licensure and Medicine. I believe Amanda Boulay is here from the State Board of Nursing. And Penny Valancourt is here and can speak to the licensing that's done by the Board of Complementary Healthcare Providers. But if you look at, just to orient your packet, the Board of Complementary Healthcare Providers licenses certified midwives and certified professional midwives. And Maine is one of a handful of states that recognize sort of non-nurse midwives as a licensing category. And those are these two types of license categories. Certified midwife you'll see in page 2, is an individual. There's one currently actively licensed as a certified midwife. Their education is on par with the education of a certified nurse midwife, and certified nurse midwives are licensed through the Board of Nursing, but they are required both in their educational requirements and their certification to essentially sort of complete a graduate program in midwifery that's accredited, but there's an accreditation commission, and pass a national exam that, as I understand it, is on par with the exam that a certified nurse midwife takes. Maine also, as I mentioned, is one of a handful of states that recognizes sort of non-nurse midwives, and those are the certified professional midwife category. And their statistical data shows that there are 44 currently actively licensed certified professional midwives in Maine. 33 of them have Maine addresses, and so they sort of identified that for you. And they are required to complete a formal midwifery training program and also be certified, but it's a different type of certification and educational requirements that are for certified midwives. I think most of the discussion that you heard earlier about the use of midwives in a hospital-based setting, my understanding is they're referring to certified nurse midwives. So there are some distinctions, but if you look at page, let me flip there a little bit out of order, but if you look at the last pages of the packet, in comparison, there are 132 active licensees currently in Maine that have the certified nurse midwife designation. And certified nurse midwives are part of that active advanced practice registered nurse category, and there are a number of individual kind of categories within the APRNs, but they are all graduate level nurses that then go and get additional training to either be certified as a nurse practitioner, they can be certified as a nurse midwife, the State Board of Nursing recognizes certified registered nurse anesthetists and clinical nurse specialists. And you'll see in terms of the licensing data within that category, certified nurse midwives, I think, are more actively part of the labor and delivery process, but family nurse practitioners, women health practitioners, may have within their training and scope of practice the ability to provide certain levels of maternity health care services. So that just sort of kind of highlights for you some of the differences. And then with regard to the licensing of physicians, I think the fact sheet highlights licensees currently that designate as their specialty OBGYN. And that's on page, I think it's on page 4. They're not all numbered, unfortunately. I forgot to do that. But there are 306 active licensees, allopathic physicians that identify OBGYN as a specialty. 166 of them use a Maine address. Osteopathic physicians, 77 active licenses and 43 with a Maine address. So a total of 383 active licensees, but 209 specifically identify a Maine address. And they also note that, you're licensed as a physician and you get that qualification, but then you additionally can have within your scope of practice the specialties like OBGYN or family practice. Those are the two primary ones that would be involved in maternal health services. And you talked about, or you heard about family physicians that have particular training in OBGYN training particular, and then they can go further and have additional training in providing C-sections. The Board of Licensing really doesn't have any role in when it moves from licensing to the specialty side of things. But they sort of did want to give you sort of level set as to how many are currently licensed in the state, because I think that was something you were interested in. And they note, the training that is received to be initially licensed. There are additional requirements, I think, to maintain board certification, exams and the like. But also highlighted some of the issues that were talked about before in terms of why factors that might impact the difficulties that labor and delivery units are having, like liability concerns, on-call duties, work-life balance, some of those things that were highlighted for you. So I wanted to point that out to you. As I said, if you have any particular questions, the board members are here. And then lastly, I did share with you previously a report that was recently done by the March of Dimes. They've been doing a report sort of annually about maternity health services and identifying sort of the idea of maternity care deserts across the United States. So as I think you heard, this is not a problem that's unique to Maine. But, and if you look at the report, it sort of highlights a number of sort of the data that they've gathered and some of the studies that have been noted, but also highlights some potential policy recommendations as you continue these conversations and identify a number of areas where policymakers may be able to take some steps to expand services. One of the areas that is highlighted is providing additional opportunities for midwives. They sort of highlight Maine as one state that has adopted what they have identified as 5 supportive midwifery policies. And I think, and they note that Maine is one of the states that expands, has licensure for sort of the non-nurse midwives. Maine also has enacted legislation that recognizes certified nurse midwives for the purposes of insurance reimbursement at, specifically providing coverage for services that a certified nurse midwife would be providing within their scope of practice must be reimbursed under health insurance. We also have state laws that provide Medicaid, main care reimbursement for certified nurse midwives as well. So there are some differences in how these policies may line up with and other states, how they may treat certified nurse midwives versus sort of, I guess I'll call them non-nurse midwives. But that's something that you may want to take a look at. Increasing access to doula services is something that was highlighted in this report, and the DHHS presentation gave you some sense of some of the efforts that they are moving forward with as part of their program to expand or provide coverage of doula services under Maine Care. And they sort of highlight some approaches that other states have taken, which may be of interest to you. One thing that was noted this morning and is also noted in this report is providing increased opportunities for birthing centers that specialize in labor and delivery services. That's something that's identified here. They do highlight Maine, the LD 2189 in terms of the notice law that was just provided. There are some other states that have taken sort of more made more financial investments, I would say, in addressing the impact of hospital closures. California is a state that recently enacted legislation to provide financial incentives to hospitals to establish or maintain what they call standby perinatal services in rural areas. That's a significant financial investment that would be provided, but it would provide payments to hospitals to provide these services and maintain them. They also highlight some efforts that have been addressed in Oregon and Washington with regard to those efforts. They highlight health insurance coverage again and Maine Care coverage and what states may do to expand in that area, and recognizing all of the scope of access to prenatal care services, and then finally talk about digital technology and mobile health services. And I think that was something that was highlighted as something which will be a part of both the Transforming Maternal Health model, but also the Rural Health Transformation Program. So just to kind of give you some sense of what other states are looking at as they tackle similar issues, I guess I would say. And I'm happy to answer any questions or provide more detailed information about some of this stuff, but it kind of lays it out in a nice way, identifies the categories and highlights some states.
Thank you, Colleen. Representative Flynn.
Thank you, Madam Chair. Colleen, thank you. Just on page 4. Why, I'm just confused. Why would we have active licenses, but they don't have a main address? What's that look like?
Well, there could be, folks who maintain a license that, we do have an recognized interstate licensing compacts for both nursing and medicine. So they could be work in another state, but have a license to, to be in Maine, but they're, they live somewhere else. So that's part of it.
So the real number of physicians practicing within the state
Could
would be
be.
those with main
Might be that
addresses.
focus on the main
Thank
address.
you.
Yeah, it doesn't mean that all of them are actually practicing. It just means they have an active license too. So they could be retired, they could be per diem, they might not be all employed full-time as well. This is just a snapshot in time of the license that they have.
Further questions, Representative Foley?
Yeah, Colleen, this may be a silly question, but what's the difference between a doula and a midwife? And do we that's well before my time, I think. But are they? After my time.
I was just gonna say,
Whatever.
yeah.
Yeah,
it's-
my age is showing.
Right.
But are they licensed as well? I didn't see any statistics where they licensed, so.
Typically, they're not licensed in Maine. They're not a recognized licensed category, similar to what I described, the certified professional midwife, which is now recognized and has some training. My understanding is doulas are sort of non-clinical providers, non-clinical professionals. They do have some training, but they provide, as I understand it, the sort of side-by-side support, whether it be emotional support, physical support, educational support before, during, and after childbirth. So they can attend to someone at a home birth, and sometimes folks will have a doula that will accompany them to a hospital birth as well, but they're typically hired separately by the individual person. And this report highlights some states that have taken steps to recognize them for reimbursement purposes under the Maine Care program. And I think that's something that DHHS identified as something Maine is interested in doing, and is on track to recognize their services. I think there has been some legislation introduced this past session. Yeah. But I think because it was on track to move, right? But there has been legislation introduced to recognize them. We haven't had any legislation introduced to license them. But there has been legislation introduced to recognize them as a reimbursable service under Maine Care. And I think this report sort of identifies that some states are looking into that as well. Sort of an additional member of a team. You talked a lot about the team-based approach, but additional member of the
term that
term.
I have just recently come aware of.
Yep. Yeah, I think they're becoming more popular than they have been, but I think they're go way back. Like midwives as well in terms of
What's old
assisting
is
women.
new. Exactly. Further questions, Representative Clucci?
Thank you, Madam Chair. Colleen, I'm sorry, I haven't read this report. I read some other ones. Do we actually have any birth centers in Maine?
We do not have any currently, as I understand it, no. And the Dr. Belisle, I think, mentioned that earlier. We did previously have some licensed freestanding birth centers, but I believe Maine does not have any more. It doesn't have any at this time. And one of the things when you look at some of the testimony that I was able to share with you electronically and contains a lot of hyperlinks to different reports. And the one report that was mentioned that Dr. Dora Mills did in the Maine policy review does have a chart that sort of shows where births have been occurring and includes freestanding birth centers as a category and shows like there were a few in previous years, but none recently.
Okay, because I was gonna say, I thought I remembered
Yep.
seeing it somewhere, but
Yep.
then
I
it
think
didn't
it's
seem like it was populated.
exactly.
Okay.
I think that's a recognition that there's an opportunity for them, I think, there may be this report highlights maybe the current barriers there might be statutorily in some states to encouraging them or incentivizing them. I don't know if there are the reason why freestanding birth centers are no longer operating in Maine is a licensing issue or other factors contributed to that. But that particular report includes that chart and it highlights, I think there are 3 or 4 or 5 maybe over, and it looks back like maybe a 5-year period that shows some that had one. Topsom had one, for instance, no longer does, but.
Yeah, the March of Dimes report shows some births at a birth center in Maine in 2024.
Yeah.
Not a big amount, but.
Right.
So,
I think that's right. But I think in most recent year, 2025, I think it showed 0. So I think it's
so as
actually,
recently as 24, there were some.
yeah. And so let me see, because I think it might be in one of this chart might be in one of the packets that you have. If I can pull it up, but it might not be, might have just been a hyperlink within, but I'll definitely share that with you to highlight it.
Yeah.
Representative Clucci.
Thank you. I was just trying to understand, so home birth is categorized differently from birth center.
Yep, and I think the most recent year in that policy review article, I think had about 300 home births or between 300 and 400 home births in the most recent year, but none in a freestanding birth center.
And do we know, is it only the non-nurse midwives that are doing the home births, or is it some combination of?
Certified nurse
Yeah,
midwives?
or-
That I
or-
don't,
yeah.
that I don't know.
That might be the one that's licensed, actively licensed.
Yeah, I'm not sure. I think most home births would, I'm just assuming most home births in Maine would be done with certified professional midwives. And a certified nurse midwife would be assisting in the hospital-based births.
Further questions for Colleen?
Just have. Yep. This is not a question, it's a comment. Sorry.
Comment away.
But I forever look at these stats, which are very helpful. And I always say, why don't we know if they're practicing? So I'm just gonna put that out there. Why don't we know that they're where they're practicing? And who is and who isn't? And where are they practicing?
I think the committee has sent a letter to the department asking them to look into some of those issues for all of their licensing boards, because that issue has come up as to how they can expand the data gathering or add it to their, licensing applications. You've talked a lot about that, but yeah.
Yeah.
Hopefully maybe that's in
Does the
the work.
department have an update on that?
Do you want to come up?
Just wanted to know if there was an update. If there's no update, then no. Okay.
Go.
Thank you.
All right, further questions? Seeing none, then thank you. I think we probably need a moment to put the podium back up. I think that makes sense for people to.
I just wanted to ask people.
I have this.
Yes.
So if anyone in the audience, Representative Clucci is just wondering if anyone has any information as to why we don't have birth centers anymore in Maine. We do. Okay, could someone come forward and share what you know?
Oh, that's nice.
So we have some birth centers, but none of them are licensed birth centers. I'm sorry? There's no path. Okay.
There's no path.
I have the library facility here on my computer. I'm trying to get to her soon.
Okay, thank you.
Thank you.
So there's mixed information as to whether we have birth centers or not, and how many.
Yeah. If it's a license.
Okay. If people could just share the information with either Colleen or Edna, and it'll get to the committee members. Okay. So we're now going to open up you had to open that can of worms. Thank you, Representative Clucci. We're going to open up for public comment. We did have sign up sheets. Oh, there's some more people.
Well, just James Mile is the only, these are the remote people,
Okay,
if they're still on. We can get to them whenever. I told them they'd probably be.
okay, thank you. And are there any more signups? There might be a few more. Okay, well, we'll just get started. I'll call your name. If you could come forward, you will have 3 minutes and just remain up there in case committee members have questions. Thank you. So the first person I have is Nigel Calder. Yep, please come forward. Hi. Oh, yeah. Thank you, Senator.
Thank you. I haven't done this before, so you'll have to excuse me if I'm a little clumsy. I'm Nigel Calder. I live in Newcastle. I'm co-chair of Lincoln County Indivisible. We have over 1,200 supporters in the county. We're not medical experts, but we do know a fair thing about community engagement, and I'm going to speak to that. One of the things that makes Maine so special is this sense of community. It's why my wife and I moved here 40 years ago to raise our children. And Miles Hospital embodies this. The land was donated. Volunteers staff the thrift shop and organize an annual sale to support the hospital. You're greeted by volunteers whenever you go to the hospital. Volunteers come to your room when you're in the hospital to see if there's anything they can help with that is not being provided by the hospital. From the very first public listening exercise in Boothbay and Damariscotta back in June, I believe, our LCI supporters have become increasingly concerned that Maine Health is not acting in good faith. And I recognize that's a difficult thing to say today, because these are some of our neighbors actually, and we know each other. Maine Health has been window dressing and a decision that was made prior to engaging in the public outreach process. So LCI decided to support the Maine Delivers Action campaign. In just weeks, this group of young women built a movement with statewide and even national resonance. They're stunningly talented. They have experts in healthcare and have drawn in numerous other experts. But every time the Maine Delivers Action campaign team has challenged Maine Health's latest rationale for the closure of the Labor and Delivery Department, the goalposts have shifted. And this has been a process that's been going on for a couple of months. Now, all of you on this committee are citizen legislators. We don't pay you nearly enough for what you do. You're here because you believe in the state. You're here today volunteering your time when the legislature is on recess because, again, you believe in what you're doing. And this is what we do in Maine. And our feeling is that the Maine Health culture has slipped to the point where it's not really engaging with the Maine culture. You here in this room, from our perspective, are the last remaining bulwark between a corporate-driven closure decision and the community itself and the community of young people that have been organizing against this closure. I don't know how you can do it, but I have a hunch that you can find a way to delay this decision. And that's all we're asking of you, that you delay the closure and that you also implement a moratorium on additional birthing center closures in Maine so that we all have time to study this and go through the public engagement process that we were promised and which we have not had. And the Maine Delivers Action campaign has actually raised money to hire outside consultants to help with this process. So we have experts, we have support, we have money, we just need time. And we're asking you to find a way to provide that time. So thank you very much for listening to me. And I'd be happy to take any
3
questions.
minutes exactly.
I practiced it.
You did. Well, you
I was 3 seconds over in my practice.
You did perfect. Questions from committee members? Seeing none, thank you very much.
Thank you very much. Thank you.
Next up is Karen Kleinkopf. Was I even close?
Yeah. Dear Senator Bailey, Representative Matheson, and honorable members of the Advisory Council on Affordable Healthcare. Thank you for the opportunity to address your committee. My name is Karen Kleinkopf, and I'm a resident of Damariscotta. I'm here on behalf of all women and children in Lincoln County. I'm asking you to pause the proposed closure through a legislative moratorium for Maine Health Lincoln Hospital labor and delivery while the committee and relevant state agencies fully review the consequences of the proposed closure. I can speak from my personal experiences. I am a mother of 3 daughters who are all delivered at Miles Hospital in 1999, 2000, and 2003. My family experienced firsthand the quality and compassion of their professional staff. I do not want to imagine this community without labor and delivery at Lincoln Hospital, Miles campus. I live 9 minutes from the hospital, and for my first birth, it took me 30 minutes to get there. Each time I had a contraction, I thought I was going through the window shield. Can you imagine sitting in Wiscasset traffic in the summer or winter weather and trying to get to Midcoast Hospital? The first 2 deliveries were uncomplicated water births. Our youngest daughter needed an emergency C-section. Her umbilical cord was wrapped around her body 3 times and her neck twice. If not for the emergency C-section, she might not be here today. Everyone on staff that was needed was woken up. OBGYN doctor, my midwife, nurses, phlebotomists, ultrasound technologist. The room was full of professionals from 12:30 a.m. until our daughter was born at 3:52 a.m. She is healthy, but the outcome could have been very different if we needed to travel to Brunswick. At Miles, my family and I received excellent care from an outstanding staff. I very much want that to remain an option for other families in Lincoln County. Maine Health claims in a full-page advertisement, trusted care close to home. At Maine Health, trusted care means providing our local communities with the highest quality health care and outcomes among the nation's best. Please hold them accountable for the safety and care of women and children. Please keep our labor and delivery open. I urge you to do the right thing. We want this to be a thriving region for generations to come, and that will only be possible if people can safely be born here in Lincoln County. Thank you for the opportunity to share my perspective with your committee. I urge you to place a moratorium. Thank you very much.
Thank you. Questions from committee members? Seeing none, thank you. I next have Dr. Lisa Torgensen. Welcome.
Thank you, committee members, for the opportunity to be heard. My name is Dr. Lisa Torgerson. I'm a family physician speaking on behalf of the Maine Academy of Family Physicians. The Academy strongly supports preserving maternity units in rural Maine hospitals and opposes any further closures. The closure of rural labor and delivery units creates significant barriers to healthcare and increases risk of harm to patients. A recent news story highlighted a case at Holton Regional involving a true obstetric emergency that requires cesarean delivery in under 30 minutes. As of today, Holton's obstetric unit is closed. Patients in that region who need any obstetric care, let alone emergency care, now must travel 1 to 2 hours from their communities. The whole of Aroostook County, as you know, only has 2 remaining birthing units. They are located 12 miles apart from each other. Longer travel times can mean the difference between a good outcome and a tragic one. Between 2014 and 2023, the average travel time from a patient's home to a birthing unit in Maine has doubled due to unit closures. Obstetric emergencies are already occurring across Maine, and they are happening further from hospitals equipped to manage them. Family physicians are an essential part of the solution that is often overlooked. We are trained to provide comprehensive pregnancy care, postpartum, and newborn care. Many family physicians practice obstetrics, and some pursue additional fellowship training for advanced services like C-section. The literature demonstrates equivalent maternal and neonatal outcomes with family physicians when compared to OBGYNs. Not that we don't love our OBGYN colleagues. We also frequently care for families facing higher social and economic barriers, particularly in rural communities. Despite our proven value, family physicians in Maine have often faced barriers when obtaining hospital credentials for obstetrics, and this ultimately hurts our communities. With 2 family medicine OB fellowship programs opening Maine, opening in Maine, we have a tremendous opportunity to strengthen rural maternity care. That opportunity depends on having sustainable maternity units where these physicians can practice. Finally, maternity unit closures threaten access to primary care itself. When communities lose obstetric services, they become less attractive to growing families. They are also less attractive places for family physicians to practice. We have seen this firsthand in Fort Kent, the town of Lincoln, MDI, and Rumford, where I practiced. When Rumford's birthing unit was slated for closure, 5 of the hospital's 6 full-spectrum family physicians, including 3 of us who had trained there, left the community. Maine should be investing in rural maternity care, not allowing it to disappear. We cannot rely on private health organizations, for-profit or not, to protect our access to this care. Time and again, they have shown their interests and priorities diverge from the community's needs. The position of the Maine AFP continues to be in support of how to provide sustainable local maternity care, not whether to do so, and we are here to be part of the solution. Thank you.
Thank you. Questions from committee members, Representative Matheson.
Thank you, Doctor. You had indicated there are barriers for general practitioners to be credentialed for hospitals. Can you clarify?
Speaking on behalf of myself, to give a real world example, not necessarily the AFP, I'm a physician who has experienced barriers to credentialing at our major healthcare conglomerate, our largest center. So they involve numbers of deliveries as well as interpersonal support. There are also some problems with the that I'll address in my personal testimony later. With contracting with specific hospitals too. So I believe a little bit of credentialing overlap and a little bit of contracting as well, among other things.
Can you go into more detail?
Yes. So how best to summarize this?
Just tell us the truth.
Yes. So in order for any of us to provide effective care, we need to see a certain amount. We need to see as much as we can of all of the different complications that present to us. I believe in that. That's extremely important. Sometimes what we experience is not fully reflected in the hospital bureaucratic documentation purposes, and other times it's part of a team-based effort. So to make a very simple example, if I this year have done 100 deliveries, but 50 of them were ultimately ended in assisting my OBGYN colleague with a C-section, was I or was I not part of that? And should the flexibility for credentialing purposes for me to get credit for the work that I've done, should that be, I hesitate to use the word loosened, but should that be changed a bit? So I think it's reflective of numbers. And then I also think it's reflective of the different silos that healthcare organizations can sometimes put physicians into. So if I'm a family doctor, should I only be working in a family medicine office, even if I'm trained to provide services elsewhere? Does the OB department itself, for example, allow for non-OBGYNs to participate fully? I am actually, one of my jobs in Maine is I actually work at A.R. Gould. I was forgotten about in earlier commentary, but I'm a family physician who provides OB there. And I love it, and it's great. And I really experienced no credentialing backgrounds because they took my experience and education and wrapped it into whatever they needed to do to make me work there. I've worked at other places. I work at other places in Maine that have not been as open to that. Does that answer your question?
Representative Boyer.
Thank you, Madam Chair. Sorry, because I asked this question twice. So in your opinion, is it a hospital by hospital decision?
Speaking on behalf of myself, not the Maine AFP, it feels to me to be a hospital by hospital decision.
Thank you.
Further questions? Seeing none, thank you very much.
Thank you.
All right, I next have Dr. Constance Adlin. Sure.
You got it right. Okay. It's about 50-50 that people do.
Yeah.
Senator Bailey, Representative Matheson, and members of the Committee on Health and Coverage, Insurance and Financial Services. My name is Constance Adler. I am a retired physician from Farmington. I provided women's health care there in Farmington for almost 30 years. First off, I want to thank you for your attention to this. I know you're here in August and that stinks, but it's really important and we really thank you for doing this. So I have really two things I want to say. One is there are models of care different from the usual hiring for obstetricians to do a practice. And I know that because I did it for 20 years. In 1992, there were 3 obstetricians in Farmington and one of them was leaving. And so I joined the other 2. I am a family doctor who knew how to do C-sections. And the 3 of us rotated call and provided all the obstetrical care in the community for years. Very successfully. We delivered about 350 babies a year. And it was great. I mean, not only did that confluence improve the stability of the labor and delivery unit, but I had some different skills. I knew how to treat depression, for instance, and chronic disease and pneumonia. So it strengthened the practice to have a family doctor with obstetricians. I will say something that she didn't want to answer, but right now there are doctors, obstetricians in Farmington who refuse to work with family doctors at all. So yes, it's hospital by hospital. But a diversified team makes a huge difference and is very stable. The other thing that I really want to talk to, because it hasn't come up very much today, is postpartum care. 2/3 of the maternal mortality that we have in the state is postpartum. It's not delivery. Deliveries are important. They're very important. But postpartum care is crucially important. That first year of life for the baby it can be a very trying year for a woman. And women die of hypertensive disease, suicide, depression, car accidents, drug overdoses. And I've seen folks come to the office, frankly, hallucinating or really immobilized by sadness. It's a year that requires attention. And if you're an hour away from the person you're supposed to be talking to about that, and you have a new baby, you are not going to get there. It's just too much of a burden. As I was saying, in a Maine winter, an obstetrician an hour away might as well be on the moon. That year is important as we think about models and ways to deliver OB care in the state. We have to think about postpartum care. It needs local care, public health nursing, and systemic outreach if we're going to keep those mothers alive and those babies healthy.
Thank you.
I did, if I have a moment to answer one other question before about maternal mortality, because you were asking about differences. The last numbers that we have, the report came out in 2024. It was the numbers from 2021, and the total number was 9. So the numbers are not big enough that you're going to see a difference with a change in a couple of hospitals. That's not going to be as useful a number as we're tracking these changes. I just wanted to answer your question.
Okay. Further questions? Representative Arford.
Thank you, Madam Chair. Quick question. You mentioned that in Farmington where you were doing the deliveries that you had a team and it worked really well.
Yep.
And that now the OBGYNs would no longer work with the family docs.
Correct.
And can you explain what
No.
that's about?
I can't.
But the OBGYN, okay, so.
It's a
the
different set. I mean,
OBGYNs
all the 3 of us who work together have all
Right.
retired. I'm old.
Right.
Um,
But, so I guess my question is, in that arena, the OBGYN is one that determines who they work with. It's not the hospital, the management of the birthing center that says, this is what our team looks like. They determine that then? They're the ones who are determining that?
I'm not sure I can answer your question.
But you're
Well,
giving
yes,
them-
they have to, you have to be able to work together. A team has to be a team that works together.
Oh, I see what you mean. It's more of a preference.
Yes.
It's not, I literally will not work with you, but if you do get hired, I am not going to work with you.
I don't know.
Okay, thank you.
As I said, I'm not there anymore.
Yeah, thank you.
Representative Clucci.
Thank you, Madam Chair. Just to follow, so is this a private practice or is this a hospital-based practice that you're talking about where the obstetricians are refusing to work with the family physicians?
It's Franklin Community Health Center. Well, it's not Franklin Community Hospital anymore. It's Maine Health at Franklin. So it's a Maine Health Hospital.
Further questions? Representative Olson.
Thank you, Madam Chair. I think you said that you're retired now, right?
I am.
Okay, so
I'm
something we've
almost
been trying
80.
to, something we've been trying to get our heads around a little bit and not getting, the data really doesn't exist, but are you still licensed?
You, after 2 years of not practicing, you cannot have an active license in the state anymore. So, I'm still an MD, that I still have those initials, but I know I do not have an active license.
Okay, good. One of the things that we've been trying to get a handle on is, we're showing X number of people with main addresses,
Oh, yeah.
but we don't know how many are actually practicing.
I can look and see if I'm on that list. I don't know if I'm on that list.
Okay, thank you.
But no, you can't have an active license if you haven't been seeing patients for 2 years.
Okay.
That's
Thank
that's the rules.
Further questions?
I would just say, we're not unicorns, those of us who do OB and do C-sections. We're around and we love what we do.
Thank you. I next have Porter Judson or Portia. Thank you.
Hi, thank you all very much for taking the time to hear us today. I really appreciate it. My name is Portia Judson. I've been a registered nurse for 11 years. I work in the emergency department at Mount Desert Island Hospital, and I'm a member of the Maine State Nurses Association. MDI closed its OB department last year. Our hospital can't serve the needs of our patients without our OB. Earlier this year, I told you about a patient I saw not long after we closed, and this poor woman was so terrified at 23 weeks pregnant that she almost bolted out of my emergency department when she realized we didn't have an OB. Thankfully, she didn't, and we were able to help her out. But one of the things that makes it particularly difficult, all of Maine is rurally challenging. We're on an island with just one road off. So when a patient asks me if we have an OB, and I have to say no, and then I have to say, we can do our best to get you transportation. That's a difficult conversation. Hospitals tell us that closures are necessary because OB staff can't keep their skills current with low birth rates. I know the experienced OB nurses who worked at MDI before our OB closure were better equipped to care for laboring mothers than those of us in the emergency department. Emergency services personnel and ambulances on long trips to hospitals are also not as qualified as OB nurses. A year later, more of our community members know that they can't count on us for OB care. They travel hours for the care they need, or they move away. It's hard to keep healthy rural communities like mine on MDI if people can't have babies near their homes. I'm worried that all the closing labor and delivery units are a harbinger of what's to come. More and more hospitals seem to be dropping essential services due to their lack of profitability. Are hospitals going to erode into serving even fewer community members? Where does that leave rural healthcare? And without healthcare, where does that leave our communities? Being able to count on safe hospital care is a core part of what rural communities like mine need to thrive. The passage of LD 2189 this year was a good first step, and I want to thank you for your work on that bill. Now we need to do more to actually stop these closures. Maine nurses ask you to set up programs to find long-term solutions to support the necessary staffing and skills to let all our rural patients give birth in safe hospital units near their homes. Consider funding programs to help train and place OB staff and help them rotate to facilities in other areas to maintain their competencies. We ask for a moratorium on labor and delivery closures while these programs get set up. And we ask for state funds to support hospitals in genuine financial need to keep their labor and delivery units open. Our rural communities are counting on you.
Thank you very much. Questions from committee members? Seeing none, thank you. I next have Senator Rick Bennett.
Thanks. Senator Bailey, Representative Matheson, honorable members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Senator Rick Bennett of Oxford. I also should disclose that I'm an independent candidate for governor, and which is one of the reasons I came here today, because of what I've been hearing around the state, all across the state, not just in Lincoln County. I really appreciate your convening this hearing on labor and delivery unit closures. We cannot accept a Maine where families lose access to health care when they need it most. Maternity care matters, and it's worth fighting for. The families who are losing this care are being asked to shoulder the burden of a failing system. The strength of a state is measured in many ways. One of them is whether families can count on care when they need it most. The closure of the birthing center at Lincoln Hospital will mark the 12th such closure in the last decade. My heart is with the families affected by the recently announced closure and rural communities around the state who no longer have access to nearby healthcare. You know, our first moments welcoming a new baby should not be filled with fear. These precious moments deserve to be filled with the excitement, love, care, and joy that having a baby brings. My wife Karen and I live in rural Maine. We drove the hour to Portland for our daughter's birth. For our son, we didn't have that luxury. It quickly became clear that we couldn't make the drive, that Nate wasn't going to wait for us to make it to Portland. So thankfully, we did have a hospital nearby, and an OB was able to meet us there, although he did arrive after us. Had we not had maternity services at the local hospital, Nate surely would have been born on the side of I-95. And I heard similar stories when I joined the listening session at Great Salt Bay Community School. I heard from so many young families, their own stories, their fears, their hopes for the future, and the resounding agreement that access to maternity care is essential to Maine families and the future of our state. Now, this committee is looking for solutions, and here are a few thoughts. We've been hearing from providers that staffing is an issue. The legislature had an opportunity this year to fund the Doctors for Maine's Future program right this last session. And it failed to do so, a longstanding program that has been supported in the past. This program has proven to be successful, and the state must continue to support it. The state must also pay providers on time and at the appropriate rate. It's unconscionable that health providers are needing to take out a line of credit while they wait for the state to pay our bills. And it's about making sure the people most affected, the families, the providers, and the communities are heard clearly. Today's hearing is an important step, and I thank you, but it cannot be the last time we engage with these communities. Because once care disappears from a community, the impact is far-reaching. It shapes whether people feel confident staying in the area, raising children there, and putting down roots. Access to maternity care is part of what makes a community livable and sustainable. We deserve that for every part of Maine. The strength of a state, as I said, is measured in many ways. One of them is whether families can count on care when they need it most. Thank you very much for your time.
Thank you. Questions from committee members? Seeing none?
Thank you. And thank you all
joining us.
for coming in August. Appreciate it.
Thank you. I next have Leah Horowitz. Horowitz.
Hurwitz.
Horowitz.
Thank you. Good afternoon, senators, representatives. Thank you so much. Like Nigel, I've never done this before, so I'm a little nervous. My name is Leah Hurwitz, and I live in Round Pond. I'm here today as a mother and as a member of the Miles Delivers Action Coalition. This past November, I gave birth to my daughter Veda at Lincoln Hospital in Damariscotta. She was breech presenting, which is feet down instead of head down. For those of you who don't know, they're supposed to come out head, not feet first. So we had a planned C-section in Portland at Maine Med. I'm one of those high-risk pregnancies that they were talking about. So instead, nearly 24 hours before my scheduled C-section, I went into early labor in the middle of the night. Breech labor moves very quickly. You don't need as much space for feet to come out as you do for a head. So I sat on the toilet and felt a foot coming out of me at my home. My husband got my older daughter in the car and we drove the 10 minutes to Lincoln Hospital. By the time we arrived, Veda was well on her way. My OB, Dr. McCullough, who's here today in orange behind me. She'd been with me from the beginning of my pregnancy. She knew my situation. She looked me in the eye and said, "We're doing this. You're going to have your baby vaginally, and there's no time to think about anything else." I pushed and I pushed and I pushed. Veda's head got stuck because I wasn't fully dilated enough for her head to come through. Dr. McCullough actually had to push her head back inside of me and pull her out, is how she entered the world. At that point, she had lost oxygen for 7 minutes. So she was stuck for 7 minutes and had no oxygen. She had to be resuscitated right there. I think a lot about if I had been 5 minutes later, if I had been forced to bypass Lincoln Hospital and go to Midcoast or Penn Bay. I've had a lot of therapy about that and dealing with that trauma. I wouldn't have a daughter. She wouldn't be alive today if we didn't live that close to my obstetrician, to my OB. We spent the next 15 days in the NICU, an hour and a half from my home, from my husband, from my older daughter, from every person who would have held me together. That distance, that isolation, it carries its own trauma. I also stayed in the Ronald McDonald House. I know we had a question about that as well. We were eventually given the Ronald McDonald House as an option post-birth. So you don't get that before you have the baby, you get that after you have the baby. So I was down there. I also just want to say Maine Health is a publicly funded nonprofit system. That funding comes with an obligation and accountability to the people of this state. The community stood up at a meeting hosted by Maine Health and said, "Do not do this." Representatives sent letters. The governor herself said, "Don't do this." Maine Health board members and leaders made it clear in their own words that our concerns don't change their calculus. Sorry. In my community, we don't have other options. There are no choices for other hospital care. Maine Health owns over 58% of the overall market share in its service regions. When one system holds that much power over whether rural families have a safe place to give birth and answers to no one but itself and its own board, that's not a healthcare system. It's a monopoly operating without oversight. We need regulation. We need Maine Health to be accountable to Mainers, to their patients, to the state of Maine, and we need it now. I'm calling on legislators to demand a stay of all labor and delivery closures, including Lincoln Hospital, while this committee reviews the board's assessment of the closure. Demand the data, ask the questions. That's all. Thank you so much.
Thank you. And you did fine. Yep.
Thank
Just
you.
Stay there for 1 second, just in case. Any questions from committee? Oh, look at this. See?
Yeah.
Representative Clucci.
Thank you, Madam Chair. Thank you so much for sharing that
Thank
story.
you.
I totally appreciate it, and I can see how hard it was to
Thank you.
share all that. I'm genuinely curious, hearing the detailed overview from the Maine Health staff today. Did it make you feel any better? Did it make you change anything? What are you questioning about what you heard? Because that would be,
Yes.
just I'm curious.
I've actually got a chance to meet with Cindy Wade and Dr. Tim Fox on 2 occasions. And my biggest things that I said were an issue were continuity of care, which has been discussed a little bit, and also distance. They haven't answered the question of distance. They gave some numbers on how long the drive is. I heard 23 miles, but that's meaningless. We live in a seasonal area where there's traffic constantly. There's road work on Route 1. My own birth story, it was November, the roads were icy. My husband wasn't going as fast as he could have. I also just remember like the fear in the moment of if I had to make one more decision, if I had to choose, am I going to the emergency room or am I making that drive to my labor and delivery department? I don't have the plan. There's no plan for me. And I think the question of individual plans for each patient is unrealistic. They need to have a plan in place for that distance. So far, what I've heard is first responders are picking up that burden, that I'm going in an ambulance, I'm going in life flight, or I'm driving myself to that hospital. So the distance piece is really the biggest thing. And then again, the continuity of care. They've mentioned that women are going to have their prenatal care here in Lincoln County and then go to Midcoast for their birth and then come back for postnatal care. And we've heard some data that's working really well in Waldo. I don't know, again, that we've been given choice. Women of the Waldo area probably can't get an hour to that facility to see the doctors that they want to see. Not everyone has a full tank of gas and 2 cars and a day to take off work to go do that. For me, at my house, to go to Brunswick every week at the end there would have been financially devastating for my family. So that distance piece is just not working for us. It's not working for the mothers who want to plan. We have members of our group who are pregnant and scared. I think the mothers of Maine and the mothers of this nation are screaming for help. We are screaming for help from anyone who will give it to us because they keep taking things away from us. They keep taking our supports, and we're trying to bring life. We're trying to do the right thing and have health and safe births. We want to do that. We want to have more children. We want to do that. This is not how you get people to have more babies. So they talk a lot about low birthing numbers. And I just think like taking away the birthing unit is not going to make more babies happen. So I just wanted to share my story and why we need to have this close by. The distance, you can't make up the distance with policy and with numbers. And I also just wanted to put a face to kind of all that they've been talking about. We've heard a lot of rhetoric around what my kind of situation would look like. And it's really scary. It's really scary in the moment to have to be making choices that are life or death, not for you, for your baby. It's not me. It wasn't me. It was her that I had to be making these decisions for. And that just comes with a much more heavy burden. And Maine Health should feel that burden. They should be accountable. Veda's life is worth something. It's worth struggling to keep a schedule going. It's worth trying to keep this service available to women. You have to keep trying. You have to keep it. You have to keep the service because we need it.
Thank you. For any further questions, Representative Arthur.
Yeah, I too really want to thank you for coming here to tell us your story.
Thank you.
It's really powerful, and I can tell that it's changed your life, obviously. And it's really hard, I think, for all of us sitting here and listening to testimony. And I have to say, when people testify, I, as a legislator, feel compelled to give them the benefit of the doubt. And unless they give me good reason to question their sincerity, to believe them. And if you've been sitting here today and you've heard that according to the experts and the people who are responsible for the birthing centers, including Lincoln, that they're in this no-win situation where they cannot follow the law themselves.
Right.
Their medical ethics and standards of care, and because of adequate staffing primarily. That's one of the big conundrums. So my question for you, and because you've been through this, and I, by the way, had not as traumatic, but a similar situation, so I get it. If you were given a choice, if it was possible that the laws or the rules changed and Lincoln could stay open, even though they were taking the risk of having to go on diversion, and there would be no liability risk for them, we somehow could fix that. I'm not saying we could, but just let's say we could. And because of the demand from the community and the community saying we're willing to take that risk, would you be willing, going back to that time when you gave birth to, I'm sure what is now a beautiful daughter, would you be willing to continue to go there knowing because of staffing patterns, you might have your situation happen and be put on diversion?
Yeah, and we've actually talked a lot about the diversions because that seems to be their kind of major issue, is that this 4 days of diversions. We actually requested the data of other hospitals and other labor and delivery units. How many days of diversion do they go on? We were denied that data, so perhaps that's something you could request. We have been told that diversion is a tool. It's not this end all be all that's been presented. Me personally, we've been told also that they let patients know. So I would have been told there was a diversion happening. I would have been notified. It wouldn't have changed necessarily what happened. There was another story that came out of a woman who had her baby in the parking lot at Miles, which was not true. She had it in the emergency room department. Like there's been a lot of stories going around about what's happened and what this diversion actually means. Again, we've requested that information. I would like to give you another kind of personal note. When I had Veda and we had to go to Portland for the NICU, I had to be discharged 6 hours after I gave birth because there were no postpartum beds at Maine Med. So I'm assuming Maine Med was on diversion at that moment because there were no beds for me there. So that's kind of my feeling is we've talked a lot about the diversions and the lack of staffing. But diversions because of too many patients happens all the time. Diversions is a tool that hospitals use for a variety of reasons. And again, I'm not an expert in this. They can speak more to that than I can. I don't understand why 4 days of diversion equals 365 days of diversion, because that's what we're getting. That's what we now have is 365 days of diversion. So I would take the 4 any day over 365.
Thank you so much.
Yeah, thank you.
Representative Boyer.
Thank you, Madam Chair. Thank you for being here.
Yes.
Where did you go 6 hours after delivery?
I got in my car and we drove to Portland. I drove myself to Portland, actually. So yeah, it was awful. So yes. Thank you so much. Thank you.
Thank you. I next have Sally Weiss. Oh, there she is. Couldn't see you behind the
hiding.
pillar.
Hello, thanks so much for having me. Senator Bailey, Representative Matheson, members of the Health Coverage Insurance and Financial Services Committee. My name is Sally Weiss, and I'm here on behalf of the Maine Hospital Association. Thank you so much for the opportunity to share our perspective and provide information on our ongoing work on this important issue. At MHA, I personally spend a significant amount of my time trying to understand the many, many layers of this complex issue. Both looking at how do we sustain services where feasible and ways to support hospitals and communities where inpatient delivery is no longer viable. In 2024, MHA convened hospital leaders through the MHA Maternal Health and Access Committee. The committee has developed strategic goals focused on regional partnerships, shared staffing and call coverage, streamlined credentialing, virtual obstetric and neonatal consultation, and rural workforce training. MHA also participates in several main stakeholder groups that bring together hospitals, community providers, and state agencies focused on maternal health, perinatal care, access, and outcomes. We also engage in regional and national discussions with other states facing similar service closures due to declining birth volumes, increasing financial pressures, and workforce shortages. And at this point, the rest of my testimony is really focused on 2 areas that I believe the legislature could be the most impactful, and that's around workforce and payment. But I just want to note that I did actually kind of peruse the submitted written testimony, and there's a lot of really solid, good policy ideas in those documents that, in fact, MHA fully supports and could get behind. And I just want to note that as I've been listening, I feel like there's really 2 public policy issues that need to be addressed. And I think sometimes we're kind of crossing them over. But one is, how do we sustain services in hospitals, communities that currently have services, and we want to maintain them and sustain them and ensure that they're there for those communities? And then the other question is, how do we support communities access care where they no longer have a hospital or a community-based hospital? And so I really think that those are there are things that overlap there, but I do really think they're kind of 2 separate questions. And that is how I have been approaching my work as I've been thinking about, identifying strategies and solutions. And I would just note that, we are very interested in working on this issue and really feel that the best approach is to try to gather a group as suggested by many people prior to me to really dig into what is happening at the state and how we can work together regionally and as a broader coalition to kind of think about what policies we can put in place to support communities and mothers and babies and families. So with that, I'll stop.
All right. Thank you.
Yep.
Questions from committee members? Yep, Representative Foley.
Thank you, and thank you for that presentation. And I would agree with you. It's going to take a concerted effort of all parties involved. But how do we break down the silos that all of the organizations that are in this mix, the hospitals, the doctors, the legislature, the insurance companies, all of these players have their own different thing, and everybody's pointing at everybody else. And that just really, I'm curious how you think is that a legislative mandate, which never really works? Or is that something that everybody's just got to get to a point where the system is so broken on everybody's part that they're willing to sit down and work this thing out?
So I think we're at that point that you just said. I convene a group at the Maine Hospital Association with 12 chiefs of OB, CEOs of major hospitals, hospitals that have lost birthing units or closed birthing units, hospitals that are trying to sustain them. Everyone understands that this can no longer be solved on a individual organizational level or even a community level, that we have to start thinking regionally about how we solve these problems. I think some of them cannot be solved with the legislature. I think some of it's going to be a regional level of organizations that maybe have not previously worked together, coming together and thinking strategically about how do we ensure that everyone has access to care. But I do think there are places where the legislature can get involved and support that work, moving it forward. I think we've talked a little bit today about payment and reimbursement. There are models, primarily with emergency medicine and rural settings, where there is standby payments, basically payments to maintain capacity, minimum staffing levels. You're basically paying a premium to hospitals to maintain a certain level of service no matter what, regardless of the patient demand. California just passed legislation last fall that is piloting a similar model in 2 of their counties for all of their rural hospitals. So I think there are ways that we can look at this. I also believe that we should be looking at teleobstetric consultation and payment for those types of services. How do we create infrastructure with technologies and ensure that not only do the technologies are available for everybody, but also how are we paying for that? How are we ensuring that providers who are on call and answering a teleobstetric call in Portland from someone in Washington County, that service is covered, that there's some reimbursement there for that service to sustain that service. Those are the types of things that I think we need to be really kind of looking at carefully. And no one of these things is going to be the silver bullet. It's many things in many buckets that have to be pushed forward together.
Representative Matheson.
Thank you, Sally.
Yeah.
I haven't had a chance to read all of your information, but I did quickly
Yep.
peruse it, so thank you. I'm
Yep.
looking forward to reading the rest of it. You indicated here, maternity care access report shows that the number of births attended by midwives increased significantly in New Hampshire and Vermont between 2016 and 2024, while Maine experienced little change. And then you cite monthly facility payment for rural emergency hospitals in addition to service-based reimbursement. Is that what you're talking about? Are you indicating that because they were getting a monthly stipend from the
Oh,
states?
I apologize. I
Okay.
may have reordered my.
Okay.
The CMS looking at the rural emergency medicine capacity payments for critical access hospitals, that's under the payment. So if we're looking at different models of ways we can support maintaining capacity in facilities with lower volume. Again, this isn't necessarily just because we pay more, doesn't necessarily fix the workforce issue. It doesn't fix the low volume issue, right? But if we're looking at a variety of different tools we can look at, that is one of them. The certified nurse midwifery is my comment around diversifying our workforce, which is something that we've heard a little bit about today. Last fall, I did publish a pretty comprehensive report on the feasibility of CNM training in Maine. We have no training programs in Maine. We have very few clinical training slots in the state. It has not been an area that we've invested very much into. And that report basically digs into some of the challenges and barriers with training in Maine and also provides very concrete things that we can do as a state to expand CNM training and the profession in the state.
So if I understand you correctly, thank you for
Yeah.
that clarification. Are you indicating that New Hampshire and Vermont between these times did more training? Is that why there was a significant increase?
They've expanded their training. So University of Vermont Health is actually expanding their CNM training. So they've expanded not only the training, but they've changed somewhat those models that we've talked about, diversifying our workforce models and thinking about how do we sustain call, right? How do we build care teams to take care of patients to ensure that you still have the highly specialized folks there for those emergencies, but who's providing kind of that continuity of care in those local communities? Yes, that's the document.
Thank you.
Yeah.
Representative Mastracchio.
Thank you. I just want to clarify, you're talking about certified nurse midwives.
That was the report I did, yes,
Okay,
on
that's-
certified nurse midwives.
And I just wanted to understand, so in the rural hospitals that are getting, for being critical access, hospitals that are getting more money for that, are you suggesting that one of the ways that we could pay more to a hospital just for being ready to be labor and delivery ready?
Yes. Yes.
And you're suggesting that the state should do that?
Well, I know at the federal level, Congress has looked at a couple different bills over the past several years, and they've been kicking around, but not much movement has been made in that area. So I think that's something we could look at in terms of MaineCare, looking at commercial payers even, is really thinking about how are we valuing this service? How are we supporting facilities for incurring costs, regardless of whether or not people come in and because we're a fee-for-service system?
Kind of like an essential programs and services like we do with education. We could do it
Correct.
with EMS. We really
Correct.
haven't applied that model, but we have to decide as a state what's important for everybody.
Right.
And then decide how we're going to fund it and what is the ability of each community to participate in that.
Correct.
I mean, it's not just as simple as it's a huge problem. That's going to take a lot of people sitting down and figuring it out.
Yes, and I think the methodology of which you apply a payment, whether it's a per capita, if you're looking at a catchment area and you're counting the number of women between a certain age per census, and you're doing a per capita or per head rate per year, or if you're doing, I mean, there's lots of ways you could approach this.
Right. And in fact, it's really deciding what are the essential services that as a state that we think
Yep.
are important.
Yes.
And deciding then how are we all going to be, all of us, whether it's a homeless shelter or a labor and delivery service.
Yes.
For every area in Maine. I get it.
Yeah.
I just think that we need to all understand that that is work and sacrifice for everyone, because it's always, in my estimation over the many years, it always boils down to money.
Of course.
And what we're going to spend it on and what we think is important. And
Yep.
that is going to take sacrifice on all sides.
Yes, I agree.
Further questions? Representative Boyer.
Thank you, Madam Chair. Thank you, Sally, for
Yep.
being here. I might be beating a dead horse, but I just wanted to clarify in this point on New Hampshire and Vermont. Is that compared to certified nurse midwives in Vermont and New Hampshire as well?
So that
Like,
came
did-
from the 2026 March of Dimes report, which I understand you all have.
Right.
And in that report, it essentially showed that Maine between 2016 and 2024 had little to no change in the number of births attended by midwives. And in Vermont, in New Hampshire, they went from roughly, I think, 20% to 30 and 35%.
Yeah, and I'm just trying to understand, are we comparing apples to apples? Because what I understand is in Maine, we only are using certified nurse midwives in a hospital setting for delivering babies. So is
Yes.
that the same in New Hampshire and Vermont? I guess is what I'm asking.
So they probably use certified nurse midwives in their hospitals, but they also probably have certified professional midwives in their community as well. Yeah.
Thank you.
Representative Clucci.
Thank you, Madam Chair. Is there data available to help us understand like what types of care at hospitals makes money versus what types of care loses money? Because I think it would be, I mean, that's one of the things I'm struggling with. I mean, I know we have nonprofit hospital systems in Maine. But it's hard to see, Lincoln Hospital's closing in labor and delivery, but yet look at this beautiful new oncology center that we're opening at Lincoln, right? Without being like, that feels bad. And it's, I think if we had more transparency, and maybe it's available in a transparent, and I just don't know where to look, but it would just be helpful for me to have an understanding of like, what are the services that don't make money and therefore are sort of ripe for losing, going away. So that we do have a better understanding of where do our public dollars need to go? Because if we've privatized healthcare in this country, if you can't, that's how you make money. Like people get sick, people get paid, right? And it's, and so it would be really helpful to understand, like, where are those areas so that we can just say, okay, fine. If this is not going to make money anymore, then the state needs to just like straight up pay for this because nobody else is going to pay for it and find ways to maintain it.
So, I mean, I'm sure we can get that information for you, but I think a lot of that will be dependent on the geographic regions that you're looking at, the types of services you're looking at. But I don't have like off the top of my head a list of how hospitals make money. I mean, in all the years that I worked in a hospital setting, it's all the services that you probably know, primary care, behavioral health, some of these services, right? But, and you're right, some of these other services like oncology perhaps do make money, but just because they make money, they're all under one system. Very often, right? Those revenues cover the areas that lose revenues. So it's a complicated question to ask when you're just saying like, well, what are the services that lose money? And those are the services that we need to support. Because I think it really depends on the institution, the services and globally as we talk about services and I wouldn't have that information like right off the top of my head.
I just want to have a sense for like in Maine, where do we best spend our Maine tax dollars? And so, and like, why does oncology make so much more money for a hospital than something else?
I mean, I think some of it is demand for services. I think Dr. Mueller kind of talked about that a little bit. By 2030, over almost 31.6% of Maine's population will be over the age of 65. So the reality is more people live longer. They need more complex care, including oncology services and orthopedics and surgeries and all of that, right? So but I think your question around like, where do we spend taxpayer dollars? I mean, that is the question, what do we value and how do we use our very limited resources, which we have very limited resources, to support services or to create infrastructures and programs that work to ensure that people have safe, quality access to care.
Representative Matheson.
Are there any other services that in the last decade that we've lost 12 of those departments other than maternity? Are there any other hospital services that we've lost 12 of?
I don't know off the top of my head what other services we've lost. I know there's been a lot of primary care consolidation, behavioral health services we've lost.
That's helpful.
Nursing homes,
Yep.
we've lost a lot of nursing homes.
So I think that probably answers a lot of what your question is where we've lost the services. 'Cause
Right.
Thank you. I appreciate that.
Further questions? None. Thank you very much.
Okay, thank you.
I next have Maura, it's either Paige or Rose Richards. Let's see who's right.
Hi, I am not Moira Rose. She had to leave to go pick up her children. So I'm going to be reading her statement on her behalf. So my name is Bailey Romaine, reading this on behalf of Moira Rose Richards. All right, I'm here on behalf of the Miles Delivers Action Coalition, a group working to preserve labor and delivery services at Miles Hospital. Today, you are asking for solutions to rural maternity closures. Research shows they exist, but our experience in Lincoln County has taught us that we cannot figure out how to help Maine Health solve a problem when Maine Health cannot clearly identify what the problem actually is. Every time Maine Health identified a problem, our community tried to help solve it. And every time we did, the explanation changed. First, it was financial. Patients were told finances were a factor. We examined the data. Lincoln Hospital had been operating in the black for years, reporting $8.73 million in operating income in fiscal year 2024. Then Maine Health pivoted to birth volume, saying that the roughly 130 annual deliveries made recruiting OBGYNs difficult. So we identified physicians specifically interested in practicing in a lower volume setting. Then it was staffing, recruitment, and retention. We brought Maine Health interested physicians, CVs, recruitment strategies, and alternative staffing models, including models developed with Maine Health's own clinicians. We even offered to fund an independent assessment. When those solutions were identified, Maine Health cited a financial trade-off. The day before the board vote, Maine Health leadership told us in a meeting with the CEO that labor and delivery, quote, comes with a high price tag, end quote, and described ending deliveries as a way to reinvest resources into other women's health services. Now it is patient safety. After the board voted, Maine Health leadership argued that safety concerns made further delay irresponsible, pointing to 4 diversions in 6 months. But Maine Health's own July 23 white paper said that Lincoln had, quote, no clear or persistent quality or safety concerns, end quote. That contradiction matters. There's a fundamental difference between showing that staffing instability creates safety risks and proving that eliminating the birthing center makes patients safer. Maine Health has demonstrated the former. It has not demonstrated the latter. Sorry, there's more. So if this committee wants to help find solutions to rural maternity closures, start by requiring Maine Health to clearly identify the problem. Then allow us to fund an independent review to assess the stated and unstated issues and possible solutions. The closure is not scheduled until December 18th. There is still time for an independent review. We cannot solve a problem that Maine Health will not clearly define. Until that happens, please pause this closure. Our lives are worth getting this right. Thank you.
Thank you very much. Any questions from committee members? She indicated it was emailed, so I don't know if we have it yet.
Copies in a basket.
There are copies back there. Thank you.
I don't want to take time that's not allowed me, but I also, if I can, just make an additional statement on a personal note that I am 18 weeks pregnant today. I'm a patient at Lincoln Hospital, and as of my last prenatal visit, which was a little over a week ago, there's no plan for my birth. My due date's the end of January, and they were not able to offer me any idea of what my continued care might look like. And I find that to be extremely scary. This is my first pregnancy, and my providers have been incredible. They were, doing everything they could, but they have no plan in place for their patients during this transition.
Thank you. And next I have Dr. Rose Fuchs.
Good afternoon, everyone. Thank you for having us. I am Dr. Rose Fuchs. I'm a board certified family medicine physician. I work in solo private independent practice in Patton, Maine, in the middle of a maternity care desert. And listening to testimony today, I really struggle to see how closing critical access maternity sites for risk reduction helps me when now I have no access. Currently, I'm testifying on behalf of my patients and behalf of the front lines in Aroostook County that we have to travel an hour and a half to get to any source of care from my office. And I have been a physician for 26 years. I've always delivered babies. I do not do C-sections. For the first 13 years, I worked in Georgia, Atlanta, Georgia. We functioned seamlessly as a team of family physicians and obstetricians with no problems. 13 years ago, I moved to Maine, and I truly was astonished at the silos. I encountered a lot of, I would say, politics when trying to get credentialing at the local hospital for obstetrics, and was told that my home technically was too far from the hospital, so don't even bother. And so I didn't fight it. I don't have time for that. I have to take care of patients. And so ironically, I travel further now to do home births than I would have traveled to Holton Regional to help them deliver. And staffing was one of their issues as well, why they closed. There would be others in the area. There's a large team of lay midwives. There's a certified midwife. There is a freestanding birthing center in Bangor that I refer people to when I'm too busy, called Holly number 7, I believe, maybe number 9. And so I am kind of the consult liaison for complicated prenatal care and assisting them with deliveries as well in home births. And we handle way too much currently in home births. I mean, I have personally in Maine delivered twins at home. I have done breech deliveries. I have done numerous vaginal births after cesarean section. Last week, I delivered a premature baby that it was too rapid to get to the hospital. And I had to make the decision, is myself and my nurse and my equipment safer than trying to access care and go en route? And care by the ambulance staff does not even compare to what I can offer. But I am by myself right now, and I am asking for solutions to be made. Critical access maternity care is not an option. If we do not do this, it's not a question of if a death will occur, it's a question of when. And whose family member will it be? This matters a lot to me. I'm driving 6 hours today to come down here for these few minutes to speak my passion. I think if there is a will to solve this problem by all the parties and a passion, it can be solved. I have seen it work in Georgia before. So I think it can be done. And I want to just highlight personal stories of patients who can't be here today with me to say their story, but one of them would have went public on national radio with her story. So last year, just after the closure of Holton Regional, my patient suffered a prolapsed umbilical cord early in labor. Too soon really to her even to have thought to go to a hospital, honestly. And so we accessed emergency transport. I had to fight to have Holton accept us. They were within their 30-day required window of emergency coverage after closure. It was the last day of that window, and they were trying to get us to go to the airport to engage Life Flight to fly to Eastern Maine. And even I fought very hard that Holton should accept us and just do a C-section. And so we did win that battle, but it took 90 minutes from identifying the emergency to the C-section, going to Holton. If I had had to get on Life Flight with that patient, it would have been much longer. That baby would not be alive today, but she's doing well. And I can say before that closure, another patient that I saw prenatally in consult for an Amish midwife experienced a uterine rupture in early labor and was transported to Holton Regional and had emergency surgery transfusions. The infant died, but the mother would surely have died if Holton had not been open then. So these are real people. I could list more. So critical access maternity care is not an option in my mind. Some of the solutions, I think definitely the silos need to come down. There are people in these communities. None of you knew me. I am there delivering babies. I looked at the stats. There's 300 home births in Maine. It's increasing. Why is it increasing? Because we don't have access. Women don't have choices in the county, and they're having to make difficult choices and forcing more risk on me. But I have a passion, so I'm a little willing to take more risk than some of the facilities. But prenatally, even what needs to change is just access to specialists. So when I identify a consult, a recent, not too long ago patient who came to me in the 3rd trimester because the midwife thought something's just wrong. She ended up being pregnant with twins that I diagnosed that day, and she had a blood incompatibility problem that could have destroyed her babies in the womb. And so I tried to access Eastern Maine. It took several faxes, several phone calls. We were given an appointment weeks away because they are busy. They are not keeping up with the volume that's on them now. And it finally took a phone call from me, and I could be pretty tough on the phone, that said, we cannot wait. She's 32 weeks along now. You cannot wait to see her, or these twins will die. And so thankfully they heard me, but that's a lot of time and it's a lot of effort. There should be open communication, not just me to the specialists, but even the midwives in the community to the specialists, licensed or not. They are there, they are practicing, and they're doing a good job actually for the most part. So again, there should be a referral hotline, honestly, that when the county is calling, we're not calling asking for a lollipop and a pat on the back. I am calling with an emergency that exceeds some of those things I just told you I'm handling by myself and a staff of 1. So I'm sorry to be so passionate. That's why I'm still in practice, why I haven't retired early. Of course, I've considered it. But I can't give up. I cannot abandon these people. I think about me in the staff, I am in this gap in this community. What will happen to these women if I left? I'll tell you, it will not be pretty. You would see a lot worse numbers going on because these midwives are accessing me, and I'm trying to access the specialized care for them. It has not been easy. So there needs to be a hotline, more communication, more access for those of us who want to. So prenatal challenges, delivery challenges. I believe that we can solve this problem. I am ever the optimist. I think it just takes a lot of coordination. It's going to take some time. I definitely think they need to stop closures and get the community involved. We had 30 days of notice with Holton Regional closing. There were community meetings, and it just closed without comment, really. Their administration did not even show up at the community meeting. It was very sad to me. If this is a problem, then let's get everybody all hands on deck to solve the problem. So thank you for letting me speak. And my written statement is not what I spoke. I usually speak off the cuff. Sorry.
Thank you. Questions from committee members? Representative Clucci.
Thank you, Madam Chair. I kind of wish I'd asked this earlier of the hospital staff, but part of me is trying to understand is when we talk about we're closing things because of because of safety, right? Is it safety because of lawsuits? Or is it safety because, is it truly safer for somebody to have to go in a hospital or in an ambulance to care rather than get maybe care that's not as great as it's not what we want it to be, right? Maybe we can't deliver the 24 hours on call, all the things, right? That is the sort of gold standard. Is it still safer to just have nothing than to have something, but maybe it's lesser quality? And how do you balance that with the liability insurance and the malpractice insurance? And I'm curious about your malpractice insurance.
I think that absolutely you can't say closing these facilities and using an all or nothing approach. It's too risky if we're low numbers to continue. So let's close it down. Your risk has just exponentially increased, but it won't fall on you. So it's sort of pass the buck and, the CYA, cover your own back end. But somebody's got to step up and say, whether it's legislation to protect liability. But I can say of my patients in the county, they know that. We have a conversation regularly after Holton closed. I had a woman show up and deliver at my office, which is not set up for that. And I transported the baby because I was a little worried about breathing. The mother had multiple medical problems, hypertension, uncontrolled hypothyroidism, all kinds of issues. So I wanted to take the baby in. It honestly was quicker for me to transport in my own vehicle than to call an ambulance in that area. And then I was afraid would Holton turn me down like they almost did the week before with the prolapsed cord. So I went by personal vehicle with the parents in my vehicle. They understood the risk. We're having that conversation. I don't, family medicine traditionally has very low lawsuit rates because we have that relationship. We've made those things clear. Now, obviously, legislation should protect doctors. That's a problem. Protect institutions. Eastern Maine and Maine Health, they can't be taking lawsuits for putting themselves out for people. So yes, there needs to be protection, I'm sure. But in the meantime, how much is a life worth to us? In the meantime, while we're figuring all this out, what's going on in the county? Well, it's very difficult. The midwives asked me, what's our plan? I said, I don't know. It's going to have to be case by case. I'll figure out the plan. The same as the lady who just talked about her physician saying, what's the plan?
Further questions? Representative Arford.
Thank you, Madam Chair. So I just feel compelled to thank you for your service. I'm old enough and I know enough to understand how truly profound it is what service you're offering to your community, and you have been for many, many years. And so my question for you is this. I'm assuming when you're gone, the service, there's no one on the horizon to step up and take your place at this point in time. So do you have, the reason I'm asking this is I went on a legislative tour a year ago and we talked to a family physician, and it was either down, I can't remember, it was down east, but, or up or higher up north, but he was about to retire and he said, there's no one, I haven't yet retired. He said, I would have many years ago, but I haven't because there's no one to replace me. And I'm just wondering, do you have a plan, or is there any possible plan to replace you when you're gone?
That is a question. There's another private doc, Dr. Reineck, who's I think close to 80, and he's not retired yet either because of the same issue. We collaborate a lot because we're both independent. I would say that the key to that is bringing the people in training up to rural Maine to ignite their fire about how wonderful and rewarding it is. And that is what ignited my fire to do this years ago when I was in training. And there's barriers there that could be helped. So I offered that. I used to teach medicine and residency trainees in Georgia. I was part of faculty. When I came up here, I initially helped with some PA programs. I offered to train family medicine physicians, bring them up from the medical school, bring them up from Dartmouth. I offered that program too, to rural Maine to experience it. And the answer I got was that I personally would have to pay for their housing and expenses. Well, I can't afford that, so it never went anywhere. But if we would make something available, just even on that regard, there are those of us in the community that could ignite the passion to generate future potential people, because especially family physicians, a lot of them are interested in that kind of lifestyle. And a lot of OBGYNs would be too, but you have to ignite them in the early process, not once they've already been sort of jaded and colored and have all their debt. And that's the second point, is they need to have some loan forgiveness if they're going to come work in rural Maine, and some tax breaks maybe. Like there would be a lot of incentives that could be done policy-wise to attract these people coming up. But I have no personal plan, except I'm very healthy and I'm not going to retire.
Well, thank you.
Thank you.
Representative Flynn.
Thank you, Madam Chair. Thank you, Doctor. So as I go home this evening and I try to digest all that I heard today, may I make a bold assumption that you are saying there is a solution if all the parties were to get together?
Absolutely,
Amen.
I
Thank
think
you.
there is.
Thank you.
Further questions? All right, so I next have Lizzie Anderson.
Hi, I'm Lizzie Anderson. I am going to send my testimony in after
I had some technical difficulties. I'm from Booth Bay. I'm part of the Miles Delivers Action Coalition. I do have a background in public administration and healthcare technology. I'm here in a personal capacity today. I was actually inspired by Dr. Fuchs' story back in June. So it's great timing that I'm right after her. I was suggested to sign the survey. No, sorry, I'm a little nervous. The petition related to stopping the closure. And I do not put my name on things that I don't do proper research on. And I researched it because I thought similar to what somebody I believe here had said of, but what are the numbers? We can't keep something open if the numbers aren't workable. And I read the Holton story. I read the data out there, and it was obvious to me that this needs to be delayed. From all of the research out there, it looks everything equitably and not actually looking at our true needs as a community and true needs as a state. So my testimony that's written will have a lot more information, but I'm going to answer some of the questions you guys might have received. I did the primary research for Miles Delivers community response to the white paper. So with my background in public administration, I've worked for 15 years across national, state, regional, healthcare, hospital systems, and human services. I do operational transformation projects that are usually novel and different implementations that have weird questions and figure them out. So when this came up and reading the white paper, it was very clear to me that there are statistics used that have been selected for purposes of a business case and not looked at the larger actual needs of the community. When we provided our response, which was a community response that included myself as an MPA, a couple other MPAs, some JDs, people of the community, it was referred to as insulting by the local health leaders here. And I believe it was not provided to their upper level management. But I suggested we sit down and speak more, and I never heard back. So this conversation that has been referenced is often, we are taking time out of our day to also talk about this and then just blatantly ignored. So some of the information that I think could be helpful from prior testimonies is that there are federal benchmarks for what a value of statistical life is. So one statistical death prevented is 14.2 million. So if you prevent the deaths of a mom and a baby, 28 million. That is what the federal standards are for that. A 1% chance of preventing death is 142,000. Severe maternal morbidity is a metric that they have found the cost of care, and per case, it is approximately $17,000 to $26,000 for every case of severe medical morbidity, which is permanent issues or health concerns. 37 to 50 miles to a birthing center increases the risk 53% for severe maternal morbidity. Cases like in Holton, she not only had to go be convincing Holton to take her, she then was hit with multiple additional payments. She had to pay for the ambulance for transfer. She would have had to, I don't know if they did do life flight, but that was also another item. So it's not only increasing the potential cost of care for folks, but also the cost to the community of lives lost. Meanwhile, Maine Health has taken other risks to prevent or solve moonshots that they have referenced, such as primary care. They have talked about this Trellis Health subscription-based model that within 18 months, they put together a
Lizzie,
system.
Could you
Oh,
kind of
sorry.
wrap up?
Yes.
here?
They put together
Way
a
over.
system that they said will resolve the maternal or the primary care issues versus Waldo to Lincoln Hospital was 21 months. So why were they able to put together something in 18 months and not between Waldo and ours? Just one other thing, if I can mention, we are in a county that is next to BIW, and they have also already identified healthcare concerns, childcare concerns, housing concerns. We will be pushed to this hospital that is already taking all of those families as well. This could be a risk to any future BIW contracts, risks to those of readiness of the families, and also the Coast Guard posts throughout the area. And there have been ways for private, public interventions for payments to provide services like this in California. So.
Okay, thank you. Questions, Representative Boyer.
Thank you, Madam Chair. Thank you for being here.
Thank you.
Just quickly, I read the white paper. I'd
Sure.
love a copy of your response
Yes.
to it.
Thank you. I believe we sent it earlier, but I could be wrong.
Okay.
It was definitely after the deadline. So we will be sending
Oh,
it.
okay.
Yes,
Okay.
so we will make
Then
sure
we'll
it's
get it.
sent.
Okay.
So you do not have it. Yeah.
Okay.
I'll make sure to get
Thank
that.
you.
Yeah.
Further questions? Seeing none, thank you. Next, I have Dr. Stephanie McCullough.
Senator Bailey, Representative Matheson, and distinguished committee members. My name is Dr. Stephanie McCullough, and I am a family physician with additional fellowship training in surgical and high-risk obstetrics. I've been practicing in Damariscotta for 2 years and am speaking solely as an individual physician from the affected community because I want you to hear my personal experience of advocating for the preservation of maternity care services. My expertise is rural healthcare. I have worked across the country and throughout Maine. As of now, I am the only surgical family medicine OB doctor in the entire health system. Since my arrival here in 2018, healthcare leaders in Maine have tried to reassure me that I need to be patient for family medicine OB to be accepted. And in the microcosm of exceptional patient-centered holistic maternity care provided in Damariscotta, I felt I could be. But in January, I was asked to join in the discussions about closure of the Miles L&D unit. When leadership cited OBGYN recruitment as a barrier to maintaining the service, I introduced reports from the Commonwealth Fund about how to successfully staff and maintain rural L&D units. I recommended utilization of Stroudwater Associates, which is a consulting firm in Portland that specifically assists rural hospitals across the nation in the maintenance of services. I proposed an on-the-job training model for non-surgical family physicians to do cesarean deliveries, which has been successful in other rural states. I submitted high-quality literature demonstrating that surgical family medicine OBs provide care that at least matches the quality provided by OBGYNs. Unfortunately, my suggestions were dismissed and communications to the community grossly misrepresented the family medicine specialty and skill set, casting doubt about the excellent quality of care that I and my colleagues provide. Indeed, recruitment of OBGYNs is challenging nationwide, but OBGYNs did show interest in our practice during the time when a job was posted prior to October 2025. We often hear 200 deliveries per year cited as a threshold for safety and financial viability, but I want the committee to know that that number is not rooted in high-quality studies. In your decision-making about the future of obstetrics in this state, I implore you to disregard the 200 delivery annual threshold as an appropriate standard. When a large health system owns multiple hospitals in a region, it is uniquely positioned to develop a triaged system of care where low-risk patients stay in their communities to birth, slightly higher-risk patients deliver in regional centers, and the highest-risk patients deliver at tertiary or academic centers. But this takes innovation and planning. It is a faster and simpler but short-sighted task to close small units while expecting patients to commute the difference. It has been my experience that there is a dearth of healthcare leaders in Maine with any substantive experience in the practice, preservation, or innovation of rural healthcare services. This is where I hope our legislative leaders can make a difference by facilitating the recruitment of such an innovator who is able to navigate rigid corporate strategic plans with alternative models for care delivery. This innovator must be independent of any one health system. Lastly, it has been reported that money saved with the closure of this unit will be prioritized for maternal mental health, addressing intimate partner violence, and bolstering substance use services. And I urge the legislature to ensure those commitments are kept. Thank you for considering my perspective.
Thank you. Questions from committee members? Representative Clucci.
Thank you, Madam Chair. Is there anything of, like, you've listened all day? Are there any questions that you feel like we've asked that haven't been adequately addressed that you would like to share more information about?
Thank you so much. I have 2 pages. I'll start with some questions from Representative Boyer about scope of practice for family medicine OB. I think you were provided an inaccurate answer from people who have only practiced in urban or tertiary care centers. So I do perform dilation and curettage, DNCs, for hemorrhage with miscarriage. I did train to do C-section hysterectomies, which have to be done in hemorrhage cases, for instance, in the operating room. Unlike OBGYN residents, where only a third of graduating residents report competency. The suggestion that an FPOB couldn't manage an ectopic or a torsion is moot when there is no GYN care at that facility, as will be the case in Damariscotta. It is not true that there needs to be a backup OBGYN for cesarean delivery. Across most of rural America, there's one surgeon in the room assisted by a CST, a scrub tech, or a nurse midwife, for instance. It is incredibly concerning to me that there is nobody in leadership in either health system that's privy to the real skill set that we well-trained surgical FMOBs have. I want to make it very clear that I'm not a unicorn. My training was excellent training focused on how to manage patients in a low resource rural setting. So where versus an OBGYN resident who might train where they've got loads of resources and IR, interventional radiology available immediately to help them with a bleeding patient. I trained specifically about what do you do? What vessels do you clamp? Do you bother taking that uterus out or do you put them on a helicopter? I think it is horrific that leadership can in one breath suggest that I, as a family medicine OB physician with over a decade of surgical experience, am inadequate to provide care in an emergency, but EMS is. And the ER doctors that they've trained in 6 months are. Representative Arford, you asked a question about diversions, I think earlier. I want to be really clear that some of these diversions were hours, maybe 12 hours. And all of these diversions have been after our job posting was removed from the HR site. I also want to be really clear that outcomes and quality keeps being brought up, and Lincoln has some of the best quality data in the system. In fact, I want to give Angela Russ, the nurse manager, so much credit because I have worked at 8 labor and delivery units from large urban centers to very small critical access hospitals across this country, and Lincoln is the best prepared I have seen for an emergency. We run multiple drills with multiple teams, multiple hours of day. We had a stable nursing team, a stable respiratory therapy team, stable pediatrics, stable anesthesia. The only hole was in coverage for backup C-sections. So you keep hearing about this labor pool needing to grow with midwives. That's because if a nurse midwife is doing most of your deliveries, then you can, as a backup surgical provider, do 1 in 4 call, because most nights you're not going in, you're not getting a phone call. The midwife is taking care of things. So that is the way that that's a helpful tool. And that's the case at Lincoln. There's 1 in 4 first call. I'm the only person who does vaginal delivery and cesarean delivery call myself. I think it's also important that it's been presented to you like patients at Lincoln don't actually know what providers will be there for their deliveries at this current time. That is not the case. We have 2 employed midwives, 2 employed family physicians, myself who does surgery and 1 who doesn't, and 3 regular per diem OBGYNs in our practice, meaning they are there for regular scheduled times each month, and patients identify them as their GYN provider. They do our surgeries, for instance. Patients rotate through all of us. And so the patients know these 3 per diem providers as just OBGYNs within our group. I want to make very clear that the public record shows that our patients do know us and we know our patients very well. It's the best of any unit I've worked with. And then lastly, I wanted to mention 2 things for Representative Clucci. You mentioned birth centers. Florida is the only state currently that allows C-sections to be done in birth centers. It has been very controversial, but the legislature approved it, and it has, some argue, expanded access. So that is one route that I think the legislature could consider. I don't think there's a lot of safety data available yet about those, but the idea being that you would have 1 OBGYN or 1 surgical FPOB at home. Most of the deliveries are done by nurse midwives or professional midwives, and then they call in a surgical provider if needed. I think that's my list.
Further questions? Seeing none, thank you very much. Oh, Representative Arthur.
Yeah, thank you, Madam Chair. And just thank you. I think I remember you from last, yeah. Thank you so much for you and the other people, because we've seen a number of people that have offered their passion and their commitment and their belief in a system that is not yet met the standards of providing the care that they believe is possible to provide to our rural women. And by the way, and men too, the dads are suffering in the same way that their wives or their partners are when it comes to a lack of care for their unborn child. And so anyhow, my question to you is solution. We're legislators. We don't unfortunately have any magic wands, but there are some things we can do. What's your idea? What's the top of your list of what we can do?
The main thing is I think assigning a rural healthcare innovator who has actually practiced boots on the ground, because the information you're receiving from OBGYNs and maternal fetal medicine physicians who've practiced only in large urban centers is inaccurate about the state of rural healthcare in rural states and about our training. So I think somebody who's actually been boots on the ground and seen a successful practice model entirely staffed by FPOBs like I had in Tennessee, or like many are in the Mountain West where I trained, that person can recognize what a real team-based approach is supposed to look like, how to maximize a clinician's skill set, how to recruit. I have many, many times said to my leadership that I would have moved my family from Portland, where I lived, to Damariscotta if they could commit to keeping labor and delivery open. And we are here now. I still live in Portland.
Is the entity that you mentioned from Portland, is that what you're talking about, a company?
Oh, no, well, I think they could be a huge help. That's Stroudwater Associates. They're a consulting firm. They're very well published. I included in my references some of their information. They have gone into rural states and looked at all service lines in rural hospitals and said, this is how you can maintain obstetrics, or this is how you can maintain general surgery, various service lines, and then can come up with plans to help solve that problem. But again, it takes an independent person to say that a major health system has to utilize the recommendations of an independent party, because I think otherwise wires are crossed about which numbers are which numbers and which facts will be presented and what is viable.
Thank you again. And I just have to say this very quickly. Unfortunately, I do have to depart because my daughter is getting married on Saturday, and I'm going to be going home to a house of over 25 people waiting to celebrate the upcoming nuptials. And if I don't show up, they'll lock the door on me, and it will not be a fun wedding on Saturday. But I will definitely review the recording. And if anybody would like to contact, I'm sure any of us, either as a group or individually, I think the best way to do that is to simply go on the legislative website under our committee, HCFS, and we're all listed there along with our email addresses, because I can't want to speak for people, but I'm guessing that all of us would like to hear again from all of you, because we are fully committed to doing the best, providing the best care we possibly can to the people of Maine. And right now, pregnant women are at the top of that list. So thank you so much. I am so grateful. It's such an honor to be here with you. Thank you.
Further questions? Seeing none, thank you very much. We next have Dr. I think it's Lisa, but your name didn't come through, Torgensen.
Speaking for myself this time.
Oh, okay. Oh, yeah, okay.
Thank you for allowing me a quick few minutes to speak a bit more freely as my own person, full spectrum family medicine physician who moved to Rumford, Maine, to do my training. I absolutely loved my patients. I found my work incredibly fulfilling, and I stayed until the announcement of the closure of the maternity unit. At that time, I then became one less primary care doctor, one less hospital doctor as I worked in the hospital, and one less nursing home doctor in that community because I provide those services as well. I would also like to comment that we have absolutely seen the closure of a birthing unit as the death knell for hospital finances, patient loyalty, and long-term operational viability. I would like to reiterate, family medicine physicians are essential to the workforce problem or perceived problem. I believe in judicious credentialing, as I mentioned before, especially in a world where we're all called providers and anybody can be a provider, but the depth, rigor, and regulation of physician training is diminished or even forgotten. However, I am a family medicine physician who does OB care, and I personally have been the subject of restrictive credentialing. A major Maine health organization was unwilling to fold me into the OB department at a critical access hospital and unwilling to allow me to travel on my own time to a larger center to continue to perform deliveries to maintain my skill set. While a different system took me my license, training, and experience as it stood and credentialed me for services appropriate to what I am trained to provide. Beyond credentialing, I believe the restrictive nature of physician contracts with the major hospital systems in Maine is severely limiting, making signing on as a full-time employee unappealing. I don't really know if there's legislation to be had exactly, but I do think you deserve to know that background about the contracts that we are expected to sign without modifying for some of the major healthcare systems. Finally, I'd just like to end with 3 anecdotes that illustrate the dangers of maternity unit closures and its increased cost. These are real patients I've taken care of in the last 6 months. A woman in her late 30s, pregnant with her 7th child and with a history of rapid deliveries, previously lived 10 minutes from a birthing unit. After her nearest birthing unit closed, care became 90 minutes away. She was in active labor for her entire drive to the nearest hospital and ultimately delivered her baby in the emergency department, which they're a great team, but not cohesive and practiced for obstetric emergencies anywhere near what the labor unit was. A woman in her 20s with gestational diabetes that required twice weekly fetal testing. She works at a hospital that once had a maternity unit. So that testing, so with the closure of that maternity unit, what she could once do during a break from her shift, for example, she now needed to travel 60 minutes each way to get that testing twice a week. So that turns into at least a half a day, oftentimes a full day, of her lost wages, lost time, and travel time. Finally, another young mother, she can't afford a vehicle. She previously walked to her visits with me or took a taxi to her local office for care. With that unit closure, her care is now 45 minutes away. So she now has to rely on Maine Care paid transportation for visits, which sometimes she can do, but other times she has to skip the visits altogether because it takes 4 hours or longer, if she can even get a ride, to get to an office for what really realistically is a 7-minute short routine visit. When it comes time for her to deliver her baby, she will have no choice now but to utilize ambulance transport for that long distance. If hospitals themselves cannot budget for maternity care and they want to punt the cost to patients, then I believe it's time for the government to set up guardrails surrounding required services, the least of which is a moratorium on closures. And while I also believe hospitals need to manage their own administrative bloat in creation of new centers, I do believe that, yes, state funding for maternity support will absolutely be cheaper and better care. Thank you.
Thank you. Questions from committee members? Representative Boyer?
Thank you, Madam Chair. Thank you for being here. Can you just go back to where you said contracts are problematic and just give me a little more detail there?
Yes. So a very common clauses in physician contracts specifically are non-compete and restrictive covenants. So if I work at a hospital in the middle of Section A, I will be forced to sign a clause that says that if I'm either unhappy with a job, if my position is eliminated, if for some reason I need to change for family reasons, I can't work within a 25 to 50 mile radius. I can't set up a private practice. Perhaps I've become disabled, so I can't perform the entirety of my duties that the hospital requires me to do, but maybe I could do my own thing to support myself. I'm not allowed to do that. That's very common in Maine and other states, and it has been a part of every contract that I've seen for the 3 hospital systems in Maine that I've worked at. There's also situations where hospital systems will restrict professional services performed outside of their hospital. So for example, I have a very small private practice for addiction medicine. I live in Rumford. My patients need that. Primary care is lacking. I provide care through a local counseling agency. And I have great success. My patients are wonderful and they're working and they're getting everything they need. And I am professionally fulfilled and it's fantastic. The contracts that I was being required to sign at like a major healthcare organization restricted my ability to do that, even though I do it on my own time. I have my own malpractice insurance and it's completely outside of that hospital schedule. So those are probably the three biggest situations with contracting that I think might help to have a background.
Thank you. We did pass a bill eliminating non-competes without an.
Yes, you did. And I would encourage you to ask for some of us to send you our current contracts, which still contain them. Anything else?
Additional questions?
Would you please send me your contract so I can?
I will.
Thank you.
Additional questions? Seeing none, thank you for your
Thank you.
time. Yep. I think we have one more person, Zach. I can't read your last name. I apologize. Zach. Oh, okay. Zach Hanrahan? Hanrahan? No? Great.
Next, we have Les Fossil.
Here I am. Now, I'm a recovering legislator from this committee.
Oh, you served on this committee.
Oh, yes.
Ah, we need
And
snacks
so I
so
have- I
bad.
have a treat for you. Keep you awake. These are, let's see, where's my help? There's my helper. This is health food. It's dark chocolate covered cranberries. So.
Perfect.
And don't take too many because I want them. The second thing that has nothing to do with this, what we're here for, is Charlie Priest, who is chair of this committee, my good friend and seatmate. His memorial service is at the Episcopal Church in Brunswick on Saturday at 10 a.m. And if this committee hasn't expressed their condolences to his family, that would be a wonderful thing to do.
Yeah, thank you.
So I've got handouts and I'm not going to read from them. I'm just going to babble as I did in the legislature, but this gives you propaganda to work from. That's enough for each one. I got some more just in case I counted wrong, which I'm good at. How would you say it? Let's start here. No, let's start with the way I'm supposed to do it. I'm supposed to say, well, I've forgotten what I'm supposed to say, so I won't say it. I'm not good at that
You need
anyway.
to say your name. That's the
I'm
important
Les Fossil.
Thank you.
I'm a recovering legislator. There's life after the legislation. I served for 16 years on Lincoln Health's board. I served on that board longer than anybody. I started just after they closed the St. Andrews Hospital. And for those of you who don't know, both our admissions and our fundraising tanked because of the way they did it. We're repeating that process right now. And when I looked at these statistics, on the second page, you've got 6 years of Maine's birth, and you have what Maine Health said and what the facts are. And I talked to the administration and said, I can't support this if you don't tell me why your facts are different than the Maine Center for Disease Control, Prevention, Data Research, and Vital Statistics. Who does this kind of thing? So they said nearly 7 in 10 expectant parents are choosing elsewhere. Not true. In 2024, 57% went to Miles. And if you notice, the numbers kept increasing. Well, why? The bitter anger of closing of St. Andrews is finally working its way out. And if you look at the number of births in Lincoln County, we meet that magic number. So I announced publicly that unless they got their figures straight, I could not vote for statistics that I could not support. And so, how would you say it? This is the first time I've said it publicly because they asked us to keep things secret. So I did. The reporters asked me if I had resigned. I said yes. And did I say that I was going to resign if the local board voted for closure? I said yes. And they said, are the two related? And I said, I can't tell you, you know. It's very frustrating when that kind of secrecy is used that way. I find it obscene. I've been involved in this area. I'm one of those people who half the people in this room know because we're on something together, or more than one somethings. And my family's been there too. One of the problems with the Lincoln Health Board is I'm the only employer on that board. There are no other employers. There's only, I think, 3 or 4 other people who have lived in Lincoln County long-term. The board is made up of people from away who have their checks sent here. And you know, if it gets bad, they're just going to move away. And they don't understand what it's, Lincoln County is 2 counties. We're a county that's full of rich people. We're also tied with Washington County for the poorest people in the state of Maine. And it's the poor people who can't afford the services that the rich people think are normal. And my obligation is to represent the people, as when I was in your place, to represent the people of my district and to represent the people of this county. And what this hospital is doing is providing not care, they're providing treatment, and they're making a lot of money on treatment. But at the same time, my hospital was cited as one of the best in America, the best in America by Consumer Reports. The health statistics in Lincoln County were crappy. And it was because we didn't get involved in community health. The absolute center of community health is providing birthing delivery services for the community. You take that away and all you've got left is a bunch of old people. And if you notice, the services this hospital is providing is for the old people, because that's where they make the money. You know, they don't do it for young people. And I find that obscene. That's not how it should operate. And if you want to do anything, please, let's focus on prevention rather than treatment. We can't afford these treatments. We need to provide prevention, and that starts with mothers, last time I checked.
Okay.
And oh, incidentally, one more thing. I was on their philanthropy committee on money. Have they ever, Lincoln Health, ever said, well, we should raise some money for a birthing center? No, that's never even been brought up. You know, it's very frustrating for me. Can you tell?
Yes.
Okay. Any questions from you guys? Otherwise,
Thank
I'll disappear and go get a gin and tonic.
Questions from committee members?
Do you like, no, my question for you guys, did you like my treat?
Yes, that
Oh,
was
good.
perfect at
Yeah, the treat was excellent.
4:15 in the afternoon.
Yeah.
So Rep. Matheson asked a question earlier about the numbers and trying to explain sort of the percentages and how they matched up, and we got a response from Maine Health. Did you follow that response, and did that sort of sway your concerns or no?
I always, being on committees like this, I always check statistics. And when statistics are self-serving, in other words, they prove what people want to say, then I go looking. So I went and looked at what the figures actually were from the state of Maine, whose figures I trust. And the figures from the state of Maine were substantially different from the statistics that the Maine Health said. So I talked to leadership and I said, can you explain the gap here? This was last May. They couldn't. And then I said, you know, I can't vote for this unless I know what the facts are. I don't vote for things that I can't find to be true. And so I couldn't. And just before the board meeting, I said, you know, here are the figures. Please don't have this meeting because these figures are an embarrassment to you. It's particularly an embarrassment to a hospital when treatment is based on truth, not fantasy. These are fanciful figures. They're embarrassing. Okay? Yes.
Could you just explain the last column here, Lincoln Hospital, if 7 in 10?
These are the figures from Maine Health. And I wanted to contrast what they were saying with what the actual figures are. And there is a huge variance, which has not yet been explained to me, except for them to say their figures are right, state of Maine's wrong. Everybody's out of step but my Johnny. Anything? Yep.
So do you get that?
I think, yeah, that's just a comparison of what they were indicating. I heard 32%, but thank you.
Yeah. It hasn't been 32% in the last 5 years, so working on old figures, maybe.
Okay, Representative Flynn.
Thank you, Madam Chair. Mr. Fossil, thanks for coming. I'm gonna draw your attention to your comment here. All the votes of the volunteer Maine Health Boards were based on false information presented by the Maine Health Administration.
Yes.
What was their response when you called them out for presenting false information?
They said their figures are right. You're wrong. And I said, well, they're not my figures, the state of Maine's figures, and as far as I know, nobody else but Maine CDC is collecting these figures. So how can they be wrong?
It's a pretty brass accusation.
Yes, it is.
Thank you.
It's an embarrassment. This is a hospital I supported for 16 years. I'm proud of the good things they've done. But if you're going to be proud of the good things, you have to call it the bad things, in my mind.
Further questions? Seeing none, thank you very much.
Good.
Thank you for the snacks. Appreciate
welcome.
that. I
And I hope there's some of my treats left. I may even pass them.
You don't know this committee.
Damn.
I next have Gianna DeJoy. Welcome.
Welcome. I do have paper copies of my testimony. It says good afternoon, but perhaps good evening. Chair Bailey, Chair Matheson, members of the committee. My name is Gianna DeJoy. I'm a medical anthropologist and public health researcher at the Margaret Chase Smith Policy Center at the University of Maine. Maine's vanishing maternity care, its causes, effects, and how individuals experience these losses was the subject of my recent doctoral dissertation, research carried out between 2024 and 2026. But I've been focused on rural access to maternity care in Maine since 2014, just a few years after my hometown hospital in Blue Hill ended its labor and delivery program. Now, so many years and so many closures later, the impacts of these decisions on individuals and communities are much better understood than they were at the time. We know that when a hospital decides that babies can no longer be born there, individuals in surrounding communities typically must travel longer distances to access prenatal care and give birth. This can raise barriers to care beyond the travel time itself. Pregnant people without reliable transportation, juggling work and family obligations, facing summer traffic, winter storms, slippery roads, things we've heard about today, find it more challenging to coordinate regular prenatal and postpartum care when that care is also far away. Obstetric closures also impact communities more broadly. Healthcare workers lose their jobs. Pregnant people feel left in the lurch. They mourn the lost opportunity to receive care close to home from providers who are also their community members who they know and trust. Parents and providers I spoke with worried about what comes next. Are the pediatricians the next to go? Do closures signal coming school consolidations? Closures also mean pregnant people in a community have fewer choices about the kind of birth they want to have. And this can influence where young Maine families want to put down roots. I want to note here on the side, because midwives have been brought up so much. First, certified nurse midwives do provide home births in the state of Maine. And my research showed significant unmet demand for both hospital-based and out-of-hospital midwifery care across the state. That's just some of those choices that I'm talking about that disappear when we lose upset maternity care resources. All these social impacts can seem abstract, but they do have material repercussions. My research has shown that median household income growth stagnates in communities that experience a local obstetric unit closure compared to communities that maintain local obstetric services. Maine parents who have shared their stories with me want to feel safe, cared for, and respected. They want choices. They want to know their healthcare providers. They want to give birth close enough to home that they can bring in family and support people. They want to see their health systems, their municipal and state leadership investing in their families and the future of their communities instead of giving up and leaving parents and the surviving maternity providers to try to make do in an increasingly untenable maternal health care landscape. I know we're
looking more at solutions today. So I think right after me, we're going to hear from my colleague, Dr. Keith Oates, who is going to share some evidence-based benchmarks on access to care and actionable strategies for achieving those goals.
Thank you. Questions from committee members? So can you elaborate a little bit on something you said quickly, that your research showed that median income stagnated in areas where, and I don't want to misstate, but where maternity care centers closed, or what's the statistic? And can you elaborate on that a little bit? Because that was
Sure.
kind of fascinating.
Yeah, I looked at 30-minute drive time catchment areas surrounding closed obstetric facilities and surviving obstetric facilities between 2015 and 2023. The closure communities on average had an increase of median household income of $17,000. And communities that maintained obstetric services, those 30-minute drive time catchments had a average increase of 27,000.
So any theories on why that is? Or are you just presenting the facts, but not necessarily? Yeah, I mean, that's just fascinating. And do you have any hypothesis as the correlation?
I can speculate. We hear, about folks wanting to move, or when they're move away from communities that lose it, specifically young reproductive age people thinking about, and not just young reproductive age people thinking about where they want to start a family, but those who have the kind of capital to make those decisions. So with transferable skills, like money to pick up and relocate, and those are the folks who maybe are leaving communities. When either there's no obstetric resources available there, or not the kind of resources that they want, like midwifery care available. I talked to someone in my study in Millinocket who was passionate about having home births. She had had a home birth in a different state with great success, was pregnant again now in Millinocket. Found a certified professional midwife willing to travel to her and assist home birth there. After a really extended and sort of challenging labor, she got scared, called the local hospital asking if a transfer was possible. They had ended obstetric services years earlier and basically refused the transfer. And when I talked to her, after the fact, she said, if I wanted to have another child, I don't have the option to have the kind of birth that I want here where I live, and maybe I would want to move somewhere else. So that's a possibility. But also, there is the all the sort of economics that surround obstetric units, that providers like the obstetric nurses and all that goes away when those close. So that could be part of it.
So perhaps a combination both of this exacerbates people moving from the area because this service is gone, and that when people are choosing where to move to, that may be a consideration, especially if they're, looking to start a family. Okay, thank you. Representative Olson.
Thank you, Madam Chair. So following on that, so we take the assumption that the people that moved out, those properties did not get backfilled, or did they get backfilled with people beyond childbearing age? Because now you're kind of mixing two different things. You could have had a move out of people that were childbearing age and a backfill with people non-childbearing age. So, you've got a different dynamic of what you need to support in that area.
I did also find that those closure communities aged slightly more on average than non-closure communities.
Yeah. So kind of gets to that catch-22, which is, these areas, the hospital is saying, well, we don't have enough births to sustain it, but yet you're not going to increase those births by doing what you're doing, right? So it's kind of a self-fulfilling prophecy. So thank you. Fascinating. Further question? Not seeing any. Thank you. I guess we're going to hear from your colleague now, Brianna Keefe Oates Thomas.
Thank you very much, Senator Bailey, Representative Matheson, members of the committee. My name is Brianna Keefe Oates. I am a reproductive epidemiologist, so I have a PhD in population health sciences focused on reproductive health. And I'm here today representing a group of academic maternal health researchers in Maine from institutions including the Rue Institute at Northeastern, the University of Maine, where Dr. DeJoy is, and Colby College. We sent the letter on Monday with recommendations from Maine reports, which I believe you have printed. So we're all public health professionals, and in public health, we really look at things from a systems lens. In the case of closing obstetric units, I think what we're looking at is broader, right? How can we create a system where everyone is supported during pregnancy, delivery, and the postpartum period, and has the best outcomes possible? We've already talked about how multifaceted this challenge is. But we know that none of these things, kind of workforce, financing, creative models of care, is really going to help on its own. There was a question earlier about clear strategic planning around access to care, and that's exactly what we want as well. Really a clear vision and system for how we imagine and want maternity care in Maine to look. Quality is super important. Today, I'm just going to briefly focus on access. The evidence is clear that the risk of poor maternal and infant outcomes increases as distance increases. And there's some coalescing around evidence showing that when someone lives further than 30 minutes from a birthing unit, the risk of poor outcomes increases and increases even further when that distance is more than 60 minutes. Again, we don't have a national standard, but there's evidence coming out every day. So we encourage everyone to work together to create a system of care where most people are within a 30-minute drive and almost everyone is within a 60-minute drive. With this vision, we can then begin assessing what hospitals have to stay open or reopen, where should birth centers open, and what resources and supports are necessary to ensure that. And I want to be clear that we're talking about minutes, not miles, because we talk about that a lot. The vision of access is not currently realized in Maine. We've heard this. My team we recently analyzed drive times, and we calculated that over 40% of women of reproductive age in Aroostook and Washington County do not have access to a birthing unit within a 60 minutes drive. Again, over 40% of women in both of those counties do not have access within a 60-minute drive.
Which counties?
Aroostook and Washington. This gap, I think it's important to mention, this gap includes many of the tribal lands within Maine's boundaries. These distances are really unacceptable. As you've heard, we're not starting from zero. Lots of work has been done to find and identify solutions. We shared with the committee a letter summarizing the 21 reports that we could count on maternal health in Maine that have been published in the past 6 years. The letter highlights the recommendations that appear across multiple reports, which I think demonstrate where the consensus is building. And we recognize that creating legislation to support those recommendations is the next step. And you all have asked amazing questions today about kind of those next steps. We're also compiling a summary of those recommendations and legislative solutions that have been implemented in other states. We hope to share that brief within the next month. We've been racing to try to do it, but we're also researchers. We want to be accurate.
That's not this.
That is a list of 8 recommendations that have been identified across multiple reports in the state. We also have a list of 38 recommendations that have come out among all of those reports and some national reports. And what we're doing now is trying to map legislation that might be able to support those recommendations. As you can see, we're trying to be very deliberate about this. Many of the recommendations that are on that list of the letter, the 8 recommendations, have already been mentioned, which is great. I'm not going to go into them. I did want to highlight just 2 recommendations from national groups that are focused on financing that didn't come out in the Maine-based reports, but are important and have been discussed. The first is examining what current reimbursement rates are in Maine and ensuring private insurers cover the actual cost of care at rural hospitals. There's some evidence that, at least in other states, private insurance company reimbursements were actually one of the drivers of OB unit closures because they weren't reimbursing adequately, especially in rural areas. So there was a question recently about reimbursements, and I don't have the answer, but I think it's worth looking into. And the second this is by the Center for Healthcare Quality and Payment Reform, is to
require main care and private insurers to pay essentially a monthly standby insurance fee for rural hospitals. It ensures, for every woman of childbearing age, there's a fee, it's flat fee, it supports those obstetric units, and then there's another flat delivery fee for births. So it wouldn't matter if it was a C-section or a vaginal birth, it would help kind of provide that stability. I believe Sally Weiss at MHI kind of mentioned something similar. There's a few of those options. I've reached my time. I'm going to stop, but we're happy to answer questions now or later. And as researchers, we're always happy to kind of dig into the data and look at the numbers. Thank you.
Great, thank you. Questions from committee members, Representative Clucci.
Thank you, Madam Chair. I know you're out of your 3-minute time, but if you had to pick one or two of the sort of top things that you would like to talk about, I would be curious to hear, because you guys have done so much work. I did read your report and to the extent that you can give us that information orally now that we can reread it later, that would just be great.
Yeah, I mean, as I mentioned, there's workforce, there's financing, and then there's also supporting specialty care. I think those are kind of the 3 big buckets that we've been looking at. And then the 4th, of course, is assessing when there might be a closure, how to support hospitals to prevent those closures, and how to make sure that those closures are either don't happen or are absolutely necessary. I think a few things that haven't been discussed in detail today that I'll highlight is that the partnerships with federally qualified health centers, I know that was discussed earlier, those have been very, very successful in other states. It reduces malpractice insurance. There are several different the reimbursement is better, and it's happening with Cary Hospital and Pines, but it's really an option to look into. And in fact, in North Carolina, a rural hospital was able to reopen their unit through that program, working with an academic medical center. So I think that's one. Ensuring that all providers can practice to the full extent of their licensing and credentialing is another one. And while we're on workforce, supporting providers to live in those communities in a way that's sustainable for them, I think will also help. So loan forgiveness, housing, rebates, things like that.
Anything else I should say? Thank you. Further questions? Representative Foley.
Thank you, Madam Chair. Sort of everything we've heard today, why do you think they closed the maternities?
I can't speak to Lincoln's decisions and Maine Health's decisions, but my colleagues and I did do 2 reports funded by the Our Moms program on workforce needs. And I think what we found was really there are challenges with workforce that prevent some units from staying open. Those challenges are not insurmountable. And we've heard from many providers today about solutions that they've had and ideas that they've had about how to recruit and retain OBGYNs, FMOBs, and midwives. And so that's, what we heard when we interviewed hospitals who had closed their units. What they said was, in the end, it wasn't a financial issue, it was a workforce issue. I do think finances can influence workforce, right? Paying people loan forgiveness, things like that might incentivize them, but workforce is certainly something that has been cited by everyone.
Further questions? So I just had a question about when you're talking about within either 30 minutes or 60 minutes, how do you calculate that? And again, specifically, what we've heard like in Lincoln County is, are you talking about ideal weather situation? You talking about mid-July on Route 1, or are you talking about mid-January in a snowstorm?
Yeah.
How do you calculate that? Do you do an average time? How do you do that?
I've been thinking a lot about this because I've done kind of a basic drive time analysis. We look at each census tract, so try to really drill down and look at kind of where people live in that census tract, and then we calculate from there. But currently, at least in the basic tools that we have, it just calculates, like what Google Maps will tell you. So that's not the average. And I think if we were to do really a systematic analysis of what hospitals need to stay open, that's a factor that should be considered. We know summer in some places is going to make a drive much longer. Winter in most places is going to make a drive much longer. So maybe it's not 30 minutes, maybe it's
25 or 20, recognizing that summer and winter are going to make it longer.
Representative Clucci.
Thank you, Madam Chair. One thing that nobody's really talked about, but I'm curious about, and I think your report, I think some of the reports have mentioned it, but just, can you help me better understand reforms that people are looking at around malpractice insurance? Because I know that the report that you mentioned talked about the federally qualified health centers, and if your providers are sort of staffed through there, you can get malpractice through other federal laws, but outside of that.
Yeah, I wish I will look into this more because it is a complicated issue and it's an administrative issue that I'm not well versed in. But I'll say in our research, what we heard was that specifically Maine's dominant malpractice insurance company had kind of very strict thresholds and requirements for certain providers that made it harder for them or more expensive for them to practice in some areas. So that's something that's even above and beyond the hospitals. It's about the malpractice insurance company, but that is a very complicated subject that I don't want to speak on without much more information. But I do think it's worth looking into.
Further questions? Seeing none, thank you very much.
Thank you.
All right, and we next have Senator Cameron Rennie. Who's been waiting.
Are
those from your kids' treat?
That was a frantic request to my aide to bring me some candy because of course I didn't want to talk today. She even labeled them with your names though. Very thorough. She's great. I will not belabor this. Hello, everyone. My name is Senator Cameron Rennie, represent Senate District 13, which is most of Lincoln County, towns of Washington and Windsor. This is my district that this recent vote to close has happened. And I think as we are trying to come up with solutions to prevent this from happening in other places, although I would advocate for a full moratorium, including Miles campus of Lincoln Health, of Maine Health. I have to speak because I took note of the question that was asked to Mr. Mueller by one of the committee members, which was in reference to, I think, a very reasonable question, which is sometimes when labor and delivery closes, it is the death knell for the hospital, and the hospital closes shortly after that. The response, I took it as a little flippant, but I've got some feelings over here, but it was kind of laughed off as, no, that is not the plan. Absolutely, that's not what's happening. I have a problem with this and with taking things like that at face value based on my recent interactions with the Maine health system on a whole. I would say that that is the exact same message that my committee and my community in Booth Bay received after labor and delivery was shut down there, but before they had closed the rest of the hospital, which did happen. And we're still feeling the after effects of to this day. So I like to approach my work with people, always assuming best intentions. And assuming, giving people the benefit of the doubt. I do think that's an important thing, especially when you have diverse interests and members when you are working to solve a problem. My benefit of the doubt for Maine Health at this point is gone. It's gone. And it's for a few reasons. One, the changing of the goalposts as to the reasoning behind the closure of labor and delivery. I think now the most prominent one is staffing and also safety, and you all got the lowdown on that. I don't need to go into it. When I was in a meeting with them a while ago and I asked, what are we doing to advertise? So that was back when we were talking more about the low birth rates. What are we doing to advertise? Because we have an excellent facility there. That's why people are coming from outside of Lincoln County to come and give birth at Miles. What are we doing to advertise? The response was, oh, why would we do that? We don't want to take patients away from our hospitals that are in our same system. The fact that it was stated that there were no plans to close Miles Labor and Delivery, when in fact there had already been talk of retention bonuses going to the doctors that work in that unit, is disingenuous. My community members found out that this closure was going to happen from going to their providers and mentioning that they want to have another baby. We have people moving in, they're having babies, they want to have babies, and their provider was the one that had to inform them, hold on, you may want to find an alternative because we're likely going to be closed. This was well before any community meetings. This was well before any board votes, local or state. And a side note, it doesn't even have to do with labor and delivery, but right now I read in the August 6th edition of the Lincoln County News about the closure of our Addiction Resource Center on August 31st. That's Monday. The article cited a loss of a provider as the reason for the sudden closure, the sudden indefinite closure, where people are going to be asked to go all the way to Brunswick or all the way to Rockland to get those services starting Monday. I have it on good authority that the provider that is being cited as the reason this is shutting down left the position because she was told it was being shut down. Now that's a side note. And I'm sure there are reasons, but I have a real issue with the lack of transparency, the lack of honesty, with the lack of any sort of details on the recruiting process, what was tried, have you offered more money? We did that great bill, I think in 2025, that makes it so you can offer doctors more money to practice in rural areas. That was not available before, but it is now. I'm not saying any of these people here are lying to you. We all work with Katie and Sarah. They work with us and they talk with us on the information they are given. I don't think Lincoln Health or Cindy Wade are monsters that want to stop all labor and delivery. That's insane. But I think they are in the trenches, they are burnt out, and they are not being given from higher up in the main health system the resources and the ideas and the creative thinking that they need to be able to do that job. So as you're going into this process, I think what I'm going to be researching is more about the potential for more transparency in systems that do receive so many taxpayer dollars and taxpayer benefits and tax exemptions from being nonprofits, and how we can make sure that the decision-making information is out there, because it should be, because it's all of us that's being affected and it's all of our money that's going into it. And I only request that if you, rather than taking things on their face as we're working through this stakeholder process, I want some documentation, something, some dates, some specifics. Because trying the same thing, potentially, who knows? I still don't know. But trying the same thing over and over and over again for years is not going to get you a new result. Thank you for your time.
Questions from committee members? Representative Olson.
Was there a second page that was supposed to come on here? Because you get 3 footnote references, but there is no footnotes.
That is not me. That is not me, so I'm not sure.
Yeah, I mean, it'd be nice to get what those references are so we can
Sure.
verify back and forth too.
Thank you. Thank you, Colleen.
Colleen will follow up.
Yeah.
Great. Any other questions for Senator Rennie? Thank you. Seeing none, thank you very much.
My grandchild will thank you later.
Thank you so much. So Edna, I think we only have one person online. Is that accurate? Judy Stone, is she still there? Yeah. All right, if you want to move her over, please.
Can you hear me?
Yes, we can. Go ahead.
Thank you so much for letting me join you. I'm Dr. Judy Stone, an infectious disease physician and a medical journalist who's summered in Maine for over 40 years now, and I own a home in Boothbay Harbor, just so you have that perspective. Rural women are 64% more likely to die of pregnancy-related causes than urban women, and 9% more likely to suffer life-threatening complications during pregnancy, birth, or postpartum. I'd like to reiterate what Cameron Rennie said. Maine Health is private, but it receives substantial public funding, and it owes these communities, our communities, real accountability. It broke that trust once already by closing St. Andrew's Hospital, and now is closing its urgent care center here too. Closing Miles Labor and Delivery is worse still. My concern led me to write 2 articles in Forbes on the Miles closure, and I've shared this with the committee. I don't know if you've received it yet, but I passed them on. Before I wrote them, I requested an interview with Maine Health, and they declined and never answered my follow-up questions. Maine Health says this closure isn't about money. If that's true, they should have no objection to answering these 4 questions that I asked them, and I hope that you will ask them too. Why the rush? The process ran from June to August 6th. Why not wait until after the November election? Why weren't the Lincoln County commissioners consulted or discussed this with? They were oblivious to what was happening to their county. How will this affect already stretched EMTs who will face longer transports and less availability for other emergencies? And finally, and something that I haven't heard brought up this afternoon in this great hearing, where is the economic impact assessment for Lincoln County as a whole? Maine Health's estimate of 37 minutes added travel time is unrealistic, which you've heard from other people, especially if women are coming from down on the Boothbay or Pemaquid peninsulas. It ignores summer tourist traffic, winter fog and ice, and assumes a car and driver are instantly available. If a woman is in active labor on the Pemaquid Peninsula in a January whiteout, she will not have 37 minutes to spare. How much longer does an ambulance take from the peninsula, and what other emergencies will go unanswered while it's tied up driving to Brunswick? I strongly believe that women in labor will die because of this delay. In terms of the economic impact, research from the University of Kentucky found that rural counties losing obstetric care saw business establishments drop 17%, 5 points worse than urban counties. Access to obstetric care is an economic development issue, not just a health one. The lack of transparency here now mirrors that of the St. Andrews closure. Lincoln County cannot both court retirees and young families while stripping away the maternity care that keeps families here. And who is going to take care of the elderly that Lincoln County has as a retirement community? I'd ask this committee to require an independent economic and public safety review before any closure proceeds. Thank you for the great questions that you asked during this hearing and for allowing me to speak.
All right, thank you for joining us. Questions from committee members? I'm not seeing any. Thank you very much for your patience. Anyone else, Edna? No. All right. Anyone else in the room that wanted to testify that didn't have a chance?
We need to pause the closure. No, we really do. We need time to have a full review when you bring in an independent.
Yep, we've definitely heard that.
Also.
Yep. So I'm gonna close the public comment at this time and open it up for committee discussion, and in particular, committee discussion around next steps. I mean, obviously, we've gotten a lot of information. For me, this seems like a step in the process, that this is not the end of the discussion. But I've been trying to think about, well, then where do we go from here? I mean, we can ask for another committee hearing if you think that would be helpful. We can ask for, if we wanted to, one thing I discussed with Colleen and Derek Grant from the Senate, just because I'm in the Senate, is setting up a subcommittee to then be able to convene and bring in a stakeholder group. I know there's been a lot of discussion about setting up a stakeholder group. the question would be, well, who would convene that, right? And so we certainly can do that as a committee through a subcommittee if we wanted to do that. This is a discussion. I'm throwing ideas out there. We're all here. As you know, it's hard to come back. So I'd like to have the discussion while we're all here, even though we're all a little tired. So thoughts, Representative Clucci.
Thank you, Madam Chair. So, we've gotten so much information today. And I imagine the next steps will probably be informing, legislation. At least partially, right? There may be working groups. I would be in favor of possibly, all coming back together as a group to talk about what we heard and the policy ideas that have been put forward, to say, what are the ones that we like? What are the ones that we think might be feasible? So that we can just have that conversation amongst ourselves on mic. So that then the public, and the sort of interested parties can be providing sort of then additional feedback to us. So that if we do reconvene, maybe in late October or something, there will be, an opportunity to have sort of real-time feedback to then inform whatever legislation gets put in December. So I would not necessarily be in favor of breaking up. I would be in favor of keeping it the full group.
Okay, others, thoughts? Representative Foley.
Thank you, Madam Chair. And I would agree, any kind of step is going to have to be legislative. We obviously aren't going to be able to do that until next year, but I think one of the pressing issues is the closure coming up in December. And we obviously can't enact a moratorium as a committee, and we can't pass any kind of legislation as a committee. But perhaps we could send a letter we love to do that.
We do.
And just ask for a reconsideration based on the information that we've received. And that we would, as a committee, like to engage in a more fruitful discussion regarding the information we've received and potential solutions. I think that is something that we can do, and perhaps initiate that sort of a dialogue. So that's my thoughts on where I think we can go. And certainly if it takes another meeting, but a letter if we're going to do a letter, it needs to go sooner rather than later.
Right. Yeah. Okay. Other people's thoughts? Representative Flynn.
Thank you, Madam Chair. Is it possible for us, can we somehow request that the quote unquote stakeholders get back together? Because I must say this afternoon, as we leave, I'm very, very disappointed. I'm very surprised at the lack of trust between the groups. We got one group saying the other group is lying and presenting false information. I don't know who to believe anymore. I want to put it back out there and say, why don't you guys get together, come up with a truth committee, and then come to us with the truth of what we can do to help. But what I'm hearing here is, we can't get together. We're not going to get together. You guys fix it. They're the ones, the stakeholders are the ones that should be coming up with these solutions, because I'm hearing from the doctor in Aroostook County that there are models in this country that work. Well, why can't they work here? I think that the dialogue has to continue amongst all of the folks in the room, rather than coming to us every session saying, here, guys, can you do a moratorium? Can you fix this? When all we're doing is triaging something that requires deeper care. And as an individual, as a legislator, I'm very disappointed today that I don't know who to believe anymore. That bothers me deeply. So I ask everyone in the room, stakeholders, can you get together here We've got people that are hurting and dying in our rural locations. And I'm hearing, as Rep. Foley has said, these silos are very real. I'm not seeing them coming down. I'm seeing them getting higher and thicker. And as that occurs, we're becoming deeper and deeper into trying to come up with some solution. And my fear has been in this committee now 2 years, that we're coming up with quote unquote solutions that a committee 10 years from now is going to be fixing our solutions because we're band-aiding things. So to that end, I don't know where to go because I don't know the legislative process well enough, but I'd like to say to those groups, can you get back together?
Yeah.
Anyway, thank you, Elle, for coming and thanks for your time.
Yeah. For me, it's kind of two different things. It's the short term, right? The impending closure in Lincoln County. And that's where, yes, these two particular groups should be having discussions and exploring solutions for Lincoln County. The bigger picture, and when I say stakeholders, I mean, all stakeholders, not just these particular groups. To, yes, explore what have they done in other states? What are they doing in other states? There's, we had a couple of reports that had a number of recommendations, but I don't feel like I know enough to necessarily look at each of those recommendations without doing a deeper dive. Maybe that's just me, but that's what I would think a stakeholders group would look at. So what I'm struggling with though is who's going to convene that stakeholder group, and who's going to do it before January. And because this seems like something that needs attention now, not in the future. So I don't know if that's helpful, but that's my thought process. Representative Matheson.
I think for me, where I struggle is the timing in particular, because I think that if the legislature is putting their money where their mouth is, we know when the budget comes out. So if this is an important thing for the legislature to fund some areas in maternal health, then that needs to be addressed before the next legislature. So I think that timing is kind of number 3 for me. Like there's the immediacy for the issue for labor and delivery. There's the long-term fix for the state, but there's also hopefully a couple of steps before that can maybe help with not having more closures, by seeing some money in the budget, helping with some solutions. So that's where I think a task force or a stakeholder group, I don't know necessarily how we do determine either one of those, but I think that needs to come together, and it needs to come together quickly so that we can actually look at some solutions, because that's really what I came here for. I mean, I certainly would like to see Lincoln not close, but the legislature can't mandate that, and the committee can't mandate that. I wanted more information, absolutely, but I certainly want solutions for seeing maternal health care not continue to go away in Maine. So, and there's other hospitals that offer labor and delivery, not just Maine Health and Northern Lights. So I think that those people have to be in on the conversation as well. So I'm absolutely in favor of convening some sort of a task force or a stakeholder group, and I'm happy to serve on it.
And I'm fine with doing a letter, by the way. Representative Foley, I don't think they're mutually exclusive. So, Representative Olson.
I mean, throughout everything we've heard today, there's a number of different touch points that are there. You have some scope of practice issues, you have some licensing issues, you have some financial issues, there's a plethora of different touch points that really need to be looked at.
Yes.
And to try and craft legislation without having a committee for, a group first to try and winnow that stuff down, we're throwing darts at a wall. I think we need to get that so we can get a little bit more focused and it's, and at the end of the day, it may not be one piece of legislation. It may be multiple pieces of legislation because we're dealing in so many different wheelhouses there. So I think, the letter is fine that, that's, we're good at that. But, I think we do need to get people back together and into a room and either lock the door and butt heads and whatever, and, I mean, I'd be happy to work on that as well, but, I think we need to get that so we can get some concrete issues that we can then craft some things around.
So ideas again on who's going to convene the stakeholders group, and that one that would be staffed by Colleen. So, I don't know who had their hand up first down here. I wasn't looking that way.
Yeah, I'll go first because I'm a B, you're a C.
Okay, Representative Boyer.
I'm in favor of the letter. I feel like I liked Representative Clucci's idea of coming back together. I feel like late October is too late. Could we come back together once we've had time, maybe in September, once we have some time, all of us to go through everything we heard today and really read it and process it, for ideas on, do we want a task force? Who's going to convene it and that sort of thing. Could we all meet again next month? Is my thought.
Yeah, I mean, we would have to get permission from the presiding officers to do that, but certainly that is an option. Yes. Yep. Representative Clucci.
Thank you. So I think we are the group that should be meeting on this regularly. Like, I don't think that we should have just a small group. Like, I've invested, I don't know, like 10 hours of prep time and then like all of today in this. Like, I'm going to go home, I'm going to read all of this in depth. Like, I want to be part, and probably other people on this committee also want to be part of vetting this. I think we're here because it's not like this issue is new, right? Like, there's been a lot of research done. I think it's time for us to get together and say, okay, what are the ideas that are viable, that like legislatively that are palatable for us? And let's start talking about them, but let's start talking about them on microphone so that people can come and sort of like a work session. All right, let's look at this issue of, we're going to, malpractice. Okay. So this is the portion where we're going to try and understand what's going on with malpractice and what are various solutions. All right. And we invite people that are in the room that have sort of perspective and knowledge to come up and answer the questions. I mean, I think that we have the format, and we have this. I would just hate to try and dilute this into a smaller group when we have structure to try and do this.
I'm
that can
trying to
then
find a way
inform.
to make it a bigger group, because I think that there are stakeholders out there that we haven't heard from. So how do we rope them in? I don't want to set an agenda that is limiting. Because I want people to be creative. Because this is going to require, in my opinion, creative solutions. So that's the only thing I struggle with, just having continuous committee meetings, is then how do we ensure that all the stakeholders are heard from? And how do we do that in a realistic way? Because we can't just keep having committee meetings. I mean, the POs are not going to say, oh yeah, you can have 10 committee meetings, right?
Well, why couldn't we invite people that have done research and look into this, come to future meetings and give presentations so that we can ask questions? And then, similarly, we treat it like a work session. We talk about the ideas afterwards.
Again, typically work sessions, you don't have presentations and questions. You've already
We wanted to think
that.
creatively.
So
I'm trying to think creatively.
Yeah.
And I mean, I feel like we have good stuff to work from already. and we can invite people. I mean, I think that this is going to have generated a lot of press and attention. And I think the solutions and the ideas that we haven't heard today, we can say, if anybody was paying attention to this, like, and your idea was not put forth, get us your idea, get us the information to back it up so we can start having discussions about which ones do we think are viable.
Other thoughts, Representative Polly?
Just from a legislative point, do we have the authority to set up a task force? Or do we have to go to Ledge Council and get their approval to set it up?
Yeah, my understanding is, and Colleen, you can certainly chime in if I'm misrepresenting, but that's where the subcommittee came in. That you can't really set up a task force, but you can set up a subcommittee, and they, of course, a subcommittee, I don't know if any of you have ever served on a subcommittee, but you can pretty much do what you want. You know, you can structure it however you want. So you could then structure it that it would, in essence, really be a stakeholder group or much like a study group where, yes, like you were saying, Sally, you would invite people in, you would have presentations, you would, you know, Colleen would say, oh, there's this person, you know, this is what they do in Alaska. You know, I don't know, making something up and receive that information. But you would also have, the other thing is having staffing from OPLA to help coordinate everything and then write a report, obviously, with recommendations that would come back to the committee. Much like a study group. It's kind of a indirect way to create a study group. Because we're not in session, so we can't pass a resolve, we can't pass a bill, we can't, you know, that's the difficulty. We're kind of limited as a committee on what we can do, so.
Get your feedback.
Yeah, you want, yeah, no.
I'm sorry.
No.
I'm just curious if you've seen anything similar set up.
In your 30 years.
Yeah, yeah. It's on.
Yes, I have. Often it's been during the course of a legislative session, but there have been lots of examples where the committee over the years has, you know, asked a small number of committee members to go out and meet with stakeholders and have, they've been public meetings, kind of like work sessions, but publicly noticed meetings where either committee members or I would try to facilitate consensus among stakeholders, usually geared to a particular piece of legislation, though, like a particular legislative proposal. So that has happened. There have also been situations where the committee has, or study committees have created their own sort of stakeholder groups that as a subset of a larger subcommittee based on topic areas, you know, would then invite additional stakeholders to participate, which I think is kind of the idea that Senator Bailey was throwing out. It could be done as the whole committee, but, or a subcommittee could then invite identified stakeholders to participate. The question always becomes, who do you invite and who are the stakeholders? And inevitably, sometimes people say that they're left out or, you know, not included, which is also a challenge. So it's really kind of the two options, but you're in a tricky position just based on where you are in the legislative calendar, as to what you can do in terms of establishing a full-fledged task force that you normally would see the legislature do, either through the passage of legislation or even through the passage of a joint order in both bodies. And you're just not going to, I don't think, have an opportunity to come together as a full legislature to do that.
So is that something, does Ledge Council have the authority to grant to us the authority to put together a study committee or some sort?
And I'm not sure about, like, to delegate to the committee the ability to do that. I'm not sure I've ever experienced that, But the legislative council, or with permission of the presiding officers, committees have been authorized to meet over the interim, or, you know, like a meeting like today, or to meet several times over an interim to deal with an issue. You know, and may, in that permission, ask for broad authority to invite stakeholders to participate with the committee. Kind of like a task force to develop.
I mean, obviously,
Consensus.
leadership thinks this is an important issue.
Yes.
They've allowed us to do this today, so it just would seem to me that it would be helpful from a more powerful or more productive standpoint to have leadership alleged counsel behind us, sort of saying, yes, we want you to go further. We want you to, but I don't know if that takes a letter to
Typically, you know,
leadership
yeah.
and and
Two
just-
letters now.
Typically.
Well, I've got another one coming.
Well, typically we've had, you know, usually what happens with like an interim committee meeting, so like this particular interim committee meeting, it's through the approval of the presiding officers to do that. That's something they can do individually. There have also been opportunities, I think, in the past where a letter has gone to the legislative council asking for certain authority to do things. So those would be the two options, but that might be something that you could have further discussions as to how to do that. But you would send a letter or a memo asking for authorization to do this, you know, convene the committee 1, 2, 3 more times or whatever. And maybe you would say, we want to involve stakeholders and lay out sort of kind of what you envision. And then typically they approve that because they need to approve both the time for the legislature to meet, and they also have to approve the staff resources, which was what Senator Bailey was alluding to, because they do have to approve staff resources. Legislative council usually does that. I can't promise that it would be.
So maybe if we send it, we could
Me,
send
folks.
a memo to presiding officers and ask them to authorize the committee to hold another or a series of meetings, or whatever, and invite and have the ability to invite stakeholders to provide information or something of that. Just a thought of I'm trying to find a process that would be
Right.
fairly quick.
Right.
But would have some teeth in it. That's sort of.
Right, right. And that's what I've been struggling with, trying to do that very thing,
Yeah.
is like, I don't want to lose the momentum and the time, you know, and not do anything between now and January. But Representative Flynn.
Thank you. Given the lack of trust within the parties that I witnessed today, is it possible within the letter or recommendation from Ledge Council that a third-party assessment be done from a professional company that does rural healthcare development to make specific recommendations to the committee on what they feel we should do?
You mean we would hire the person?
I don't know who would do it, or can we in the letter recommend strongly that the stakeholders engage with a third-party assessment?
We could certainly do that in the letter to, I assume we were gonna send a letter to Maine Health. That's what you were thinking, right? I mean, in our letter to Maine Health, we certainly, you know, can put whatever our opinion is. So that certainly is something we could ask them to do. Yes. Representative Olson.
I mean, once you start to bring in a third-party study, you've now added additional time.
Right.
And is that time 3 months, 6 months, or whatever, you know, because, you know, once you're trying to go out for an outside study, they're not gonna want to do it in 30 days. They're not want to do it in 60 days. They've got a finite time that they want to have in there. So have we just then kicked things so much
Well,
further down? the
again,
road?
that's just addressing, I think, the immediate closure in Lincoln County. So that's that, you know, I mean, what I heard Representative Foley saying was write a letter to Maine Health saying, hey, can you slow down and not do this? And now Representative Flynn is saying, and as part of that letter, would you seriously consider this outside assessment that, yes, might take time, absolutely. But I think that's distinct from, but what should we, if anything, as a committee do in the meantime to look at the bigger picture of rural labor and delivery and maternity care and, strategies to ensure that more units don't close in the future. So to me, it's like two different tracks. Representative Matheson.
I also think that we have a wealth of knowledge that we saw come in front of us. Plus, there's many, many studies that were associated to this. So I would tend to not want to do additional studies. I think that what we need are some people are thinking outside of the box for solutions based on the information. I mean, there's two different things here, right? We're talking about our concern about Lincoln, but we're really ultimately trying to solve the problem of maternity care not continuing to get lost in Maine. And I think that that shouldn't get, those two, they're similar, but they're conflicting, right? Because one is an immediate concern and one is a longer term concern. But my take is we have an anthropologist that came before us. We have many, many studies that I've read through a lot of this material, and I want to read through it even more, that I think we can pull from and get information and try to guide us on what we would want to do moving forward. And if it's this full group, so be it. If it's a smaller group, so be it. Whatever the committee's desire is. My desire would be to try to consider if we were going to come together, however it is, to do it the month of September. Try to come together during the month of September 2 or 3 times, however that is, driven by, okay, by the presiding officers. And bring an agenda that we are very interested in hearing about solutions. That's my goal, is to hear about how can we change the trajectory based on the information that we have and what other states are doing and what other, that would be my, but doing another study, I honestly think that might be repetitive in some respects.
I think the study he was referring to was just in regards to the miles closing.
Oh, I see.
It was something that was brought up a number of times that they
Okay.
had asked for.
I see.
Just to get objective information on that particular closing, right? That's what you were
I see.
referring to.
Sorry, I
Not
misunderstood.
not a global study.
Okay.
Yeah. That's why I said we could certainly put that in our letter
Got
to
it.
Maine Health to ask them to do that. Representative Clichy.
So I've heard you and Rep. Foley both mention a letter to Maine Health. I'm curious what you would have that letter say, because I feel like we've heard a lot of information and I want to take some time, and it's conflicting, and I want to take some time to actually better really fully read it all again before I put my name on a letter. God, I don't even know what I would want it to say. Because there might be information I'm looking for that we don't have, but
Yeah, my understanding of what Representative Foley was suggesting for a letter was simply to say, can you slow down? Is there any way you don't need to close this at this time? And then Representative Olson said, and oh, by the way, can you look at the possibility of having an independent outside assessment done? That was the gist of the letter. It
Yeah.
wasn't, so it wasn't, getting into what information is accurate, what information is not accurate. But.
Yeah, I
Representative
mean, my
Foley.
sense would simply be to address Maine Health and say, after our hearing or during our hearing or after a hearing, we heard a lot of information that's conflicting with the facts that we have. And we want to continue to look into this, and we would ask that you pause your current action until such time as this can be fully vetted with the committee and with other stakeholders. Something of that nature, that not specifics, just saying, look, we've heard a lot of stuff. And a lot of it's conflicting. And we need further information. And at this time, we would appreciate it if you could. We can't force them to. So it'd just be a matter of, we'd appreciate a reconsideration or a pause until such time as we can reconvene and come up with maybe some solutions that could help.
Yeah. Representative Chimino.
Thank you, Madam Chair. So I agree with the letter because I think we want to try to stave off the closure. That was the purpose of all of this today and hearing this testimony. But I also know that there's some fabulous information here, even though it conflicts. I think some entities did think out of the box, and I would really like some opportunity to just be able to review all of this, maybe look at some of the things that were cited where it's working in other states, and then proceed with that. So maybe that gives us a little bit of time, and then in September, maybe we meet again and then decide based on more information. Maybe we will have heard back from Maine Health as well. We can reconvene and then decide the next steps.
Okay. So it seems to be the consensus is a letter and then get permission to at least meet one more time sometime in September. When are you going to be away, Bob?
I get back on the 24th.
Of September?
The following week, but I don't think we pulled, I can go back to my original poll. We did pull some dates at the end of September.
Yeah.
That maybe had a quorum at that last week after the 24th. I could maybe share that again and take a look at that, but would that be the time when we'd be looking at the last week in September? Can't think of the dates, but the 24th, I think, is a Thursday, 25th is a Friday, right? So it'd be 28th, I guess.
Yep. Representative Crucial.
I mean, if we were looking to try and have multiple meetings, potentially, we would maybe want to start earlier.
It's just going to be a struggle to get a quorum.
That's the issue.
A quorum.
When, I don't know if things have changed for people, but when we were polling
right.
for this meeting, we had a stretch in the middle of September where we couldn't get one. It was either really early or
I
really
see.
late, but that was just, that was a while ago, though.
And that's
well,
the challenge. with
yeah,
the
got
whole
it.
Committee is
Yeah.
getting a quorum.
For my part, I will move whatever I need to move to make it.
Okay. Anything else? Representative Foley?
I just have one other thing that I would like us. One of the things that I would like the committee to consider is, as we all know, Penobscot
Oh, yes.
FQHC is
Yes.
in dire difficulty, and
Yes.
another letter, but I would like the committee to send a letter to HHS and ask for them to provide some of the rural health transformation money to Penobscot to sustain them until real solutions can be found to their financial. They cover 50,000 people.
Yeah.
And we cannot, the state cannot afford to allow that to close.
Yeah, I mean, we're even looking at, partnerships with FQHCs for the issues
Correct.
we were doing today, so,
And, there is that money out there, and they have used it to support FQHCs. And so it's not unrealistic for us to ask them to consider moving some of that money to them to support them for, I'd say 5 million would be my recommendation, but
yeah, I think they need at least 3 million is the figure I saw. And I'm happy to write there. I would also suggest we write to the Attorney General to see if he's got
Mhm.
any monies.
Yeah.
Because, he has different settlement funds and whatever.
I agree.
we can send it to both. I think it's.
Even the opioid settlement fund, because
Yeah.
I know they do a lot with
We can
that.
send it to the
Yeah.
chief executive.
Yeah, find the money wherever you find the money.
Yeah, I think
That's
I think
my
it's
personal
important
opinion.
I think it's important for our committee to be a part of that
Yeah.
request. I know there was people from representatives and senators from the Bangor area is doing something.
Of
But
course.
I think this committee
Yep,
has an obligation to chime in on it.
Yep.
To those places where we have some influence.
so Colleen, yeah, I would suggest that I don't know if you want to do separate letters or one, it doesn't matter, but certainly HHS,
DHHS. you're talking about.
DHHS,
The state
yes.
DHHS,
Yeah,
okay,
yeah.
not the HHS committee. I wasn't.
No,
sure
no,
When you first
no.
said that, yeah.
Yeah,
Okay.
yeah, yeah.
Perfect, yeah.
The Attorney General's office for settlement funds, and the chief executive in case she has some resources as well.
Yeah.
Um,
And the ask would be for 5 million, up to 5 million,
sure,
something like that? Okay.
whatever it takes to keep them going.
You'll have to review this. I guess we'll have
Yes.
to, it'll be a little, we'll review it. We're not gonna change the substance, but.
Well, that's why I say you might find it easier to do 3 separate letters. And if
yeah.
you do, that's fine, or one. I mean, I think you understand.
You'll have to
what we're
review
doing.
electronically all of these 3 letters I'm writing, I think.
I just think they recognize the importance of what this organization does.
Yes.
This part of the state of Maine is just vitally important.
Agreed. Thank you for thinking of that, Representative Foley. Anything else while we're here? Representative Clucci.
Thank you, Madam Chair. I think I would be more comfortable sending a letter to Maine Health if we encourage them to try and utilize some of the creative ideas that we heard today to sort of encourage them to sort of rethink based on, rather than necessarily like, I don't know, for some reason I feel uncomfortable with the idea of
Colleen
of saying, don't do this, even though like they've planned out and they're like, we think that this is the thing we have to do.
Yeah.
You know, because I'm not sure that I know enough to say like, that's a bad idea. You know, it's
Yeah, I mean, I think Representative Foley used the word reconsider.
reconsider. Okay.
You used the word rethink. I think,
Yeah, okay.
I think we're along the
Just-
same lines. Yeah.
Like, I just want to recognize that like decisions have been made because like not like people have made thoughtful decisions without, you know, I just don't necessarily want to chime in if I'm off base, you know?
Yeah. You know, it's not going to be accusatory.
Yeah.
Colleen knows how to do that. And we'll review it as well.
Yes.
So, but
Okay. All
Yeah.
right.
anything,
Dan's, if everybody agrees with all those 3 letters, just so I. We can do it by perfect consensus.
hey, anything else? Thank you all very much. And we'll probably see you sometime in September. So, thank you.
Thank you.